morning, everybody, and a warm welcome to this scientific session when Kolkata is just experiencing the onset of a bit of a cold. So let us meet for a day for dengue. As you know that still the winter has not set in and still there's a lot of mosquito roaming around. Though fortunately the dengue cases have waned a bit, but still let us have a day and dedicate this day for the Aedes aegypti mosquito and dengue. And to start with, we will have a short session on ethical issues in medical and pediatric practice. By who else? Obvious choice is Dr. Arun Manglik. So may I request Dr. Manglik to please come and enlighten us about the ethical issues.
Yeah, can we have the slides? Yeah, thank you very much, Dr. Joydeep. Go back. So, thank you very much. So, we'll start the morning session with ethics, and before that, in this slightly cold morning, a very warm congratulations to our own Dr. Arup Rai, Arupda Edike Takao, on his 37th wedding anniversary. So unfortunate na, that his wedding anniversary and he's going to spend the day here, separated from his beloved wife. Fine. So we go over to the ethical issues. On the left you can see the 4 pillars of ethics: autonomy, non-maleficence, beneficence and justice. These are basically the 4 pillars on which medical ethics stands. But we will not restrict to this. We'll try to discuss how ethics has been affected over the years. Medical ethics at one point of time and what it is today. So there's no sponsorship to this talk. What are ethics and morals? Are the two different? Well, ethics refers to principles or recommendations as they are accepted by society in general. There is no legal binding on it. We must be clear, there are 3 aspects: the law, the ethics and the morals. The morals is my own conscience. What I feel is right. Now that may vary from person to person. So it's an individual independent choice. So that's the difference between ethics and morals. You remember this, when Lord Krishna gave a big lecture to Arjuna when he was reluctant to fight his own kin and relatives around on the other side of the fence. So what is the background? Well, in ancient days we had the highest standards and it was not influenced by monetary gains. And we had this Hippocratic oath which is more than 2.5 or 25 centuries old, and wherein it was service to humanity. We must do away with the sufferings of the sick, do no harm, and be noble and dignified. Now this is a recent addition by WHO on the Hippocratic oath when they say that doctors jolly well take care of your own health as well, apart from taking care of the health of the community or society. So this is an addition. So what's the present scenario now? That was the past, maybe 2, 3, 4 centuries or even more. We have advertisements, commercialization, money is crept in, okay? We have very high expectations from their patients, and these expectations we are partly responsible for that because we claim that we can get them the moon, despite knowing very well the fact that nothing is 100% curable maybe, okay? And at the same time, since we are not able to fulfill expectations, obviously there's lack of trust comes in. When I say I'll get you this and I'm not able to do that, I jolly well must say that I can try my level best, but I cannot guarantee. In fact, when people ask in Bengali, "Daktabu kono oshubidha hobe na to?" that means that there will be no problem. Well, we must be very sure and tell them that I'll try my best, but I cannot offer any guarantees. Sometimes I have to be so damn blunt and tell them there's only one guarantee in life, and all of us know that, and that's death. whether you like it or not. Some people may not like it. You're talking of death. Well, fine, that's reality. So our patient relationships have gone down. We have judicial interventions. We have a technical exploration. And what are the areas of importance where ethics are important? Medical education, research, the pharma industry, our own relationship with our own doctors, vaccination, that will come out as part of in the pediatric sector, and off-label use of drugs, and finally, euthanasia. So what has happened now? We have had a blooming of medical colleges. Remember, I think about this was around pre-COVID time when the government of India, Ministry of Health, had banned opening up of newer dental colleges. There was a moratorium for 5 years that there will be no further dental colleges because they were coming up, mushrooming, like every place, every sort of village is having a dental college. They were not having patients. So similarly, probably the time has come there should be a moratorium on medical colleges, but it's the other way around. The reality is they are opening up more and more and more and more. So when you go into the private sector, it becomes costly. And imagine, medical education means a period of not less than a decade, or maybe 15 years or 20 years, the person is studying. Imagine a person who does an MCH with those bonds now, he spends almost 20 years. So by the time the fellow is 40, he's probably thinking of settling down in practice now. And at that point of time, he's probably working as a resident because nobody is going to come to him. Think of and no reason, no joke now that in the top 500 or the top 100 NEET PG people, only 2 people are choosing surgical streams. Everybody is going into non-surgical aspects. So, mushrooming, and the mushrooming of the medical colleges has occurred because of one important factor, and that is many of these private medical colleges are owned by political heavyweights. I'm not cutting across party lines. They are owned by political heavyweights, and huge capitation fees are tasked. And once a student pays the capitation fee or pays the high fees, obviously the person comes and expects that I'll get the return. They have something called ROI, return on investment. So that is taken as an investment. So they expect the returns, obviously. And if he's taken a loan, obviously he has to pay back to the bank or whatever institution he has taken the loan from. So we need to get that. So what actually happens? We are producing factories who has a lot of quantity, but probably the quality has gone out of the window. And if the costs come up, and if my target is to earn and recover the money I've invested, obviously you can't be ethical. We had this person who has jailed and then come back and then whatever. This is beyond this. Now, research. Well, in yesteryears, research used to be guided by the researcher. Now it is taken over by the sponsorer. And most of the time, 9 times out of 10 or 95 times out of 100, it is sponsored by the pharma industry. And the pharma industry, who is the sponsor, owns the results of the research. But let us be very clear, you don't own your research. You are doing the research, you have no right to publish it, it's their right to publish it. So if the research goes adverse to their expectations, then it's thrown into the dustbin. Imagine, this is not very recent, drug trials 11 times more likely to give favorable results. So you can obviously feel that whom the hell will I believe? Are all these things believable? So this is what is happening to the pharma industry. Imagine the number of companies, imagine 70,000 formulations, whereas WHO says there are only 250 essential drugs. So why we have, and imagine the end, despite many of us, including our own organization, didn't support her, she fought her way and finally really succeeded in getting this ORS label on brands which do not purport to the WHO formulation. Now we come to vaccination. Now we have guidelines, we have some Ministry of Health guidelines, which is followed by the government sector. We have the private sector guidelines, which are followed by or purported by the IAP or organizations like per se. Do we need to follow those guidelines? There are vaccines available in the market which are licensed, but they are not recommended as a routine by either the IAP or the Government of India. So why are they licensed or why are they available if they are not effective or safe? Well, we must assume that they are effective and safe, and then only that is available. The question comes when we are working in the private sector. The person comes and asks me, should I take this vaccine? Like, for example, a meningococcal vaccine, which is not a routine vaccine. But the person says, I want to be sure that my child doesn't get it. So what do you do? So it's a question of having the class versus mass. The mass means the public sector, but the government is actually supporting them and they don't have to pay a single penny. Whereas the class comes when they come to the private sector, they pay in thousands. So sometimes you can feel that we are not ethical by overusing these vaccines. Some practical issues. A 15-month-old boy has not had measles, mumps, or MR vaccine and is now 4-year-old. The SIB is autistic because the elder child is autistic and they don't want to take it. How will we go about it? Any thoughts? We got to convince them that it is not related to autism, and on the 4 pillars we got to tell them there will be no harm, non-maleficence, that means no harm, you can be assured, despite the fact that there have been some studies, but that studies have been refuted several times. So we got to convince them that beneficence is prime, but still we have to leave that final decision to them. Like meningococcal we talked about, like we have a 40-year-old mother who has cervical cancer, advanced stage, and she has brought her 11-year-old daughter for a HPV vaccine because she's concerned for her daughter. But the daughter says, I won't take it. She's too scared of injections maybe, or maybe she's read somewhere that there was a study somewhere going on where in the government sector and the study had to be withdrawn because of certain side effects. A patient or two died in that. This happened in India. So then here again we have to convince them that the benefits far outweigh the risks, and that is what is something which is important. And suppose it was a case of a class 3 dog bite. Suppose it was rabies and the child says, I won't take the vaccine. Rabies vaccine, I won't take even the immunoglobulin. Well, you have to convince the child that yes, benefits far, far, far outweigh any risks, and you jolly well have to take it, otherwise you will be playing with fire. So euthanasia, now this has come up in a big way now, and the government and the judiciary has permitted it, and we had this Times of India only 3 days back when the Supreme Court is hearing. There are set systems. You have to have a medical board, and the medical board finally the institution decides, and the composition of the medical board is also recommended by the court. So, how do we behave with our patients? We must at any point of time remember, all of us have somewhere, in some place we have an ego. I am this big, I am this, I am invited to talks. Well, we must all realize when we are facing patients, the E of the ego must go to hell. So it should be only go and no ego. Because the ego comes in and our behavior at times fails. I'll just quote a single example. My own relative, she was due for a hysterectomy because of fibroid and she had completed a family. And the OT was booked. This was very recent, about 2 weeks back. And I posted this on Facebook also. And what actually happened that she just asked, and she is a dental surgeon, the patient herself. She asked the gynecologist that can this be done under spinal anesthesia, because she read somewhere in the Google. Now, and obviously the person could have explained to her that it should be done under GR because that is safer when you're doing it for lab. But instead of that, he just said, okay, you want under spinal anesthesia? Fine, please go to somebody else. And he cancelled the OT also, which was already booked. So this is what actually happened. The ego of that gentleman was far much, he didn't have time to explain things, which is actually not. We must, as of now, it's no point seeing 100 patients in the morning and 100 patients in the evening and having no time for any patient. That's ridiculous. Okay, yes, it's true that sometimes we have to do that, but we should not. Well, these are other areas where we are doing a lot of unethical practices, like reusing costly disposable, and this happens in lots in cardiology and orthopedics. It doesn't happen much in pediatrics. And all these we are also charged upon or accused of doing this, keeping the brain dead patient on ventilators. And imagine this, the government sector, the patient wants an urgent MRI and he won't get a date for 3 months because the VIPs are poking in and coming out. Okay? So finally, the society needs to be more responsible. They go to corporates because they want five-star facilities. Remember, we are going to a hospital, not to a hotel. Now, yes, comfort must be there. Everything must be taken care of. That does not mean that I should have blue, red lights on the top and alarms running and good morning, good afternoon every time. Well, that may be something beyond the limits. Again, I repeat, we are going to a hospital. So let our patients must realize that just having a five-star comfort. Remember, the corporates will only employ a doctor who listens to their whims. They don't want quality. I can say this with real emphasis standing on this podium. They are not bothered of quality, they are bothered of the person who will give them patients, who will give them revenue, and listens to their dictates. So, the community must also realize this. So, the effects are these. We are losing out, and finally, what do we do? Profession and commerce need to be separated, but can we really do that? We can't, because if you are ethical, probably you won't make money. If you want to make money, probably you have to throw the ethics out of the window. But somewhere you have to have a compromise. You have to be both ethical at the same time, earning enough. And as a whole, in general, the community, the upcoming people must realize the medical profession, barring the top 1%, or maybe 1.5%, people can live comfortably in their lives, but they cannot be filthy rich. No doctor can be filthy rich unless there are very few who own big nursing homes or something like that. So, with these, finally, is ethics only for us? The court says if the lawyer makes a mistake, he is not culpable. So, this one, the Nuremberg trials, doctors made prisoners stand naked in the open in freezing temperatures for 10 hours to see the effect of rewarming. And these trials went up. And this gentleman has published so many books on medical issues where ethics has been not taken care of at all. So finally, what actually counts is my own conscience. My morals, whether what I do is right or not. Well, in the hoard of earning more and more rupees and increasing our bank balance, sometimes we tend to forget the ethics, the conscience. So finally, should we have a council for medical ethics, just like a Prince Council of India? Remember, 20 out of 28 PCI members are from the press itself. So that's a joke. Thank you very much for your time. 30 seconds extra.
No, it's fine. Thank you, Dr. Manglik. It's quite informative and enlightening. Now, may I request Dr. Kundu to just start the dengue session with the context setting. So over to Dr. Kundu for the introduction, please.
So, good morning, everybody. It is very heartening to see the more than half-filled auditorium in such an early hours of the morning. So, we did dengue, though this time the dengue is much less. And as you know, all zoonotic disease, they have a time frame. They don't strike every year. But dengue is always an enigma. Dengue is only one of the diseases which involves the capillaries of the lungs and peritoneum, pleura and peritoneum, and it does not involve the other capillaries. When it ends, it does not leave behind any mark. Mortality rate is as low as 1%, but still it causes lots of concern, morbidity, and above all, it is very frightening for the patients. So that's the reason you need to know the dengue. And the pathophysiology of the dengue is very complex. It does not follow like other disease. So we have called 4 experts from the 4 corners of the India. From the west, Mumbai, Dr. Suhas Prabhu has come. From the central, from Hyderabad, Dr. Surendranath has come. And from Delhi, we have 2. One is Tapisha, another is Dr. Puneet Karla. Though Puneet Karla is a company people, but he will be talking on science only. And he is also a pediatrician. He is a member of IIP. And our main focus, there are certain issues in dengue. First of all, dengue in an infant is a very dangerous situation. So we have taken that up. Gone are those days when dengue was a simple disease starting with fever, headache, breakbone fever, classical. But now dengue has expanded. So we have an expanded dengue syndrome. We'll try to cover that, and very much that a vaccine is on the horizon, and we'll be talking about the vaccines and certain special issues about dengue. I hope you will, when you, at the end of the session, you take back something to learn. And also, we are planning to do days with not only dengue, we are planning to do a day with pneumococcus, we are planning to do a day with staphylococcus, with mycoplasma and scrub. These are the plan of this year. So I hope you will appreciate that and attend to those things. Thank you very much.
Not to mention the summer CME. That's our flagship program that we will definitely have. We will we will declare soon. So without much frill, as you know that we do not believe with a prolonged flowery inauguration and flowery introduction because most of the faculty are quite known. May I request still Dr. Arun Manglik and Dr. Sharmani Mishra to please come up and chair the session, and then you please welcome Dr. Surendranath, our curtain raiser speaker.
So I welcome Dr. Sridharath sir to speak on the important aspect on dengue and why it is increasing. He will talk on this topic, and sir, please start your talk.
Thank you, madam. And from the bottom of my heart, I thank the trio of the Kolkata, Dr. Kundu, Dr. Keya, Dr. Jaydeep and others, for a wonderful CME which we are going to have today. And being a part of this wonderful CME, I thank them. So coming to the dengue. Dengue as a disease, we are able to discuss for one day means you can imagine what is the difference compared to the previous years as far as the incidence of the dengue is concerned. When I was postgraduate, the Nelson textbook mentioned only 10 lines about the dengue. And we never used to see any dengue cases at that time. We used to see tuberculous meningitis or viral meningitis or encephalitis. But dengue is very rarely seen in, when we were postgraduate, that is around 80s and 90s. So we started seeing the dengue when we started the practice. Around 2000, I think, the dengue cases started increasing. So we should know why the dengue has increased so much compared to the other diseases which have come down. In fact, compared to the malaria, to some extent malaria could come down, but the dengue is still increasing exponentially, not only in the areas of endemic areas, now it is spreading to the other areas, temperate climate areas also. There are reasons for this. We have to see what are the reasons why the dengue is increasing. I feel that most of the time dengue is a man-made disease. So most of the times it can be prevented by simple measures where you reduce the breeding places of the mosquitoes. So let us see why the mosquito population has increased, and this is one of the reasons for increasing dengue all over the world. If you see the trends of the dengue incidence, now the WHO says that dengue is the most rapidly spreading mosquito-borne viral disease. So this is the statement from the WHO. And the incidence of the dengue has dramatically, from 500,000 in 2000, it has increased up to the 14.6 millions in 2024. Imagine how fast it has grown. And there is a twofold increase compared to the 2023 in 2024, almost doubled the incidence from 2023 to 2024. And more than 12,000 dengue deaths reported worldwide in 2024. And this year, from January to July, over 4 million cases are reported and already 3,000 deaths have been reported in almost 97 countries all over the world. And now the disease is considered to be endemic in more than 100 countries. And WHO estimates that 5.6 billion people are at risk of dengue and other arbovirus are all vector-borne diseases, and almost half of the population is going to be affected. So this is the change which has occurred. Though the disease is more seen in tropics and subtropics previously, dengue is now spreading to the new areas, including the European countries and Eastern Mediterranean region, which are temperate climate regions. So this was 2011, where the incidence of dengue was found to be in the tropics and subtropics. You can see both the red lines, where the most of the dengue has been found in 2011. If you see now, it is also spreading to the Europe, and US also has the same problem of outbreak of the dengue now. So this is one of the statistics which has been shown by the National Vector-Borne Disease Control Program. This pre-COVID estimates. What they have shown is almost from 2009 to 2017. 2009 was 20,000 cases were there. Now in 2017 it was found that 150,000. That is the smallest figure, but now if you see, it is much more than that. So this is the latest figures of the National Vector-Borne Diseases statistics. These are the reported cases. I think there are almost about 10 times number of the cases which are not reported. The reported cases in 2024 in India is about 2,33,000. But I think you can add another 0 to, it may be 10 times more than what it is reported. Even up to August 31st in 2025, 50,000 cases are reported and only 42 deaths have been reported. This figure is, I think, much less than what we see in our clinics. So the projection is India will have about 2,78,000 cases by the end of this year, with almost 300 deaths to be reported during this year. So as far as the death rate is concerned, there is one country which has shown 0 death rate is Sri Lanka. This is only by proper management of the dengue cases, which we are going to learn in the due course of this. So India accounts almost about third of the world's 100 to 400 million infections which are occurring all over the world. As usual, we always lead number of cases as far as infections are concerned. And one published paper, this is a mathematical calculation that Pune is going to be the highest number of dengue cases and highest number of deaths if we don't change our environment and climate. What they have shown is dengue-related mortality in the city is set to rise by 13% by 2040, and 23 to 40% in 2060, and 32 to 112% by 2010. This was a mathematical model which they have shown, depending on the climate, rainfall, and the city's temperature statistics. They have shown that it is going to be a big problem as far as dengue incidence is concerned unless we tackle it properly. So this is the culprit, the villain of the dengue. We have 2 mosquitoes, Aedes mosquitoes, Aedes aegypti and albopictus. Both are tropical and subtropical mosquitoes. Most of them are in urban places. We see more cases of urban, whereas other encephalitis like Japanese encephalitis, which is a rural disease, but whereas the dengue is most of the urban places. And most of the times it is immature strains found in the water-filled habitats. So if you see the life cycle, almost eggs and the larvae and pupae are developed in the water. So wherever water storage is there, water stagnation is there, they are going to develop. But most of the times it takes about a week to 10 days for the developing of the larvae to the adults. So if you change the water once in a week, definitely we can reduce the dengue. So make it a point that every Sunday, remove the water from whatever containers are there in and around the houses. So this way we can reduce the dengue in fact. But only problem is eggs can stay up to 1 year even after desiccation. So eggs life is almost 1 year they can stay. Whenever the rains comes, eggs hatch and the larvae will come. And wherever stagnation of water is there for more than 1 week, definitely the dengue population, mosquito population is going to be increased. We'll just see the nature of the vector which is transmitting the disease before knowing why it has increased. So most of the times Aedes aegypti mosquito breeds in the stagnant water within and around the houses. And they breed only in the clean water, whereas the other mosquitoes, they do breed in the unclean water, but dengue breeds in the clean water. And it is a container breeder. What are the containers? The containers which are around the house are more important, like cement tanks, waterhead tanks, underground tanks, tires, dessert coolers, pitchers, discarded containers, and junk materials, potholes, rooftop, window parapets, ornamental fountains, lucky bamboo pots which we keep at the house, and the money plant plants. These are the most of the places where water stays. The small quantity of water is enough for the dengue to breed. So all these things are in and around the house, and the mosquitoes grow, population will grow in and around the house. And if we change it for once in a week, definitely the dengue will reduce. The lifespan of the adult mosquitoes is around 3 weeks, and most of the times it is the indoor mosquito, mainly stays in the indoors. That is in the furnitures, bed, shelves, almirah, dark clothing and hanging inside. So most of the times the mosquito is inside only, it is not coming from the outside. It breeds in the house, it stays in the house, it bites the person. Once the dengue person is bitten by a mosquito, the virus stays in the mosquito for the lifetime. So and most of the times it's the morning and afternoon biting. So it is not the night one, it is where you try to work and exposure is more important. So if you have the clothing which is not covering all your body, definitely you are likely to be bitten by the mosquito. So another advantage is the mosquito will only fly for 100 meters. It won't fly more than 100 meters. So if you can control the mosquito within that 100 meters, definitely you can reduce the population. And recently, albopictus spread to every continent except Antarctica. It has also found that at least it is seen in the 20 European countries. That's why we are seeing more number of cases even in the Europe. And Egypt also had the dengue cases. That is because of the traveling of the mosquito from the US to the Egyptian country, Egypt and European countries. So these are the common containers where the mosquito breeds. We all are aware of it, and all of us are aware of it, but still we are not able to contain this problem. So once in a week, just discard the water which is there in the containers in and around the house, you can reduce the mosquito population. And these statistics which I have already told you that all over almost 390 million infections, 5,000 hospitalizations and about 40,000 deaths occur every year. Another problem is 25% cases are symptomatic, only 5% are severe dengue and 30% persistent dengue symptoms are there. That means almost 50 to 60% of infections are asymptomatic. They have only the viremia, they may not have the symptoms, but they can transmit the disease. That means 50% of the times we do not know whether the person is having dengue or not because it doesn't have any symptoms. So rest of them may have symptoms which are mild and most of the times it is missed. We will only find out when the patient is presenting with severe dengue. Okay, so what are the reasons? Now we come to the reasons. These are the reasons why it is increasing. I'll explain you each one in detail in the coming slides. One is the climatic change and leading to the warmer to the wetter conditions in favor of mosquito breeding, increased urbanization which creates more breeding grounds, and the more travel to the dengue prone areas, limitation in the public health system, insecticide resistance, inadequate sanitation and waste management. These are the major causes of the increased dengue. Let us come to the climate change and weather. So warmer temperature. The higher global temperature create more favorable conditions for the mosquitoes, extending their breeding season and the geographic areas. We know that prolonged monsoon, there will be stagnation of the water. Fortunately, when you have the floods in the area, you have less dengue. This year also same thing happened. Dengue season started. It is there for about 15 days or 20 days. The Telangana had floods, Andhra has floods, dengue has disappeared. So the flooding to some extent will reduce, whereas a consistent rainfall, a low-grade rainfall will increase the dengue mosquito breeding centers. And increased unpredictable rainfall creates more stagnant water and providing the ideal breeding centers for them. We are seeing that prolonged rains are there this year. They did not stop in September or December. There are prolonged rains with a low-grade intensity of the rains can increase the dengue. And extended seasons, climatic change projected to lengthen the dengue fever in many areas. So why this happens? What is the problem? Mosquitoes are being poikilothermic, undergo fluctuation in their internal temperature depending on the surrounding environment. Why this is important is the dengue cycle, in fact, what happens is whenever the virus enters, it has to multiply. The best ideal temperature is 27 to 35 degrees in the mosquito. So mosquitoes also face various risks including desiccation, changes in the metabolism, reduced mobility due to the thermal variation. But the extreme drying is, whereas the eggs can sustain the extreme drying also. Only when there is rain, then they will start hatching. So let us see what happens. Mean temperature between 27 to 35 degrees is found to be optimal for increased dengue transmission, considering several vector parameters like longevity, mosquitoes live longer, and number of eggs deposited by the female vector also depends on the temperature. It should be between 27 to 35. And number of times a female lays eggs also depends on the temperature. And the time between the blood meal and the oviposition, that means after the blood meal, development of the virus also depends on the temperature which is existing in the climate. This extrinsic incubation period is time taken for the virus to develop inside the mosquito also depends on the temperature. The ideal temperature for dengue to replicate the virus or increase the mosquito population is 27 to 35 degrees. That temperature is very ideal for mosquito, and during that temperature mosquito population will increase. Not only that, viral replication in the mosquito also increases. So intrinsic incubation period is time between human infection to the symptom of onset. So the temperature between 25 to 35 degrees is very ideal for the mosquito breeding, at the same time viral replication. So now come to the urbanization. So this is how our cities look now. Uncontrolled urbanization. I think definitely we know that before 2000 this kind of urbanization is not there. There is a lot of migration of the people from the rural areas to the cities where construction activity is going on. So a lot of development is happening in the urban areas without any climatic control. At the same time, we don't have any protocols how to develop, how systematically it should be developed. So uncontrolled population explosion and the urbanization is one of the reasons. So increased urbanization leads to the overcrowding, poor infrastructure. They don't have infrastructure for the sewage transmission or water supply. Nothing is planned properly. And they create more breeding spots in the urban areas. It is very easy to, for the people to just throw the whatever containers which they have used on the roads and in and around. Poor sanitation because of the uncontrolled urbanization. Water storage, because the water shortage leads to the storage of the water in the containers. And overhead tankers are very common nowadays. So these containers and irregular water supply can lead to the water storage and increase the breeding of the mosquitoes. There is one very beautiful study I will quote here. In the Australia, in one of the areas where they had a decreased water supply, so they started storing the water in the containers. Immediately at those places, dengue incidence has gone up. In fact, it has been published in the paper also that because of the storage of the water, because of the shortage of the water, they were continuously storing the water, which led to the Aedes aegypti increase. So, socioeconomic factors. Okay. This is also, there is a one very beautiful paper is there. In US, Texas is the southernmost state, whereas bordering the Mexico. So in the Mexico, the incidence of the dengue is very high, almost about 7 times more than the Texas state. Because both have the similar climatic environment, but the incidence of the dengue was found to be less in Texas compared to the Mexico. This is because that if you are in a high socioeconomic country, you will have the measures to prevent the mosquito bite. You will have mosquito window curtains, mosquito nets, mosquito repellents you will be using. Whereas socioeconomically lower class may not have that facility to prevent the mosquito bite. This was one of the reasons what they have shown that incidence of the dengue is more in those conditions where socioeconomic factors are playing. A low socioeconomic factors definitely increase the dengue incidence compared to when you are in a higher socioeconomic. So now another problem is increased travel. Almost about 4.5 billion passengers are traveling globally each year. And everybody is traveling, taking vacation to different exotic areas, they are going there. So these population migration also can spread the dengue to the areas where the dengue is not there. So what happened? Why it spreads? Yeah. So another 2-3 minutes is okay? Yes, sir. Okay. So more than 60% of infections are asymptomatic, we know, and few may have mild symptoms, and they can transmit the virus to the mosquito. Because a asymptomatic person has a viremia, he can transmit the mosquito. Human to mosquito transmission can occur in 2 days prior to the symptoms. You may not have dengue symptoms and you are traveling to another area with a dengue virus in your body, you are likely to transmit the disease there. And most of the patients have viremia for 4 to 5 days, but viremia can last as long as 12 days in spite of having the decreased symptoms. So asymptomatic dengue patients who are carrying the virus, if they are traveling elsewhere or internationally, they are likely to transmit the disease more. And maybe this is the reason that the dengue is spreading like anything to everywhere, and most of the subtropical countries also facing the same problem. This is because of the increased travel internationally and nationally. So public health surveillance, limited surveillance is there. We do not know what is the exact statistics, and insecticide resistance is one of them, because controlling the mosquito, we have to spray some mosquito sprays. They will reduce the mosquito population. We are not following most of them now. Lack of awareness, public awareness to remove the water once in a week, we have to educate them. And vaccine access. Today, entire session is done just because we are going to have one more vaccine which is found to be very effective without any adverse events following the vaccination. Whereas the previous vaccine which was introduced had some problem where the seronegative individuals are. So we don't have any effective vaccines which can be given to the all aged without any complications. So the present vaccine is also going to be permitted to be used for more than 6 years only. But we have seen the dengue even in the infants. So the vaccine should be there to protect all ages without any severe adverse event. That is not there now. So this is the end of the slides. The key messages are climate, rapid urbanization, increased international travel has increased the dengue incidence enormously, spread of the disease to the new areas. Prioritizing dengue virus on global and research agenda would ensure coordinated efforts to address growing burden of the dengue. The vector control measures are essential in managing the mosquito-borne diseases, but it has shown only limited success, and it is a concern for all of you. The emphasis on personal protection and proper case management is very important. It is likely to reduce the mortality. Development of an effective vaccine for all ages with newer modality of the treatment may help to reduce the dengue menace. Thank you for the opportunity. Thank you very much.
Thank you, Dr. Surendranath, for a vivid description of why the transmission is increasing. So may I request Dr. Jaideep Chaudhary to hand over a... Okay, I thought the chairpersons, okay. So may I request the chairperson, Dr. Arun Manglik, to hand over a small token of appreciation to Dr. Surendranath. And may I request Dr. Surendranath to hand over similar things, right, to Dr. Sharbani Mishra and Dr. Arun Mangli. Yeah. वो तो नहीं, we don't believe in cash. We believe in kind. So the next session we have will be on lab diagnosis on dengue, which is the most important session of this today's year, and it will be taken none other than by Dr. Jaideep Chaudhary. And we have So we have a very esteemed panelist for this. May I request Dr. Tapisha Gupta, who's a very, very dear friend of mine from Delhi Max Hospital. And we have, of course, our own Dr. Amita and Dr. Shumon, who are also very close to us. And Shumon is, of course, in our institute itself. So over to you.
So good morning, everybody. So gradually we started with ethics and we are moving towards the core topics of dengue. Yes, there are some dilemma about the lab investigation and lab diagnosis of dengue. That's why I have with me 3 eminent panelists to enlighten us. Please start my slide. To enlighten us about the lab diagnosis of dengue. What we will do today, that we will start with some very basic common scenario that we often encounter. Like this 4-year-old boy, it was in the month of August, the child came from a Kolkata suburb with a history of high fever with chills for 3 days. On examination, there was hepatomegaly of about 2 centimeters, spleen was not palpable, and there was no other focus of infection. And the parents were anxious because there were many children in the same school who were also ill. So I will start with Dr. Tapisha first. This is a very common, she has a very busy OPD, I know. So if we encounter this type of kid, so what would be the ideal investigation of choice? I have given few choices. So what about, according to you, your opinion in this scenario, please.
Thank you, Dr. Jaideep. So if we read the slide, we know this is the monsoon season and from Kolkata. So fever with chills without focus, so we are going to think of malaria as well as dengue, definitely. Then we come to this history of parents being anxious as many children in the school are ill, so there could be a possibility of influenza or some other viral illness also, that would also be there. In a 4-year-old child, we don't really suspect UTI unless the child, usually by this age, children will complain of dysuria, etc., or increased frequency, usually. So if we look at the choices,
you can go as per your decision. The choices are very arbitrary.
Yes. So if I look at how I will approach a PG exam, I will take out A and B because there is no NS1 in that. So we are left with C and D. So it would be a good idea to do the C set of tests initially, and if they give us the diagnosis, well and good. If not, we can maybe proceed and do blood cultures and urine cultures, etc. So I would go for C.
Fantastic. So the message is that because there is a clustering, so we can more or less rule out UTI and that too in a 4-year-old child. Blood culture probably is not mandatory with a 3-day fever when the child is very stable. Definitely we have to think of both malaria and dengue, and as per that we can proceed with a routine blood, malaria and NS1 antigen. We have the head of the Department of Microbiology and Professor of Institute of Child Health, Dr. Shumon Poddar. So I will dedicate few core microbiology questions to Shumon. So Dr. Shumon, this child NS1 was positive. Now NS1, we all do NS1 and we do it frequently. So what is the basis of this NS1 and how sensitive and specific it is? And if the option is there, you go for ICT or ELISA, and the chances of cross reaction. So lots of spin balls, googlies and all I have delivered to you. It's your turn to tackle.
Okay, sir. Now regarding this basis of NS1, now NS1 actually the full form is non-structural protein. It is not non-specific protein, which is sometimes still, but it is actually non-structural protein 1. And it is a glycoprotein, as we have already mentioned on it, and it comes in the circulation on the day 1 of fever. So, sir, please give the questions. Yeah. So this is the basis of doing this NS1 in the early period, and in the first 3 to 4 days, that is the best time. From 5 days onwards, the NS1 gradually comes down as the antibody gradually grows up. Now regarding sensitivity and specificity, this is highly specific test, and it is in the tune of 99 to 100% is specific. And regarding sensitivity, it depends upon at what time you are doing, what is the pre-test probability, and all these things come into play. But overall, if it is a primary one, it is somewhere around 90 to 93%. And if it is a secondary dengue, then it is somewhere around 70 to 74%. And regarding what are the chance of cross reaction, now this NS1, and we are thinking of dengue. Dengue is a flavivirus. So it can cross-react sometimes with other flaviviral infection. Now we have seen Zika, we have Japanese encephalitis and yellow fever. So this can cross-react. In India, we know that we don't have yellow fever, but we go for Kenya as I have gone. So that's it. So South Africa. So these are the things when you have given this recent yellow fever vaccine that can cause false positive. And regarding ICT versus ELISA, ICT is the immunochromatographic test or the CART test, and ELISA is definitely better than ICT. There are two things. One is the science, another is the government regulation. Now, if I go by science, then also ELISA overrules ICT. ELISA has got better sensitivity and specificity than ICT. But ICT is a point of care test. It can be done without expertise and it can be done at bedside in 10 minutes time. So ICT holds true in certain states as an emergency screening procedure. But in our case, in West Bengal, ICT is not allowed. It is the only ELISA that is dictated by our very own government. So in that situation, ELISA holds better than NS1, but definitely you need an expertise.
So thank you, Dr. Shumon. I think you have got a very...
I have a question for Shumon.
Yes, sir.
Child has taken a Japanese encephalitis vaccine only 2 weeks
That-
back. So what will happen if you do an NS1 test for dengue? You are thinking that you might suffer from dengue after 2 weeks of 2 or 3 weeks of taking a Japanese encephalitis vaccine, because that vaccine contains NS1 antigen.
Yes, sir. In certain instances, it can give false positive if it is within 2 weeks, but after 2 weeks, usually not.
So I think we have to be careful, but what we have got from this discussion that NS1 is a fantastic test and definitely it's a first line. Next I will move on to Dr. Amita. Now what happens, I believe for every one of us, that parents, once they come to know that it's a dengue NS1 positive, they repeatedly ask us, what about platelet, when should we repeat the platelet? So this child was obviously not admitted, very stable child. So when do you repeat hemoglobin, PCV and platelet, or you repeat only platelet, your opinion?
So, first of all, platelet is a overhyped parameter in dengue because the parents think if the platelet is normal, then the child is stable. So, first we have to let the parents be aware that this is day 3 of illness. So, the fever usually persists for till day 5 or 6 in dengue, and we have to let them know that after the fever decreases, there is the chance of complications, because the parents often assume that when the child becomes afebrile, the child is again stable and they don't need to do anything. Until that time, they themselves want to get the platelets done every day. So if the child is stable, then obviously, if I would do, then hemoglobin, PCV and platelet together in toto would give us a complete picture. And also the clinical symptoms, we have to explain to the parents the danger signs in dengue and when they have to report to the hospital immediately, because by 4.5 days the danger signs may set in. And to repeat the platelet, if asked, then maybe alternate days. Along with the clinical symptoms, they should also show in the OPD on a regular basis and keep in mind the danger signs.
So the message is that though the parents might be too much bothered about platelets rise and fall, but we must be very cautious. No need to repeat platelet daily, or if the child is stable, and we have to explain, got it from. Now what has happened, Dr. Tapisha, that it's the day 6 of illness. This is the same child, NS1 antigen positive. There was slight decrease in fever, then fever with chills again, and the child is vomiting, unable to retain, so the child was admitted. Now once this child admitted, it was initial fever, then the fever came down a bit, again fever, NS1 was positive. So do we really need to do any other test like dengue IgM, IgG, repeat NS1, both IgM, IgG, or do NS1, IgM, IgG, or whether we are happy to do no more tests? Dr.
Yeah.
Tapisha.
So I think as sir very nicely told us, NS1 has a very good specificity and sensitivity. So we really do not need to retest because the clinical picture is also matching biphasic fever, some danger signs which have come. The only point of caution that I would suggest is find out how the NS1 was done. If it was a card test, maybe you could think of repeating it, but otherwise there's no need. So it would be F, no more dengue test. That's what I
So
would
no more dengue test. Actually, that's what we have already learned, that if it's an NS1 positive, then there is no point in doing IgG, IgM again, because there is a phase. First there is viremia, then NS1 positive, then only IgM, IgG develops, and with the sensitivity and specificity of NS1, we can rely on it, and we have to just monitor the child and do not do unnecessarily again IgM, IgG. So this is the overall interpretation. I think this is a cliched slide you have come across many, many times. Even if it's NS1 positive and IgG, IgM negative, then it's an early dengue. If it's NS1 either positive or negative, IgM positive, it's a primary dengue most of the time. And there are so many permutation and combinations, so we have to be oriented with this and not do tests unnecessarily, because what the main motto of this session is to the rational investigations for dengue. And again, this is the profile of the primary and secondary dengues that we can have, that viremia decreases, NS1 decreases, then only IgM becomes positive in primary, and in the secondary IgG also rises early. So I'll again go to Dr. Shuman. Now we have so many serological tests. See, serology is the test of this century, or rather it has come up in a great way for all the diseases. Now, could you please highlight about the limitations of the dengue serology that we commonly do?
Sir, mostly we now do the IgM and IgG by ELISA, but there were few tests beforehand, like this complement fixation test, hemagglutination inhibition test, but these tests have got a lot of false positive, false negative results. Now these are actually phased out. Now when we say as it is a dengue serology, for all practical means we think that it's a dengue IgM and IgG. Now IgM is actually MAC ELISA, that is IgM antibody capture ELISA, M antibody capture, MAC. So MAC, that is, it is something that IgM is captured in, it's in a, like in the mean of sandwich, something like that. So the sensitivity, specificity should increase very high, provided the kit is of a good quality. Now, again, the limitations are, if you do the serology early, before 4 days, then it's a difficult ball game. Then it has to be repeated. And then again, if the sample is hemolyzed, if the sample is not kept properly, kept outside maybe in the room temperature for a long time, so these are from the operational point of view. Or maybe you are sending the sample long distance. On the other hand, IgG that may turn out to be early positive even before 4 days in secondary dengue. In that situation, sometimes you might find that IgM is equivocal or IgM is negative, but NS1 was reactive, and then after that initial few days, and then IgG has become positive. So these are the limitations. Again, all depends upon the pre-test probability of the dengue and the dengue you are getting in your vicinity.
Thank you. So again, I go to Dr. Amita. So it was the day 6 of illness, the child was admitted and some tests were repeated, and along with that SGOT, SGPT was done, and SGOT was 110 and SGPT was 80. Now these are the very common investigations that we do, because dengue after all is a hepatotrophic virus. So what is the significance of these elevated SGOT, SGPT, and when should we do, if at all we are doing, and whether it suggests that any other co-investigation that we must investigate?
Co-infections, you mean?
Sorry, I'm sorry,
So,
co-infections.
Yeah, so SGOT, SGPT by day 4, 5, I think one must do to get an idea of the affection of the liver, and the child may have minimal ascites and some sludge in the gallbladder as is seen in any viral infection, and if they are raised and the child is symptomatic, then it should be a caution sign for us. And so it should be done around day 5 to 6 of illness, and especially if the child is symptomatic. And any other co-infections like in our country, so scrub, maybe enteric fever, and also if malaria has not been ruled out, then because all of them are hepatotrophic infections, virus and protozoa.
So being a hepatotrophic virus, borderline elevation of the liver enzymes are acceptable.
Yeah.
Depends on the clinical condition also, we have to judge it in a larger perspective. So what often happens that nowadays that we have the facility of bedside ultrasonography or POCUS. So often it's given a lot of stress. Probably it's definitely of great use. May I ask Dr. Tapisha that USG or POCUS in dengue, if we want to discuss, when it should be done and what is the significance in monitoring, whether we should do in all the child once the child is admitted, or whether we should keep it only for monitoring, Dr. Tapisha?
Okay. So the answer is not that simple. Ultrasound of the chest can pick up even 20 ml of fluid. So it's an excellent modality to detect early plasma leak. So there are many studies to say that. There are studies done in India, in Singapore. They're using ultrasound to detect early plasma leak and stratify risk of patients, whether the child will get into trouble or not. So that is one way of doing it. Currently, it's not in any of the protocols, national or international, because the reason is you need more data to find out that doing an ultrasound will ultimately change your management or ultimately affect mortality, morbidity. That is why it is not in the guidelines, but it's a very good tool to detect early plasma leak. That's one thing. In OPD practice or in hospital, in an, say, outpatient. Point of care ultrasound on the bedside in ICU is excellent. It is used to determine how much fluids can we give to the child who is already on a ventilator or who is in critical dengue with persistent hypotensive shock. Basically, you look at two parameters. You look at the IVC and you look at the ejection fraction. You see if the IVC is collapsed, that means you need to give more fluids. If the ejection fraction is low, IVC is fine, that means you need to add inotropes. So in order to decide fluid therapy or whether inotropes will be useful, you need to do point of care ultrasound, and that is already established and it is done. It's a very good modality.
Yes, though it's not a routine, but for monitoring, definitely yes.
You can see the V lines also, yes, for pulmonary edema. You can detect fluid overload.
Yes, that's for monitoring. Dr. Amita, I would like to ask you that is it possible to someone to be infected with multiple serotypes? Because we know there are 4 serotypes. And how important is the dengue serotype? What's the relevance? And any need to do serotyping routinely for treatment and prognostication?
So yes, there are multiple serotypes like dengue 1 to 4, and paradoxically, if the child is infected by a other serotype in the second time, there is this antibody dependent enhancement which all of us know, wherein the neutralizing antibodies against the first serotype, they are not efficient enough, and in fact they form a antibody virus complex which then goes during the second infection and goes and binds to the FC receptors of the macrophages and the monocytes, mononuclear cells, and then the entry of the second time, the second serotype becomes very easier. So the viral replication increases during the second infection, and it leads to more severe form of dengue, more capillary leak, and maybe hemorrhagic fever also. So the second infection, paradoxically, instead of providing any immunity, leads to a more severe infection. So therein is the significance of multiple serotypes, and therein the secondary dengue becomes much more complicated. And relevance in routine practice, I think none of us we do that. It is only for epidemiological purposes and to know which kind of serotype is circulating this time in the population, to know the severity. Like dengue 2 is usually known to cause more severe infections, whereas dengue 4 causes less severe infections.
Yeah, so yeah, Dr. Shuman wants to
So
add.
to add to it, if someone has undergone DANE 4 initially, followed by DANE 2, then it becomes massive disaster, usually.
Of course, but yeah.
And sir, another DANE 1,
Yeah, but the point is that this is not a routine investigation that we can do. It's not possible to do the serotyping, say for the pneumococcus. Are we doing the serotyping routinely? No. If we get by culture, that's fine. And serotyping is done only in few labs. So here also we must be aware of there are serotypes, but it's not routinely possible. I go to Dr. Suman. I think you have addressed this question more or less in the last discussion about the comparative features of different dengue serological tests. Do you want to add anything to that?
Sir, I have already said that this
Yes.
complement fixation test and hemagglutination inhibition test, these are now phased out
Yeah.
for dot of phosphorus. And the ELISA test, I have already said.
You have already
rapid
tested.
It's already, I said.
Yeah, anything to add to the card test?
Sir, regarding card test, it can be used at bedside screening, but not in Bengal.
Yeah.
Preferably, and that one reason for that is there might be little bit of, lower of sensitivity. In the ELISA, there is a control there. So for every test, you are having some control. So you have more of faith on that ELISA, so the specificity and sensitivity increases, which is not there in case of rapid test. And
These are some
yes,
of the...
this plaque reduction, neutralization test, these are all not done routinely, so not required. I don't think these are
required,
Can I
just
add
for
something?
theoretical purpose. I would like to go to Dr. Tapisha also, that
Yeah,
regarding the
I
point
just
of...
wanted to say
Yeah.
that our national guidelines recommend very clearly say do not use card tests. So they are not being used in Delhi also because there's a high rate of false positivity also. And in fact, in Delhi, we've had many such cases who were IgM negative by card test. They were actually dengue and they came in shock. So we really do not recommend card tests.
So what I can summarize from the discussion so far is that in the season, if we have suspicion for dengue in the early phase, we can definitely do NS1, and if NS1 is positive, we can take it as a dengue. If the child comes late, beyond 5 days, there is no point in doing NS1, we can go for IgM, IgG. If it comes positive, then it's fine. Once confirmed by NS1, no need to repeat, and always ELISA is the best. So to summarize the discussion till now, anything to add, the 3 panelists, from this? So we will move on to a typical situation. This is a 2-year, 1-month-old girl who had high fever and vomiting for 4 days, then altered sensorium. And there was recurrent convulsion. The child was irritable, GCS was low, there was no cranial nerve involvement, there was hypertonia, exaggerated reflexes and plantar extensor. So the child presented like an acute encephalitic syndrome. And of course, as the DD of AES, the first cause that comes is the JE, and being the JE endemic thing. So the investigations were done, total count was raised, platelet was low, CRP was high, CSF there were no cells, and JE, IgM and IgG was done and it was negative. As a next investigation, MRI was done. There were abnormal signal intensities, bilateral thalami, brainstem and cerebellum. So what's it happening? It's not a JE, and yes? So, that's why this session is. So with this, we moved on to the second line investigation, and it was dengue NS1, IgG, IgM all positive, and CSF dengue IgM was done. It was positive. So the diagnosis was severe dengue fever with encephalitis. Now I would like to ask Dr. Suman that what's the relevance of CSF dengue IgM? I mean, when we should do, whether we should do it, and how do we interpret it?
Sir, this CSF dengue IgM, this only denotes the neuroinvasion of the dengue, because we know that dengue can cause encephalopathy as well. So encephalopathy occurs because of the cytokine storm, maybe electrolyte imbalance and all this, but encephalitis, that means that it has gone inside the CNS. So to differentiate it, whether the dengue itself is causing the disease or it is the immunity or the cytokine storm that is caused the all these things, so that you can do this. Now regarding this, the problem of this test is this should be taken into account only with the blood tests. If the blood tests are positive, then go with it. Now, CSF dengue IgM has got poor sensitivity and specificity than the blood test, because this particular test is been designed or standardized based on the blood. We are now extrapolating it on the CSF. So it can be done. It helps to differentiate, as I said, whether neuroinvasion or not. But if it comes positive, then it is neuroinvasion. But it is not routinely needed. If there is any dilemma, you are thinking that whether it is something else, then you can do it to have a better evidence of it.
So once that means if the CSF dengue IgM is positive, we can take it as a dengue. So we can take it as a dengue, but this is a very atypical situation. Rare, of course rare. So first definitely we have to think of other viral causes like herpes, like JE, and then only if not we can think of dengue, and especially what Dr. Patra has told that with the MRI feature, though I did not want to go to the MRI diagnosis. Now there was another child where it was a dengue, positive confirmed dengue. The fever was persisting beyond 10 days. And the child had an episode of hypotension also, the child was being managed as severe dengue with IV fluids, and also antibiotics were given because the fever was persisting. The serial monitoring of platelet and PCV were done, and still the child continued to have high spikes of fever, and the child developed icterus and also was becoming pale. So hemoglobin was 8, WBC was low, platelet was normal, ESR 41, CRP 23. You see liver enzymes were raised and bilirubin was also raised. X-ray was normal, USG mild coarse ecotexture with gallbladder wall edema, mild ascites, and echocardiography was done, which was normal. Then it was investigated further, and it was seen that serum ferritin was very high. You can see here 28,000, triglyceride was high, fibrinogen was low, D-dimer you can see was high. So this was obviously a dengue with HLH. Now when to suspect an HLH in a dengue, and how to diagnose, Dr. Amita, if you can tell it.
Yeah, so when the fever is persistent, so we should know that in dengue it is usually the fever subsides by around day 5. So this child was having fever till 10 days also. So this is usually we have to rule out other causes of sepsis, and since all the parameters are deranged, the ferritin is increased, the triglycerides are increased, the fibrinogen is decreased, So this is infection associated HLH, and very common cause is dengue, and since this child was already diagnosed to be a case of dengue, so dengue with HLH, and the criteria we usually go with the HS 2004 criteria, where either it is a molecular diagnosis or it is the lab parameters along with clinical. So that is 5 out of 8 parameters should be positive, and amongst them is fever more than 38.5 degrees for 7 days, more than 7 days, and all these criteria, that is triglycerides more than 265, ferritin less than 1.5, and the ferritin more than 500, fibrinogen less than 1.5, and pancytopenias, usually 2 lines should be deranged, hemoglobin less than 9, platelets less than 10,000. So and also evidence of hemophagocytosis cytosis in the bone marrow, liver or spleen, and also so these are the criterias. 5 parameters of the 8 should be positive for us to diagnose it as HLH.
So it's though not very common, but see secondary HLH, secondary to infection, it can happen with many infection. We have come across with typhoid, with scrub, with malaria also, with dengue also sometimes. Point is that initially if we do liver enzymes, it may be slightly raised, but once with the persisting fever, clinical deterioration, when there is leukopenia, hemoglobin falling and the liver enzymes rising, we must be very cautious and we should investigate, we should think of HLH, secondary HLH also, and thus once we did the panel, it was secondary HLH and it requires definite management. So intentionally, I have kept very simple investigations for this discussion, and I have kept some time for you to ask any questions regarding lab investigation of dengue, because we have so many other sessions to cover on clinicals and complications, but if you have any question on lab investigation.
Sir, before that,
Yeah.
one aspect I should add regarding the dengue PCR, that is something coming in.
Yes.
Now, dengue PCR is yes, okay, you can do it. Even it can be done in 1 hour time, so some of the kits are coming in very fast. So you are just taking the blood within 1 hour time, you know that dengue PCR is positive. But this is not, I will not say that this is something routine to be done. Dengue NS1 is very well positive in the day 1. So it is a better cost-effective one than the dengue PCR. And PCR has its own negative points, like it should not be done in the after 4 or 5 days time. And again, it needs its own precision and all these things, in your own expertise and all this. So PCR is in, okay, we will know the serotype, it's okay. But for all practical purpose, dengue NS1 should be better taken than the PCR.
Fine. Doctor, just once. Dr. Subhash is what? Please, Mike.
No, you please go ahead.
You told that arbovirus infection, other arbovirus may be cross-react and there is a possibility of NS1 positive.
Yes, sir.
But we are getting lot of non-arbovirus infection like scrub typhus, hepatitis A, leptospirosis, NS1 positive, false positivity.
Right, sir. More of, rather than NS1, sometimes IgM is also positive in that situation. So it is there, that depends upon the kit that we are using. So if the kit has got better, better type of kit, I will not name the company's name. There are few companies which are randomly used and which are pretty cheap. In that situation, these sort of things happen more. Even it is seen that even after COVID, that is COVID-19, some of the patients have shown false positive IgM. And in that situation, we have to take into account regarding the clinical picture, and also you may repeat after 2 days or 3 days how the titer is rising or something like that. So that helps in better identification of it. Especially it holds with scrub typhus. Now scrub typhus, if you say scrub typhus positive, it is better to go with the ELISA. We all know. Now scrub typhus ELISA, only one US FDA approved kit worldwide is from the InBios. Since it is only one, so I am naming the company's name. But in spite of that, that particular test has got certain fallacy. It can have false positive in case of dengue. So with the clinical picture, you need to judge it, And then in case of any doubt, you should repeat after 2 days or 3 days, maybe after 4 days as the situation demands.
Just
Sir,
one.
actually, this is the government supply. We cannot control the kit what is available.
I know, sir.
What we are doing we are doing IgM, and that came to be negative. IgM dengue was negative. NS1 was.
That's what I said. You have to do, if it is NS1 positive, then after 4 days or 5 days, we will go with IgM. If initial phase you have not tested, it is IgM positive, but you are seeing it is not fitting into the case
Please,
of,
summarize.
then you can do it after 3 to 4 days again to repeat.
Sir, you have just mentioned the titer, rising titer. Should you repeat? And any, say, grossly raised titer is in relationship with severity of dengue?
It is no. It has got no relation with the severity of dengue regarding the titer. It only helps to know whether it is not actually titer, it is actually optical density.
I wanted to make a comment regarding your question. I think part of the problem comes because we need to use our tests much more carefully than we do. For any test, there is always a false positive, false negative. No test is 100%. So there's something called as a pre-test possibility or probability of having the disease, and then only you should do the test. The problem now comes is that you have these labs who come with these panels. So when you have any child with fever, whether you're thinking of dengue or not, you get an NS1 done and then it comes false positive and you get confused. So I think we should use our tests very, very carefully and use only when the clinical situation demands it. And as the panelists have already said, it's better to do an ELISA. I understand your situation, you don't have control over the test, but please take the results with a pinch of salt.
Thank you, Dr. Prabhu. Yes.
A simple question.
Yeah, please.
After 40 hours, if some patient again fever and such develop. It is the serotype, another serotype. After 40 hours again fever come or such and such. It is the another serotype.
Dengue is classically dengue fever is biphasic. So, and serotyping is not possible routinely. Dr. Tapisha, you want to add anything?
Yeah, just 2 quick points about PCR. One is, of course, sir said it is as good as NS1. Only remember, in secondary dengue, the NS1 antigenemia is cleared very quickly. So PCR may be positive, but NS1 may be negative. We've had children who have come with shock on day 2 of fever, everything negative. When we did a PCR, it came positive, and that's how we could diagnose that particular case of dengue. So it has utility there. Otherwise, large-scale studies have established that PCR and NS1 have similar sensitivity and specificity in first 5 days. Also, as Sir said, if your PCR kit is unvalidated, it may come false positive in any illness. So the dengue PCR kit has to be validated also. Viremia, sir. Secondary infection will have more antibody response.
Quicker IgG response, yeah.
Yes, so it clears the viremia fast.
Because of the pre-existing IgG antibodies, the virus gets cleared faster from the circulation. But the problems are more because of the antigen-antibody complex.
Antibody enhanced. At which frequency I should do PCV?
Please, question please.
Hematocrit should be checked at which frequency? In a per day or 3 days?
That depends on your clinical scenario. PCV, platelet and hemoglobin, you have to repeat as per the clinical condition of the child.
Yeah,
if you're feeling that the child isn't, and that will usually start, if there is a capillary leak, it will increase after 4.5 to 5 days.
West Bengal government যে গাইডলাইন আছে তাতে বলেছে 2 আওয়ারলি পিসিবি চেক করার জন্য
Actually, if the child is admitted, there is a strong guideline from the government of West Bengal. Then you need to follow it up. If the child is not admitted, then what Amitadi has said. If the child is admitted,
Yeah,
then it
one
is to be
second.
done.
I will tell. See, the management of complicated dengue, we have sessions. But here, what the panelists have already told, that it's not essential for a stable dengue, not essential to do frequent platelet or PCV. Depends on the clinical situation. Next question. I think this will be the last question, please.
Let's take 2 hypothetical situations. One is child is suffering from viral hepatitis A, gradually improving, and on the 2nd or 3rd week, he has developed this fever and this NS1 positive. So how long how much it will help to do the SGOT, SGPT, liver enzymes or ultrasound in that case. Number two, the child is suffering from nephrotic syndrome on steroids, and then in that case, how will it help for the ultrasound as well as the liver enzymes?
You want to add?
Hepatitis A. So by the second week, the liver enzyme should have come down. And here in dengue, not all dengue will have a rising SGOT, SGPT on the.
That's what I'm asking, whether it will help or it will give more confusion.
So you have to have the clinical time.
Yes, that's what it is, the second and third week.
No,
Second and third
actually,
week it comes down. So whether it will help or not.
The thing is that, see, in any dengue being an hepatotrophic virus, there will be borderline elevation of SGOT, SGPT. If the child is clinically deteriorating, features of leukopenia, thrombocytopenia, we have to think of HLH and investigate likewise. If the child is having high jaundice, which is unlikely of HLH, then we have to think of other co-infections. Then also liver enzymes will be high, but other markers will not be that high. Any response about the nephrotic syndrome to finish? Any response? Or should I call Dr. Shakil? Our nephrologist, Dr. Shakil Akhtar is here. Would you like to give your input? I have seen Shakil entering.
No, she's already answering.
No,
please, you
it's
continue.
just that you have to individualize every case. You cannot have standard protocols or standard answers to this.
Hey.
Understand that any way the nephrotics are, if they are on long-term steroids, they are at risk for severe dengue. So if any nephrotic develops any suspicion of dengue, day one you have to admit and manage.
So final
that's how
expert,
it is.
yeah, thank you, sorry. Final expert comment from Dr. Shakil, please.
Yeah, rightly said, ma'am. So when you have a nephrotic, they are usually immunocompromised, and because they are on long-term steroids, they are likely to have more severe infections, more fluoride infections, likely to have a very fatality rate is very high. In that case, the standard management of dengue takes the precedence. So that should be the utmost importance. In terms of managing the dengue, that becomes the first and priority. And then nephrotic can be managed later on. But then be very careful about the superadded infections or associated infections that comes along with the dengue and nephrotics. So
thank you. Let us, please.
Now, ultrasound will give you the volume status. If you check the IVC, that will tell you the volume status of the child. Whether you need to upgrade your fluid status, whether you need to give more fluid, or you have to restrict your fluid.
I think we have to wind up, because as an organizer, I cannot overshoot the time. So I am grateful to the panelists for enlightening and also to the delegates for nice interaction. So the mosquito population is decreasing definitely with the onset of winter, and I wish you all a season's greetings, and let us have a nice and cool winter. Thank you so much.
Thank you, Jaydeep, for the excellent day. May I have the privilege to hand a small memento to Jaydeep first? And picture, please, picture. And Dr. Tapisha, an old friend of us, always coming to Kolkata just on one call. Dr. Amita, and So next, our next topic is suspected dengue in OPD, and it is by Dr. Khya Ghosh Uttam, and our experts are panelists, Dr. Surendranath, Dr. Subhashish Bhattacharya, and Dr. Dibyendu Rai Chaudhary. Khya asked me what exactly she wants to do, but she has done a very nice job, and you will be learning a lot that not all dengues need admission and that all dengues are not very serious. Please, the panelists, take your chair.
So thank you, sir. As sir said, I was just thinking in a suspected dengue in an OPD, without investigation, what I should speak for 40 minutes. But I thought it is the most commonly, because we only 5% or maybe 10% cases goes into the critical phase. So mostly we deal with the OPD. So here we have an august gathering of this very good clinicians. So we will restrict our discussion to the how to manage in the clinically in the OPD. So when a baby with a suspected dengue in OPD comes to you, there are 4 questions which should come into your mind. First, whether it is dengue and how we can do it by simple guidelines, ask, look, and then test. We will not go into the test part. We'll just do on the ask and look part. And then, if it is dengue, what is the second thing that you should hear? Now we have the, what is the severity? So we used to say dengue with or without warning signs and severe dengue. Now we classify them into dengue, mild dengue, moderate dengue and severe dengue. So this is very important because on that you will decide on your next step. And how we will decide that? By checking the presence or absence of danger signs, by taking history and assessing the clinical status so you can find out the next. The important question is whether the baby requires admission because the parents will eat your head. Doctor, bhotti korte hobe, bhotti korte hobe. So this is the most important and we should not overburden our hospitals also. This is a very, very important. You will see in dengue season, not a single bed is available. If you have a severe patients in some other condition, you will not get a bed. Just all bed occupied for mild to moderate dengue. So this should not happen. Okay. And next, if we are managing the baby in OPD, taking the burden on your shoulder, how we will monitor. And we have an excellent expert panelist for this, so we will answer this. So just for the introduction, dengue infection, you know, it's a very dynamic thing. It has 3 clinical phases. The acute febrile phase has a sudden onset high-grade fever with associated symptoms. We'll come into the cases, we'll discuss that. And it may last from 2 to 7 days, okay, as we were discussing. Any fever which is in dengue, it's going beyond 6 to 7 days, you have to think high alert. The critical phase occurs only in 5 to 10% of the dengue patient which progress to critical phases. And when the fever comes down, the deprivation sets in, then it occurs. And it is marked by 2 important things, coagulopathy and vasculopathy. So how to monitor, we will come into that. And of course, the recovery phase is as good. So some of the babies go directly from febrile phase to recovery phase. Some goes into all the 3 stages. So it's a very dynamic thing. So now comes to the cases, because this is how we see a 3-year-old female child presents in your OPD with high-grade fever for 3 days. There is myalgia, there is body ache, occasional cough. They are not, so every mother comes and says the baby is having cold and cough, even if they don't have it. So it's like that, occasional cough. So Dr. Surendranath, sir, what do you think? It's a...
It is an acute febrile illness, typically,
absolutely.
and without any prodromal symptoms. Sudden onset of the fever, without any focus. So we have to think of all the conditions of acute febrile illness without any focus. Like most commonly the tropical fevers, which we have to think. And sometimes urinary tract infection also has to be kept in mind.
Yes, so commonly we think of like thoda bahut khasi hai, theek hai, influenza, other respiratory viral illnesses. Of course, in monsoon we have to think of dengue, malaria, and UTI typhoid always hits in the children's year. So, but what are the important histories that we should take so that we can rule out all these differentials, Doctor?
Actually, any febrile illness like this, the high fever for 3 days, myalgia, this rainy season and post-rainy season, few months, we should consider as a differential diagnosis as a dengue fever. But the presentation and history you should take properly. Because we are getting huge number of OPD footfall of dengue patient, and also they are being admitted. They are presented with just sore throat. There is a sore throat. When you are examining the throat, it is red. And what we have seen, some pediatricians, they have advised antibiotic for that, because diagnosing that it could be acute pharyngitis or laryngitis, tonsillitis. They have started antibiotic, but these are actually dengue. So we have to see all these things, throat examination, which may be there, and also the kind of cases we are getting now is little bit of facial puffiness, and
conjunctival
red type
redness,
of face, reddish appearance of the face with a high fever. And the classical pain, now whatever getting is not always this retroorbital, it is headache little bit, and limb pain, cough pain, and difficulty walking, those are cases we are getting nowadays.
So of course, you have to take that whether family members or neighbors are having dengue or is it a monsoon season.
Yes.
Associated symptoms localized and very rightly point out. Even pharyngitis, a little bit redness of eyes, which mimic any other viral infection, viral URTI, can be there in dengue. And very important, don't forget if you suspect to ask 3 golden questions to assess the hydration status. How much fluid the baby is taking, how much urine output, and whether any limitations of activities. Of course, you will ask about warning signs, medications, comorbid conditions, because that's how we triage the dengue into A1, A2, you must be knowing B1, B2 and C1, C2. So associated with comorbid condition, they becomes to the 2 categories.
One point regarding this medication.
Yes.
We are also seeing the cases, the high fever, the
NSAIDs.
mefenamic acid was
Mefenamic
given
is-
and ibuprofen was given. Those
Exactly.
are the cases present with the complicated dengue and being
Exactly. It's a very, very important message. In monsoon season, suspected dengue, don't write anything other than paracetamol, okay? So often they will come 104 fever, madam paracetamol se nahi ja rahe hain, but you have to explain this is the safest medication, at least in the dengue seasons. And of course, to rule out, you can take an exposure to jungles, waterlogging and swimming. So back to our case, it is a monsoon time. And there were few cases of dengue in the neighborhood reported recently. So drinking adequately, the mother said the child is drinking adequately with good urine output, only on paracetamol, occasionally vomiting also after that. On examination, you could see a macular rash, which is a very classical of dengue, and there is no other focus. So mother is restless and want to send investigation and admit the child. So first, is it a dengue? Anyone would like to say?
Yeah. In the season, even on day 1, if the patient comes to your OP, you can definitely say it is going to be dengue.
So
What we have observed is a very high-grade fever which starts suddenly.
Yeah.
They come with a high-grade fever, severe myalgia, and the rash is very typical. It is a diffuse erythematous rash. When you put your palm, you can see your impression of the palm.
So this is a clinical description of dengue fever by vector-borne disease. Classification is any acute febrile illness with 2 or more of the following manifestation. In this baby, the baby had myalgia, the baby had rash. So even if we don't think there is no danger signs, this is most likely a dengue. And these are the classical symptoms. The rash comes in 2 phases. In febrile phase, in the first 2 to 3 days fever, if you get a maculopapular generalis rash which blanches on pressure. As you can see, this one. This is blanching on pressure. This is typically seen in rash in febrile phase. And here, the baby looks erythematous, as Dr. Bhattacharya was saying. And if you just put your hands, I know this can happen in many other cases, but it looks like this. Whereas the rash in a convalescent phase is confluent erythematous eruption, which does not blanch on pressure, with multiple small islets of normal skin, what we call of isles of white in the sea of red, and it itches. It has an intense pruritus. It itches. The baby always goes on. And the good thing is, if you see the convalescent rash, you can always say the baby is out of danger. So this is the classical. Now, Dr. Dibendu, what are the danger signs of dengue that you should ask for?
So it is very important. The danger sign should be aware to the clinician as well as the caregiver. Because in case of dengue, what we have seen in our clinical experience is that the deterioration is very rapid. So you have to pick it up as soon as when the danger sign appears. So you should well aware of this. So what are the danger signs? If we say they are the like abdominal pain is a very alarming sign for a dengue patient. So you have to pick it up, number 1. Number 2, if there is persistent vomiting, and if there is any bleeding from any mucosal site, if there is any third space loss, capillary leakage like ascites or pleural effusion, that are also to be picked up. And if there is sudden alteration of the sensorium like restlessness or lethargy like that, if there is hepatomegaly, when the liver is more than 2 centimeter or like that, more than 2 centimeter increased or like that. And lastly, when there is rapid fall in the platelet count and increase in the hematocrit.
Hematocrit.
So we have to pick up it very rapidly when it appears. So these are the warning sign of dengue.
So a very, very clear message from Dr. Dibyendu, not only the healthcare providers, but the parents should be also taught about that, and they should report immediately. This is the most important thing that we should do in dengue. So this is, I'm just going because we have already discussed, so it was first dengue with or without warning signs. Dengue without warning signs is your mild dengue, you can manage in OPD. Warning signs becomes moderate and severe dengue. So coming to Dr. Surendranath, so when you will admit a case of suspected dengue, especially in this child, the mother is less late. Would you like to admit the case? Okay,
No.
the answer is no. But
Yeah.
when you will admit a case of suspected dengue?
So now it is 3 days fever as per the case, in fact. On the day 1, definitely we will not admit. Day 3, it's a biphasic fever. Usually on day 3, again the fever may go up. Day 3 or day 4, it may go up. What are the signs to get the patient admitted is, if the patient is living far off, where you cannot follow up. If he is not coming for the follow-up,
Exactly.
definitely those patients need to be admitted. Those poor intake is there, oral poor intake is there because 4 days fever, child is not taking anything orally, you can definitely admit them. And clinical signs of dehydration is one of the signs definitely you have to take into consideration as far as admission. Investigations on the 3rd day, maybe definitely we can send them because most of the parents, what happens is that it is a high grade fever. By 3 days, they will be pestering you for the investigation. They want some investigation to be done. As we said that, most of the times you can manage without investigation also. From the 3rd day onwards, I think we have to look for any thrombocytopenia which is occurring. So it can occur even before the fever subsides in some cases.
So
On the 3rd day, if you are suspecting, do a CVP. If there is any fall in the platelet count, definitely those patients may require admission if it is less than 1 lakh. Normally, if it is less than 1 lakh, better to admit. It is very difficult to follow up them practically. My practice, less than 1 lakh is difficult to follow up. Ask them to come every day, do a platelet count. It's very difficult to admit. And raising of the PCV will take some time, I think. They have to get into the critical phase where afebrile, after the fever subsides, they enter into the critical phase. At this moment, if the child requires admission to a CBP with a leukopenia, thrombocytopenia, with the decreased intake of the fluid, definitely we can admit. If you take the Sri Lanka into consideration, all the dengue they admit.
Yes, absolutely.
Once the dengue, they admit dengue.
Exactly. So the dictum is, though there are classification like this, but you have to individualize this. So as sir said, you cannot just say, okay, mild dengue doesn't require OPD admission, though this is the guideline, because if the compliance is poor, if the patient stays very far off, and the mother is not able to understand what are going to be the danger signs, if you think like that, it's better to admit. And as sir said, in Sri Lanka, the mortality is 0 because they admit all cases of dengue. We don't have that facilities to admit so many cases. So but we have to individualize, always use your intention, what you want to achieve, and then you do like that.
Yeah, I can add one thing.
Yes.
Any child, fever, 3 days, and that's decrease, and there is a persistent vomiting.
Vomiting, it's
urine
better.
output decrease.
Yes.
Child is not taking anything.
Yeah,
orally,
that is.
we should admit those child.
Because that will go to moderate dengue. That will, it's not a mild dengue.
The only
so
problem-
any dengue with some signs of danger signs becomes a moderate dengue. So dengue without danger signs is a mild dengue. Then decision whether to admit this mild dengue is mainly depending upon the compliance and when you think the parents will not be able to take the proper care. Moderate dengue like this, dehydration, there is abdominal pain, there is persistent vomiting. Maybe the platelet count is normal, even if it is 1.45 lakhs. In that case, ideally it is better for hospital management, but you can go on observation provided you are very, very sure they will report to you every day. But severe dengue, no question, just admit. Yes, sir. Below 1 year, again, because I said this Group A, Group B, Group C, all are divided into A1, A2, B1, B2 and C1, C2. So A1 is, or B1, A1, B1 and C1 is all without risk factors or without comorbid conditions. Infancy is a risk factor. Extremes of age is a risk factor. Chronic lung disease, chronic hematological disease, these are risk factors. So if you have, it becomes A2, then you have to decide it's better to admit.
One caution is,
Yes.
okay, you can admit the patient even before the leakage is there. But only thing is, managing the fluids is very important. Don't be over enthusiastic to give the IV fluids. This is the cause of the mortality. In fact,
Exactly.
once it is admitted, people tend to give at least maintenance of the IV fluids. Don't give maintenance of the IV fluids if you have admitted.
Assess the hydration
Follow the
status
Sri
and then-
Lankan formula. Give 1.5 ml orally,
Yes.
0.5 ml IV. Always maintain oral even if you have admitted.
Exactly.
Because once you have admitted, they expect you to start some IV fluids.
Yes.
So
that is
if you
very
give the normal level of IV fluids, definitely you are landing in problem.
Exactly.
For the leaking,
No,
admission.
if it's a falling
No.
platelet, it's usually
Yeah.
it's better to get admitted because if there isn't some severe bleeding, you may be sued. Because in the first year we have a discussion on the ethical issues. You may explain them, but I think falling platelet. But don't think that if the platelet was 2.4 and now it has become 1.8 lakhs, don't admit. Of course, you have to judge that way. So not only the falling platelet, how much it has fallen, you have to consider that.
Kya,
So what is severe dengue?
should we tell any mother that your child is suffering from mild dengue?
No, that's what I said. Though they have classified like that, we should not say like this because you don't know when it will progress. So when, even in a mild dengue, if you think the mother is not, what I should not say intelligent enough, but not capable of monitoring, you better dengue. That is the first thing I said. So compliance is a very, very big issue. So though that classification is there, you should keep it in the back of mind, but individualize every case. So, but we should know what is severe dengue whenever there is severe plasma leakage, significant bleeding.
Bottom line is, follow-up is very important. Dengue, if it comes on a day one as a dengue fever, parents are worried. Explain them, ask them to come for follow-up after 2 days, 3 days, after the fever subsides. Explain them they have to be under follow-up.
Exactly, and always, always assess the hydration status.
Yeah.
Because you don't know, sir, when
The most of the mortality in dengue is giving
fluid.
over-enthusiastic IV fluids. That is the reason. That is the reason. If we can take orally, maintain them orally, what Sri Lankan experiment shows is they admit all the cases, definitely. But they give only 0.5 ml IV, 1.5 ml orally, the 2 ml per kg per hour. They give orally. They monitor the patient, see for any signs of shock or see for any leakage is there. Then if there is shock, they will increase the fluids as a bolus. That is the management. But if you start with regular amount of the fluids IV, definitely those patients are going to have leak if there is thrombocytopenia.
So if we calculate the maintenance in a children, the normal maintenance comes to the tune of 3 ml per kg per hour. So in a mild case, when there is no vascular permeability, no baby is not in shock, or you don't think there is vasculopathy, it is better to give it a maintenance half. That is 1.5, what sir is saying, 1.5 ml per kg per hour. Normal maintenance is 3 ml per kg per hour. If you suspect 5% dehydration that we think of in a moderate, we start with 5 ml per kg per hour. 7% is 7 ml per kg per hour and 10% is 10 ml. So in moderate we give around 3 to 5 or maybe 5 to 7, but never 7 to 10, which we give in severe dengue. So this is how the calculation is.
I've got one experience.
Yeah.
When we take the responsibility of the patient on my hands, body's reflex will not work, and suddenly if it's not cared for, and child goes in shock, many times I find that if you attempt giving good fluid at that time, before giving maintenance fluid, that works well.
Now that's because then you have to monitor
Present
this.
recommendation
Once you
is
give fluid, you have to
not to
monitor every 6
overload.
to 8 hours.
Present recommendation is not to overload.
Yes, yes.
Monitor the patient.
So we
Once
will have a
admitted, you are
separate
monitored.
discussion in the critical year. So that is basically, but if you give fluid, don't give a fluid for 24 hours. That's the dictum. You give it for 6 hours and evaluate every 6 hours. Yes, okay, yeah. So the clinical assessment in suspect of dengue, not only we have to do the monitoring of the hydration status, do a assessment of the mental status, because or if there is organ perfusion is deranged, as in the early features of shock, you will have irritable child. You assess the hemodynamic status, look for respiratory tachypnea, acidotic breathing, pleural effusion, abdominal tenderness, hepatomegaly, ascites, and look for rash, bleeding manifestations. And sometimes we say tourniquet test to see whether this baby requires admission or not. So, Dr. Shubhashista, do you do it regularly and how do you do it?
In our PGD days, we used to do the tunicase test several repeatedly, but nowadays hardly I have seen the
Yes.
doing tunicate tests. Nowadays we don't do it. I don't know what.
Exactly. What is the opinion of the house? I don't think no one in the OPD at least does this tourniquet test. So it is, so it is not done. So we used to do it because there are so many other methods where you can do.
The instrument today is automatic, not the marker. Marking is possible, not
So you cannot keep the PP in between the systolic and diastolic. Okay, that's a good point. Okay, how to manage the case in OPD? Dr. Dipendra. So how will you manage the case in the OPD?
So as you know, all dengue are not critical initially. So some dengue you can manage on OPD basis. So what to do first, you have to confirm the diagnosis and first NS1 and serology. Then you should have done hemoglobin, platelet count and hematocrit. These are the basic. Then counsel the mother. First you have to say what are the danger signs. You have to pick up. Mother said, as we have explained earlier. And regarding therapy, therapy is only paracetamol. No NSAID, no NSAID and no SID. Only paracetamol in proper doses that will take care of the fever. And regarding fluid therapy, so oral fluid is preferable as in OPD basis. Adequate fluid and optimum fluid should be given. In our residency days, it was called aggressive fluid therapy. In the book, it was written like that, aggressive fluid therapy. Now, it is not aggressive fluid therapy, it is optimum fluid therapy. That is most important. So, you have to titrate the requirement of fluid. You have to monitor the urine output. So, for that, these are the main thing you have to do in OPD basis to manage a child. But most important, you have to counsel the mother regarding the warning sign. You have to pick it up early as possible when there is deterioration.
So the only
because dengue, as in our clinical experience, it deteriorates very fast. They not give enough time. So that is most important.
So very clear. Yes. You
can give
ORS,
normal water,
ORS, but don't give carbonated drinks.
But canned food, aerated water, that should not be encouraged.
Don't thumbs up Sprite nahi. Okay. So prescribe the oral intake. It is better always how much to drink. You can write it also, and it should be carefully monitored.
Here, one point to add.
Yes.
Sometimes you see whole the day mother is giving ORS.
That is also not. That is also not. So ORS and plain water.
So better plain water in between ORS or other liquid like coconut oil.
Coconut. So, and you should also educate the mother and the warning signs, and also they should report if they see, if any of this, they come across any of these symptoms. So you can always explain them. It's better to write in your prescription the danger signs. Like when we discharge a newborn, now we write the danger signs in one sign. So if any of these danger signs are there, come back. I think for a dengue, it's better you write the danger signs, and if anything comes back, otherwise you may be sued. So coming to our next, so this baby, the case one was managed in the OPD because the mother was okay, so I'm not going into that. Now this is another case, a 3 year, 7 months old male child, fever for 7 days, monsoon season with abdominal pain and vomiting. On examination, the child was irritable, sick look, icteric, tachypneic, there was hepatomegaly. So what are the differentials against Dr. Surendranath, please?
4 days fever differentials should be, one of the dengue is there, but icterus is very rare. The point against is 4 days dengue may not have icterus, clinical icterus may not be there. There may be liver enzymes may be elevated, but the serum bilirubin may not be that much elevated. Viral hepatitis definitely a possibility, vomiting and malaria. Sick looking child with mild icterus, okay, we can think of. Leptospira, possibility is there, provided epidemiological features are there. He is exposed to the flooding of the water.
Yeah, this was a monsoon, so we get leptospirosis really.
Rickettsial with icterus on fourth day, still, I am still suspicious. If there is any definite eschar is there, you can think of it. Typhoid, unlikely, because 4 days fever with icterus, typhoid is very unlikely. So we come to the conclusion that most probably, if dengue is not there, viral hepatitis, malaria, leptospira may be a possibility.
So the first four are hitting the link because you have. So the investigation revealed, so we will not go into the investigation detail, but the investigation revealed a leukocyte, leukopenia 4,100 with a platelet 75,000, CRP 9. SGPT, SGOT was 115, 156. I think we have addressed this in the last discussion. So is it dengue or viral hepatitis? PT-INR being normal.
Yes, as the differential mechanism shown before, all are possibility except viral hepatitis. Viral hepatitis unlikely because that kind of fever, high rise with chill, and you see the platelet. 75,000. So it's very unlikely viral hepatitis to decrease the platelet count, and also this SGPT, SGD enzyme, they increase viral hepatitis in 100 or 1,000.
Thousands.
Very uncommonly dengue, maybe 1 or 2 or 3 times.
Exactly.
But unlikely to be 100 and 1,000 in dengue. SGPT.
So it is markedly increased in viral hepatitis where it is only 2 to 3 times in dengue.
But one thing, dengue as such presenting as icterus I am yet to see.
Yes. So itself can present.
But
so dengue fever will always have a hemoconcentration, thrombocytopenia, and coagulation profile is usually normal in dengue, but you may have a prolongation of prothrombin time. Abnormal coagulation profile usually indicates a co-infection. So if you get an abnormal coagulation profile in dengue, usually it indicates a co-infection with hepatotropic virus or DIC associated with sepsis. And of course, as Sir was mentioning, concurrent infection with hepatitis A is not rare because, you know, the low socioeconomic monsoon season, so there may be a hepatitis A. So dengue NS1 in this case came out to be
concomitant infections, we do see dengue with typhoid also nowadays.
Yes.
We are seeing dengue with typhoid, dengue with hepatitis may be a possibility there.
So this is a dengue NS1 came out to be positive. How to proceed? Of course, Dr. Dibyendu, will you admit this case?
So as in previous hepatitis you are telling about, but in few cases of dengue I have seen that the enzymes have been raised manifold.
Okay.
It is not like that. In dengue the enzyme is not raised very much. But it is dengue also, there is manifold rise of enzyme. I have seen in my clinical. But it is not usual.
Concurrent infection, no infection.
So it has been ruled out. It was not, it is plain and simple dengue case.
So,
yeah, more than that, more than 1,000 I have seen. Sometimes it occurs, I have seen that.
So usually, so this becomes a moderate case, you will admit and you will of course monitor. Monitor, but remember dengue hepatitis is a as Dr. Jaideep was also mentioning, it's a hepatotropic virus. It is associated if hepatic complications are quite common if the child is already suffering from any chronic liver disease, hepatomegaly, and may develop hepatic encephalopathy very quickly if they suffer from dengue hepatitis. So, and there is a risk of severe GI bleeding. So now coming to the last case, 6-year-old boy came to an OPD, breaking the queue. It was an OPD of not mine, but I think the one who has 50 patients in the line. So they break the OPD queue and came, Dr. Babu, please see my child first. Okay, the child was having high fever for 4 days. There was severe body ache, eye pain. There was persistent vomiting, which was non-bilious, not taking orally since morning. There was giddiness, sleepy, not able to get up, no urine for last 12 hours. God knows why he came to the OPD, he should go to the hospital. So on examination, you can see the baby is drowsy, heart rate 132, pulse very weak, respiration rate was 40 per minute, CRT was prolonged 4 seconds. BP blood pressure 90/65. The doctor has a saturation in his chamber and the assistant said it is 90%. There was pallor, tongue dry, no jaundice, lymphadenopathy. Abdomen, there was hepatomegaly, spleen also plus minus. There was epigastric tenderness, reduced air entry, right lower chest, no Krebs bronchi. CNS, drowsiness, responsive, no meningism, neurodeficits. So what are now your differentials? So Dr. Surendranath is giving as differentials of 3 different categories.
All these cases she has not sent me the spontaneous answers. I may be wrong sometimes. Okay, this case is 6 days fever is there definitely. Tachycardia is there, drowsiness is there. Respiratory rate seems to be normal. CRT, little hypotension is there, BP. SpO2 hypoxia is there, pallor is there, jaundice, and liver 4 centimeters. And there is associated pneumonia is also there, definitely. Drowsiness, responsive. So this is more likely to be a multi-system involvement is there because 6 days fever is there, involvement of the liver, involvement of the lung. Most of the multi-system involvement, you should think of tropical diseases only. It is an isolated findings are not there. So I would think if the child is very sick, I would think of a rickettsia is a possibility in this case because of involvement of the
So
liver
this is an
and
acute febrile illness with shock, with multi-system involvement, and you have severe dengue, you have typhoid, malaria, rickettsia, you are absolutely right, rickettsia, leptospira, and meningococcal often present in MHEA. So here you have features of organ dysfunction because the child is irritable, and also there is reduced urine output, so the brain and the kidney is there is reduced air entry in the respiratory lungs, so maybe either it's a pneumonia or some fluid is accumulating, and of course this child needs admissions. So, day one,
why not it is acute encephalitic syndrome? It fits with the diagnosis of acute encephalitic syndrome.
meningococcal or maybe some other CNS, yes. So, but there was no convulsion or there is just impaired consciousness, yes, that can be also a feature of acute febrile encephalopathy. Now they showed a report, the parent consultant doctor at day one, the hemoglobin was 13 gram, the total count was 5,200, peripheral polymorph 58, PCV was 52%, platelet was 1,86,000. They repeated by themselves a report without showing to a doctor, which came out late because this was just at the end of day 4 when they come hurriedly, where the dengue NS1 was positive, the hemoglobin was 13.5, there is leukopenia 3,200 with a platelet of 82,000, and urine also shows 8 to 10 per cells per HPF. So now what is your diagnosis and what you should think?
Definitely this is a complicated dengue.
Okay. So you will not think...
The child, and this is a very serious child, very sick child. Because all these parameters showing seriousness, and we admit the child, treat as a severe dengue in the hospital.
So we will not go into further.
May require PICU admission.
Exactly. So very, very rightly said, you have to just send to a PICU and take that precaution that the patient does not collapse in the way. And so you should do like that because we will not go into the monitoring because we have a separate session. So now after admitted under you in a hospital, their fresh investigation shows on day 5, hemoglobin to be 14.8, total count 2,600, PCV 60%, platelet now 30,000. Dengue, ELISA, NS1, IgG, AGM, all are positive. USG, hepatomegaly, gallbladder edema. There is ascites, pleural effusion. Now, how we will monitor and how we will, is there any lack of anything in the, do you think there is any lack of?
So what we are seeing here, all the clinical parameters in the all it is severe dengue and complicated dengue. And we are seeing also in the investigations that there is rapid rise in hematocrit and rapid fall in platelet also. So this is a severe dengue and rapidly deteriorating. So we have to shift the patient in the PICU and we have to monitor the all parameters, the available gadget. We have to,
so I think we will not discuss anything regarding monitoring because we have a session, but do you think there is any lapse of any management? Why this child landed like this? So they visited the pediatrician on day 1. The fever has come down but not gone. It's come down. No, this is not HLH.
So adequate fluid therapy which is required?
So the only lapse can be because I think what we discussed in the first slide, the important thing is counseling the parents because maybe the doctor has done, sometimes the compliance is an issue and maybe they should have early reported a little early. Even in spite of that, they may land up like this. So we should be ready in the OPD. So if you see a case like this, immediately refer.
So early detection.
Yes.
Early detection.
Early detection.
The 4th day fever. fever.
Yes.
So by this time fever decreased, parent thought that child is
Exactly.
okay.
Yes.
And then
Then,
complications start.
So,
yes.
The critical phase of dengue.
exactly.
Critical
So
phase of dengue.
in the defervescence type, it is very
So this is very important. We have to make the parents understand about the danger when the fever comes down.
very, very
And
important.
you think the baby is stable, you should be very cautious. Even the day 4 platelet count was a little less. So maybe they could have done it a little earlier. But anyway, this might happen to our everyday who is practicing. So I thought of putting this case. And before we end, we would like to have the key messages and of course answer a few of the questions. So dengue in OPD can mimic any other viral illnesses. So may mimic upper respiratory tract infection, may mimic other viral infections with jaundice. And because symptoms will overlap with other infection and classical signs and symptoms of dengue are not often lacking. So if you are lucky that if you get the typical skin rash, typical retroorbital pain. So proper history taking, clinical examination and laboratory investigations are all equally important. So just don't arbitrarily look for the test, follow, ask, look and then test. Educate the parents how to monitor and when to report. Very, very important. Otherwise, you might land up with a case like this, where compliance, maybe, I'm sorry, it's a mistake, maybe an issue. It's better always to admit the child. I think we have some questions on the floor. Yes, yes, sir. Okay. Mic take to down.
Can I?
Sir,
I wanted to make two comments, not questions. One is something that has not been discussed at all, which I find a big problem in Mumbai as of moment, is the differentiating between chikungunya and dengue.
Yes.
Both these epidemics are simultaneously running around in Mumbai at least. The difficulty is they present so similarly clinically. They both come with high fever, they can get a similar rash, they get a headache, they get a body
severe
ache.
pain, yes.
The issue is when we do an NS1 in this patient, we know that there's a 90% chance that it is positive, but 10% that although it is negative, the patient still has dengue. So what do we do in these cases? I think some clues are important. One is, of course, the epidemiology. If there's a parent who's been diagnosed with chikungunya or something, that should raise your, your antenna, and then you say, okay, let's look for chikungunya. Chikungunya, unfortunately, we don't have a very simple test. It means doing a PCR if you really want to make it. That is expensive. So we can't really do it in every patient. So I still do an NS1. The other thing, there are small clinical clues. In chikungunya, the fever comes down typically by 48 to 72 hours. In dengue, the fever lasts slightly longer. The fever in chikungunya also rises much rapidly and is higher. I generally find 104 or plus in chikungunya rather than in dengue. But otherwise, they are so very similar. The only other difference I find is retroorbital pain is much more characteristic of dengue, whereas general body ache and limb pain is more characteristic of chikungunya.
So we usually get a very, very severe pain in chikungunya.
So I wanted to make this one point. My second point is regarding the discussion about what Dr. Surendranath mentioned about platelet count. In my opinion, no patient dies really because his platelets go low in dengue.
Exactly.
They die because of third spacing. So while I understand that if you have a platelet count of 60,000 or 50,000 and you third space, you are more likely to have a problem. That is granted. But if you are not third spacing, a platelet count of 60,000 is not going to harm you.
Exactly.
So that's something we need to keep in mind. I have my residents, we do CBC maybe every day in a patient admitted. Sir, the platelet has gone from 75,000 to 85,000. So what's happened to the hematocrit? I think we need to look at the hematocrit much more critically than we look at the platelet count. I think you know that now we get these platelets so easily because we have Coulter counters. If you look at what WHO recognized in my time, I'm saying my time because I'm pretty senior now, we used to treat dengue by doing hematocrit only, capillary hematocrit. Dr. Ritu Pratap, you'll remember, we never had this counter. So the hematocrit is even more important. And when you say admit a patient, if the platelet count is below 1 lakh, I will admit a patient above 1 lakh also if its hematocrit is rising. Those are 2 points I want
Just to add to Dr. Suyash Prabhu, if you have, keep a
one
note of how to manage the case in OPD. My first line is confirmation of dengue and do a baseline hemoglobin and hematocrit, not the platelet. So platelet is rare. It is the coagulopathy and the vasculopathy which matters. So you have to have a baseline hemoglobin and hematocrit and not platelet. So this is, but usually we do a CBC, so we get a platelet report.
One last comment.
One.
Yes.
When patient come in
Dr.
outlook,
Suhas Prabhu, the one thing, less than 1 lakh platelet count is not to prevent the hemorrhage. The parent psychology is that I mean thrombocytopenia, they are worried. They don't know that hemorrhage is going to happen, not because of the thrombocytopenia. That cutoff is just for practitioners, so that any critical problems are there, they can anticipate and admit and after doing that.
Only one question, short, very short.
Patient come in outdoor, depend upon the season. If it is post rainy season, an outbreak of this area, so when patient come and outdoor OPD with fever, we must do
Exactly.
exactly.
The first question was whether it's
one more thing is decreasing platelet count is an indication for the leak. Whether leak will be there or not, we do not know. But a decreasing trend definitely suggests that this patient is likely to have leak. Leak may not present as a pleural effusion. There may be mild leak also.
Mild leak also.
Observe that patient for leaks. That is important.
So, okay, thank you the full house for attending and listening to us. Thank you so much.
Thank you so much. Thank you, Dr. Khea and the panelists. Now, may I, as the organizer, may I request Dr. Khea to please hand over a token of memento to Dr. Subhasis Bhattacharya, Dr. Dibyendu Rai Chaudhuri. And may I request Dr. Surendranath to please hand over a memento to Dr. Khea, and please come and have a group photo. So from this, we will move ahead to a more core issue in dengue. Now, dengue in infancy is quite a challenge. So to chart through this aspect, may I request Dr. Jayadev Rai, who is the principal of, somebody please call Jayadev Rai, he's outside probably. So the speaker for this session is Dr. Suhas Prabhu. So may I request Dr. Suhas Prabhu to please come onto the dais. So without wasting much time, I request Dr. Suhas Prabhu to please start the session. The chairperson is having a cup of tea outside, I think. Yeah, Dr. Chairperson has arrived, and he is Dr. Jayadev Rai, Principal of Institute of Child Health, Kolkata. Sir, you please take the chair, and I request Dr. Suhas Prabhu to start the session.
Good morning, everybody, respected chairperson, friends. Sir, you have any comments to make?
Today the topic is dengue in infancy. In the second session, one person from the audience asks whether the all infant child should be admitted or not. Really, the infancy is such a situation when a child suffering from dengue, there is more chance of severity. And they cannot even complain what is happening to them. So these are the two important things. So greater monitoring should be done and early diagnosis should be done. So this is a very important topic. On this, Dr. Suhas Prabhu, he speak on this topic. He is one of the senior most person from the ID chapter. Even IIP has given a great recognition. In 2024, he got the Lifetime Achievement Award from the Indian Academy of Pediatrics. And as a professor, he is attached to Hinduja Hospital, Bombay. So, Dr. Subhas Prabhu, please speak on dengue in infancy.
Thank you for that introduction. Good morning, or it's almost afternoon, everybody. Before I start, I want to make a couple of comments. One is the fact that I'm very grateful to be here, and I know you have invited me, and Ritubrata knows he always invites me every year, and somehow or the other I have never managed to come. This is a infectious disease chapter program, and I know that the summer CME is held almost every year in Kolkata only for so many years. Ritubrata has been so kind to call me every year, I think for the last 5 years, and somehow or the other I have not managed to come. So this time when he called me, or Jaideep called me, I said, no, this time I will come no matter what happens. So thank you very much for giving me the opportunity to be here in Kolkata. The second thing I wanted to say is that this is an infectious disease chapter, and when I'm in Kolkata, I remember Tapanda. So I think he was a pioneer in Kolkata in infectious disease. So when I'm here, I'm somehow missing his presence. Although it's been so many years, I just remembered him, so I thought I should mention it today. So with those few remarks, I want to go ahead with my talk, and it's going to be very short. So I know we've had big discussions. I think I have only 17 minutes left. I hope to finish in less than that. So when I was asked to speak on dengue in infancy, I said, what is there to speak separately in dengue in infancy? There's a whole day program in dengue fever. What is different about dengue in infants? So I sat thinking, and I thought I should write it in some way that, so I thought I put up 3 points in which dengue can be different in infants compared to older children or adults. One is the fact that, as our chairperson has rightly said, it is a more dangerous problem, it's a more serious problem. It results in higher morbidity and mortality. The second is the very strange issue which was also mentioned earlier in the slide, that you can get secondary dengue-like complications after primary dengue, and that's because of circulating maternal antibodies. And third, I thought I should talk a little bit about something which is quite rare but can be extremely dangerous, and that is dengue in a neonate, and that happens by transplacental transmission. So we know that in pediatrics, morbidity and mortality in dengue is inversely proportional to age. That is in pediatrics. In adults, it's the other way around. The older you are and you get dengue, you are more likely to get complications. But in pediatrics, the younger you are, the more likely you're going to get severe. So infants are more likely to get complications compared to older children. And secondly, as I said, it is true that dengue in infancy, it might be the first infection. So it's a primary infection. And in that case, it may pass off as an uneventful illness, like most primary infections, even in older children. But you know that in highly endemic areas, it can even be a second infection. Maybe the child got a first infection 3 or 4 months of age and then again got one a few months later. It's also true that if you do get secondary dengue-like complications, and some of them have been discussed now, they are more likely to be severe. Why are they more likely to be severe? That's because of the immature physiology in infants. Infants have, first of all, they have underdeveloped immune responses. Their immune system is not as good as ours. And I know that the most irritating question I have in my OPD is mother comes and says, my child's immunity is poor, give me some medicine to improve it. And I tell them there is only one medicine available that's free to everybody, that's called time. When your child grows, the immunity improves. So we know that children's immunity is not good, there's no way we can improve it. So because of this, they cannot contain viral replication. So they are also more prone to get severe dengue or complicated dengue, which I'll be talking about a little later. And they can even have hepatic and neurological involvement much more commonly than an older child. So that's the first thing, that you can get a severe infection of dengue itself. When you get a secondary type of dengue with vascular complications and plasma leak, we know that newborns or infants have a very immature cardiovascular regulation. They also have a relatively poor renal ability to excrete or retain urine, because the ability to concentrate urine is less. So because of this, there can be an improper adjustment when intravascular volume changes, and therefore these children can go into an early shock. The third thing that happens is that infants have a much poorer bone marrow reserve. And because of that, when the platelet count drops in dengue, the recovery is much slower or later in infants than happens in older children. So these are the three things, these are the physiological reasons why infants are more prone to get problems in dengue. The second problem that you get in infants who get dengue is that the symptomatology can be very different. It's not the typical symptomatology that has been nicely described by the panel now. They can be very atypical, they can be subtle. You can have a small child with just an irregular fever, not really have much rash, just be irritable, crying. The infant is unable to tell whether he's got retroorbital pain or whether he's got body ache or whatever, so it's very difficult. So it can mimic any other common viral illnesses or maybe even bacterial sepsis. It can look almost very similar, and therefore diagnosis becomes a challenge because of the different symptomatology. Yeah, I already covered this, that the symptoms might be so vague, irritability, poor feeding, and this may of course delay the diagnosis if you do not think of checking for dengue. The other problem that happens is many of these infants, when they get high fever, they present with a febrile seizure. So when the child comes with high fever and febrile seizure, our concentration or our the importance we may give to the seizure itself and try to look whether it's a febrile seizure, whether it's a complicated seizure, is it meningitis, and the cause of the fever being dengue may be relegated to a secondary issue and therefore the diagnosis will get delayed. So we have to be aware that whenever a child with what looks like a simple febrile seizure, if it's a dengue season, please think whether it's got dengue, because otherwise a couple of days down the later you're going to start having problems of plasma leak. The third reason is management in an infant is going to be more challenging, because assessment of the cardiovascular status and hydration is even more difficult in infants than in an older child. It's going to be pretty difficult in an older child. Dr. Tapisha is going to talk about how we're going to give fluids to them and how we're going to manage. Also, because of the cardiovascular problems, the immaturity of the heart and the cardiovascular system and the kidney, you have to be really very careful of how much fluid you are giving. 100 ml of excess fluid given by mistake or by over enthusiasm can really create problems in an infant much more than in an older child. Thirdly, of course, we all have struggled with vascular access or even ventilatory support in small children. It's much more difficult. And also, if shock occurs, bleeding is more likely to happen and may soon reach irreversibility and therefore death. So these are the issues associated why dengue can be much more severe in an infant compared to an adult. The second point I wanted to talk about was antibody-dependent enhancement, which is all we know is the main problem why children get all this vascular leak and secondary dengue-like symptoms. So the strange thing is that in infancy you can get that even after a primary infection. And that's what we really worry about. We know that that is the only thing that's really going to be trouble us, the fluid leak and the secondary complications because of that is because of antibody-dependent enhancement. And it means that once antibody-dependent enhancement means the antibodies have to be already present. Now that generally means the child has had a previous episode of dengue in the past. But in an infant, particularly in the first 3 to 4 months of age, it can happen without the child having a previous dengue infection. If the mother has had a dengue infection either in pregnancy or even earlier. Because we know that the IgG antibodies in dengue can last for a very long time. I think you saw that chart where secondary dengue, the IgG goes on for a very long time. IgG antibodies are transferred across the placenta, unlike IgM antibodies, and they circulate in the baby for the first several months. We all know this, and that is why we don't want to give vaccines like hepatitis A and MMR and measles in the first 6 to 9 months, because we know that those antibodies are going to interfere. The dengue antibodies here are not going to really interfere with the vaccine. We're not going to give vaccine for dengue, but they can create an ADE-like situation after a primary infection. So the child is having a primary infection, that is the first episode of dengue virus, whichever type it is, 1, 2, 3, or 4, and there are circulating IgG antibodies from the mother, and they will cause the same kind of reaction that would have happened if this was a secondary type of infection. So you can get all these kind of ADE complications that are so typical of a secondary dengue infection. So this is very much more common in, say, our country, where dengue is so endemic and people get dengue all the time. So the mother might have got dengue during the pregnancy, carry the anti-dengue IgG antibodies, and they get transferred across the placenta. Okay. Now let me come to the third thing, and as I said, I'm going to be very brief. I'm going to finish before time. So transplacental transmission can result in neonatal dengue. Now this is not transfer of the antibodies, it is transfer of the virus itself. The virus can be transferred across the placenta from the mother's blood, and when this happens, of course, the neonate gets infected, so actually the child gets dengue fever. When does this happen? If the mother's had dengue, say, for example, in the first or second trimester, then the viremia has disappeared by the time she comes for pregnancy. So that's not the case when it will happen. Incidentally, now that I'm talking about that, the other thing we need to remember is that unlike Zika, you do not get teratogenicity. So if the mother has had dengue in the first trimester, she doesn't have to go for abortion or anything, because the child is unlikely to have any kind of teratogenicity. But when she does have dengue, just in the perinatal period, just before she delivers, when she's going into labor, that's the time when the virus can go across the placenta into the neonate. Now when does the neonate present? The neonate will present sometimes as early as a few hours after birth. That depends on, I think one of the speakers already spoke about how long it takes after the virus enters the body to the symptoms to start. It can be as short as 48 hours or sometimes as much as 5 days. So if the virus has gone into the baby maybe 2 days before the labor, then the child can present even on the second day of life. In any case, because the symptoms start within 5 to 6 days, all neonatal dengue which are transplacenally transmitted will present within the end of first week. If you have a neonate, say, I mean we say a neonate up to 28 days, if you have a 14-day-old child who's presenting with dengue which you diagnose, rest assured it is a postnatal infection which the child has got bitten, because that cannot happen because these would present by the end of 1 week. So neonatal dengue is rare, fortunately for us. Less than 150 cases have been described worldwide. What would be the symptoms? They're relatively similar to what you would see in an older child. You see rash, you see thrombocytopenia, you see bleeding tendencies, and they are seen in like 81% of cases. But unlike in older children, fever is sometimes absent. We know these neonates do not produce a febrile response, and you can even get a bacterial sepsis and a child can be hypothermic if he's a neonate or a preterm. So even in dengue, the same thing can happen. So there may be no fever and you'll be confused. Why does this child have a low platelet count and is starting to have bleeding? The other thing that you typically see is that you see hepatomegaly. In an older child, when you see hepatomegaly, typically it means a severe or complicated dengue, and you got to look out for other complications, which I will discuss when I speak later. But in a neonate, hepatomegaly is seen in almost 1/3 of cases, and that doesn't necessarily mean that the child is going to have more severe infection. But I mentioned that infants have a poor hemodynamic ability to manage their volume status. It's even more so obviously in a neonate. So they can rapidly become hypovolemic or have distributive shock. And when this happens, this can happen like over hours. And as I said, there may be no fever. So when this happens, most of these patients present to us like a case of a normal bacterial sepsis. You think this is a bacterial sepsis because the fever is not very prominent and the patient has directly come to you with a shock-like state or like looking like sepsis. So how do we approach this? These are the issues that we need to counter. So first thing is we need to have a very high index of suspicion. So even if the baby has no fever, if the mother has a history of dengue just a week or just before she goes into labor, this child needs to be looked at very carefully whether the child is going to develop neonatal dengue or not. And in fact, all these babies should be tested for dengue if the mother has had dengue diagnosed just before she went into labor, or even just day after she went into day after she delivered the baby, or maybe even a couple of days later. Because remember, the virus could be, she has viremia for 5 to 6 days before the fever starts, so she could have transferred it to the baby. So all these babies need to be tested for dengue. Now how do we test them for dengue? We don't look at the IgG. Because I just told you that the IgG is transferred from the mother into the baby. So you can only diagnose by the NS1 or the PCR. An IgM response in a baby, in a neonate, is not as good as in an older child. So don't rely on the IgM. So you really have to go for the NS1 or the PCR. Also, in any case, the IgM is going to come on the 4th or 5th day. And that's really too late if you really want to manage your neonatal dengue, because they can go into shock very rapidly. So these are the differences in the diagnostic approach. We need to rely more on NS1 or the PCR. Regarding the management issues, I would think that all neonates with confirmed or even suspected dengue, that means the mother has had dengue during pregnancy or just after, the child should be admitted in the NICU. I don't think I would like to have the baby go home or even remain in the ward. And such babies, even without fever, need to have their vital signs monitored almost as if you think they have dengue, like at least every 4 hours or so. There is a problem in looking at fever in neonates because we typically put them under a warmer. And then we adjust the warmer depending on how much the baby's temperature is. So when the baby starts, your temperature 38 degrees, oh, the warmer is too much, so let's reduce the warmer. But actually it could be fever. So you need to be aware of that. The temperature regulation, it becomes more complex because the fever is going to confuse you. And of course, if there is fever, you can use paracetamol. But like in older children, You should not, of course, use any NSAIDs. Lastly, about the fluid management. I think if a neonate has suspected dengue, I would put the baby on a maintenance fluid right from day one, even without plasma leakage. Because I told you the time that you will get from plasma leakage to shock is going to be just a few hours. And in a neonate, hunting for a vascular access when the child is already going to shock is not going to be easy. So I would put the baby on, even without plasma leakage, on maintenance fluid. But if the baby is feeding well, I can say, okay, well, I'll just leave the IV line in. If the baby is, of course, hypovolemic or is having shock, you will administer crystallized fluid guided by the volume status, which can be assessed for older children. Dr. Tapisha is going to give you a big lecture on what fluids to give and when, so I won't talk about that. But another important thing I want to mention is in neonate, you can really assess the hydration status by looking at the weight. It's so easy to look at a neonate's weight. And we do neonatal weights every day. So that becomes very easy to assess the fluid status by looking at the daily weight measurements. And of course, you have to look at other parameters for fluid adjustments. It has to be adjusted. For example, if the baby is premature, you have to look at the gestational age. These babies might require a different rate of fluids. Depending on the postnatal day, we know that fluid requirement changes with age. And of course, looking at the serum electrolytes. So the other thing is, 1 minute, sir. I think you can't really look at the hematocrit to guide your fluid. Because we know that neonates start with a very high hematocrit. So when you say hematocrit of like 44%, doesn't mean the child is already in shock or in having a plasma extra. So, but it's a good idea to have that as a baseline, and then you can look at that later. Change in hematocrit from the baseline in combination with other parameters should guide your fluid therapy. And of course, inotropes and other things can be given. I won't discuss that. You have a speaker on that. One more thing I want to point out is that I just mentioned to you that when the child comes to you with dengue shock as a neonate, it's really difficult to diagnose dengue immediately. It could be bacterial sepsis. All these babies, if they present like that, it would be prudent to send a blood culture and start intravenous antibiotics for shock, presuming bacterial sepsis. And we know that even the leukemia can happen in a bacterial sepsis. Leukopenia, sorry, not leukemia. Leukopenia can happen, which has happened in dengue. So there's just no way of making sure there is no bacterial sepsis unless your culture comes back. So a culture and antibiotic for 48 hours should be done. And of course, once you diagnose dengue, you can discontinue the antibiotics. So I think I won't go into the summary. I've been, I think, quite clear due to lack of time. Thank you very much.
Thank you, sir, for your nice presentation. Exactly in time you have finished this. And already he has mentioned the mortality and morbidity high in neonates if he is suffering from neonates and infant. If he is suffering from dengue, symptomatology also different because symptomatology is probably not there. And here is also like that of other. The NS1 antigen was more specific for the diagnosis. And during the time of management, to some extent it is different. He has meticulously tell about the management. So when an infant suffering of dengue, then greater precaution has to be taken for the management of case. Thank you, sir, and thank you.
Thank you. Thank you, Dr. Prabhu. Yes?
Any question from the audience? Any questions?
No, let us I would request our chairperson, Dr. Joydev Rai, to please hand over a small token to Dr. Suhas Prabhu, please. And I would request Dr. Suhas Prabhu to hand over to the chairperson, Dr. Joydev Rai. Now, for the next session, you know, it's like you might be a great chef, but if you are not very vigilant about the salt, your all culinary expertise will be challenged. Fluid in dengue is just like adding salt to your preparation. So for that, may I request Dr. Shopon Rai to please come to the dais as the chairperson of this session. Dr. Shopon Rai, our Shoponda, he is presently the president of West Bengal Academy of Pediatrics, and he is also professor. But more than that, he is our Shoponda. He is very close to us, so I would like to request Dr. Shopon Rai to please start the next session.
Thank you, Dr. Joydeep, and it's a pleasure to me over here. And today, this topic will be fluid in dengue will be delivered by Dr. Tapisha Gupta. You have already heard her in the early morning. And I have got some request to you, Dr. Gupta. So please give some emphasis on the diagnosis of the ultrasonography, particularly the IVC aorta ratio and the IVC collapsibility in managing the fluid, because it's the new topics some of our colleague asking outside. So please give some emphasis. So over to you.
So I'll first finish my presentation, sir, and then we can discuss.
Okay.
Yeah, thank you. So, good afternoon, and it's a pleasure always to be in the city of joy. Thank you for the opportunity to the organizers and wonderful audience. So my topic is fluids in dengue. Why are fluids the mainstay of dengue management? What is the underlying dysfunction behind severe disease? So essentially, we know that there is plasma leak which causes severe disease. You can see those beautiful oval-shaped endothelial cells. They undergo transient dysfunction. The brush-like glycocalyx that undergoes damage because of dengue virus and the antibodies against it. And there is plasma leak which is happening there. And plasma leak is the basic reason why children get into trouble. Now, what is very intriguing? The intriguing thing is that this dysfunction and damage is transient. Within 48 hours, all the fluid that you have given is going to come back. Why does that happen? Mechanism is unclear. And so this is the primary aim of fluid therapy. We have to be judicious in our fluid therapy to prevent fluid overload. There is this beautiful principle in management which says that if you have an optimum amount of stress in life or in a team while working in the hospital or elsewhere, you have peak performance. I think you can see in the middle. If the stress is less, you get bored. If the stress is more, you are anxious, overwhelmed. So you need an optimum amount of stress in life. So similarly, the fluid has to be just right. Too little is not right, neither is too much. These are the questions that we face when we start IV fluid therapy, and we'll take them one by one. So the first question is when to start fluids. What do we do in dengue fever without warning signs? So when do we start? Should we admit all dengue and start IV fluids? Because the minute you hear this word dengue, everyone gets really worried. Parents are really worried. So what do we do in fever without warning signs? We suggest oral fluids. The kind of fluids that we should advise are these. They should be alternated. Parents should be told not to just keep giving ORS. Keep a check on overhydration. And overly sweet carbonated drinks should be avoided. Parents should see that the child is passing urine once in 6 hours and that is enough. So do we have data to tell us how this rehydration or correction of dehydration in the beginning helps? We have little data because essentially this is a disease of the third world. Only now it is making inroads into the first world. So more and more cutting edge research is happening. And so adequate hydration could reduce severity of dengue in primary care is reported 2023 from France. And earlier study which says adequate fluid ingestion in 24 hours before presenting to the hospital was protective against hospitalization. Remember that while you are seeing these children, observe them closely, and all these children who are infants or who are obese, or if there's an underlying disease like nephrotic syndrome we earlier spoke about, or G6PD deficiency or diabetes, or if they are malnourished or if they're on long-term steroids, they are at risk for severe disease. So these should not be watched too closely at home, admit them early. So when do we start IV fluids? So we start IV fluids obviously upfront in severe dengue and in dengue with warning signs about which we all know in those children who have poor intake and dehydration. So this is an important, interesting study. Sri Lankans are the pioneers, or I would say experts in managing dengue. And this is a very good study in which they have shown that the severe plasma leak trend usually starts on day 3, or by day 4 it is quite evident. It is these children who progress to severe disease if untreated in this crucial time. So this is the time that this has to be picked up. Also, our own guidelines say that if shock is identified as soon as pulse pressure starts narrowing and fluids are administered, then the prognosis is excellent. So this is the point that we have to really be careful. Which fluid we should give now? So we keep hearing about colloids and crystalloids. So crystalloids have crystals, small molecules, immediate help, but then they slowly move out of the circulation. Colloids, colossal molecules, large molecules, they stay in circulation for a longer period of time and they're effective at increasing blood volume. Crystalloids are easily available in our hospitals with less chances of allergy. Examples are normal saline, ringer lactate. Colloids are expensive, difficult to find, more chances of allergy. You could have gelatin or dextrin based, hardly available in our country. You could have starch based like Himaxal and 5% albumin. So what type of IV fluid we should give? It's important to give isotonic fluids and crystalloids because they replenish the compartment immediately and effectively, reverse the plasma leak. What if you give a hypotonic fluid? It is going to leak further, worsen your ascites and pleural effusion. Why shouldn't we use colloids up front? That we'll come to that later, but colloids are to be used in severe shock after a few boluses of crystalloids. The fluid of first choice is normal saline, 0.9%. Can we give ringer or 0.45%? Obviously 0.45 we will not give, it's a hypotonic fluid. Ringer lactate is also isotonic, but see here that normal saline is a little more physiologic. If you give large doses of ringer lactate, there's a chance of hyperkalemia because it has potassium, which is quite a dangerous thing. And also the osmolarity is a little less than normal saline. So normal saline is preferred if multiple boluses of saline have been given and the child is developing high chloride levels. That is when you plan to switch to ringer lactate because you do not want hyperchloremia to happen and acidosis to worsen. Why should you not use colloids? Because colloids are being used in shock after crystalloids. Why don't you use colloids as first line? It has been seen that whether you give colloid or crystalloid initially in resuscitation, it's the same thing. It does not provide any added benefit. Therefore, you don't want to add to the cost. You use colloids subsequently when you are managing severe dengue. They have to be used judiciously. Remember that a liberal colloid use approach, which means using colloids for more than 4 hours, can increase the risk of respiratory compromise. So anywhere between 1 to 4 hours and few boluses, maybe 1 or 2, is something that will keep your patient safe. Why does it increase the risk of respiratory compromise? I said earlier, these are large molecules. They stay in the circulation for a longer period of time. So whenever there is resorption happening, there are chances of fluid overload and edema. Now we come to the question as to how much fluid should we give. Remember that to guide fluid therapy, we have our national guidelines, we have WHO guidelines. Understand that these guidelines are based on clinicians' observations over the years. They are not solid research-backed guidelines. And you should not rigorously just follow everything and the ml per kg written over there. You must balance it with your own patient, individualize your therapy as well as the blood reports of your patients, not at the flow chart. Whenever you are treating obese children, check the weights and then the ideal body weight for that age and then give fluid therapy according to the ideal body weight, not the actual. Also understand, and this is very important, that in most cases that you will admit with maybe, a third day, fourth day fever, some epistaxis, child a little sluggish or lethargic, not taking orally, most of these children, you need to give higher infusion rates in the first 6 hours, and after these 6 hours, the rates will fall, and usually you do not need to give fluids beyond 48 hours. Because while you are giving fluids, you must remember that the fluid that has leaked out is very much sitting there, and it will all return. So you must avoid aggressive, unmonitored fluid therapy at all costs. So now you have these various guidelines and various ml per kg per hour. And what do you do then in dengue with warning signs? So first do a CBC so that you have a baseline PCV. And you just give about 5 to 10 ml per kg for 1 hour. What I have seen after treating so many children in the last 20 years, usually in these children with warning signs, not all, but most of them settle with one fluid bolus of 5 ml per kg for an hour. assess them, and if they look better, start decreasing IV fluids. Decrease it to 3 to 5, and usually 3 to 5 would somewhere come a little more than maintenance for all body weights below 40 kilos. If the child does not look better, what do? You repeat one more bolus of say 5 ml per kg per hour or something, and that is usually enough. If the child is still not better, decrease the, if not better, manage as severe dengue. So this is what usually works. Now the question comes, how do you assess them? Because there was a question earlier, how frequently should you do PCV? It is not really possible to keep checking for PCV every 1 hour or 2 hours. So what do? So what are the ways to assess? We remember that if you do a good assessment, the child recovers fast. So these are the 6 P's of assessment. Passing urine, this is extremely important. This is the most important parameter. And if you have a urine output of about 0.5 to 1 ml per kg per hour, that's really good. Pulse rate and pulse volume you can easily see at bedside. And of course, measures like blood pressure and PCV come down. And peripheries you can touch and see whether the color is okay, the temperature is fine, and what is the CFT. So remember these 6 P's of assessment. Most important out of these I would give to passing urine. Remember that most important dengue doctrines are give enough fluids always to maintain a urine output which is just about equal to or little more than 0.5 ml per kg per hour. And remember that usually beyond 48 hours you will not really need to give IV fluids. Now that was in dengue with warning signs. What does one do in fluids in severe dengue? So obviously you need to give higher amount of fluids. So you have our own guidelines for this and you have the WHO guidelines. So in the national guidelines, you start with a crystalloid bolus, assess the 6 P's, and you can give a similar bolus up to 3 boluses of normal saline. And obviously if the child is better, you start decreasing after the first bolus itself, get it down to 7 ml per kg per hour, then 5, then 3, and everything depends on how soon your child is passing urine and other parameters that I've explained. Now suppose after 3 boluses also the child is, if this is still refractory shock, this is when you start giving colloids, and also assess if there is a bleed happening somewhere or if there is a cardiogenic cause, in which case you're going to go and add vasopressors, and for hidden bleeds you would transfuse packed cells or whole blood. What does WHO say? Does WHO agree to this? So WHO has similar recommendations, but it makes a slight difference between compensated and hypotensive shock, and it says in compensated, the systolic pressure is normal, and in hypotensive there is a fall. So compensated shock, it says the recommendations are somewhat like this, that you can give up to 3 boluses. Usually they get improved with 1 or 2, and if still refractory, give colloids. It's the same thing that has been repeated. But if it's hypotensive shock, then they say, WHO says that hypotensive shock has to be treated aggressively. At presentation to the hospital, it is a poor prognostic sign. These are the children who are going to land into trouble. So give 20 ml per kg colloid up front. You may, if it's available, or crystalloid, and give it fast over 15 to 30 minutes, and then start tapering if the child looks better, and switch to crystalloids if the child is better. If the child is not better, you can give 2 further boluses of colloids at 20 ml per kg over 1 hour each. Now we come to these questions which are always in our minds. What is the indication for transfusing blood? When should we think of giving blood? So there are only these 2 indications. One is the shock is not getting better, and you find that instead of a rising PCV, you have a fall along with hemodynamic instability. This is important. All the 3 things together: shock persisting, PCV fall, and vitals not fine. Look for an internal bleed. Usually such a child will have a GI bleed. Internal bleeds are usually GI bleeds, may have an abdominal distension. That is one indication for blood transfusion. The other is a persistent or worsening metabolic acidosis. Such a child may even have a normal blood pressure, but the child will have a worsening metabolic acidosis. Again, look for a hidden bleed, and unless you treat that, the child will not get better. Remember that while you are treating, you may overload, therefore transfuse fresh packed red cells at 5 to 10 ml per kg or whole blood of 10 to 20. remember that you have to keep asking and checking for abdominal distension and tarry stools in children. Now the most important question, what are the indications for platelet transfusion? Because, no, please don't take a picture, it is not correct. Yeah. So this, I had put this slide to wake up the audience, but this audience is awake since 9 a.m., so I didn't need to. So what is the indication for platelet transfusion? So essentially, all guidelines and including the Indian Society of Critical Care Medicine has taken out very good practice statement. It says that prophylactic platelet counts have no role, except maybe if the platelets are less than 10,000. That's the only indication. Otherwise, what about in bleeding? So if a patient is bleeding, if a platelet count is less than 50,000, you may transfuse platelets. It's not 20,000, it is 50,000 cells. Why is that so? As we've spoken earlier, most of the bleeding or hemodynamically significant bleeds are not because of thrombocytopenia, but because of coagulopathy or vasculopathy. So giving platelets will not help. In fact, it has been found that if you think of giving platelets because of some pressure from the parents, etc., there may be adverse reactions, there may be anaphylaxis, there may be what is known as transfusion reaction associated lung injury. So it is better to avoid these. And low platelets are happening because of destruction in spleen and antibody. Therefore, even if you give platelets and repeatedly give platelets at a count of 60,000 or 40,000 but no bleeds, you are only benefiting the blood bank, not the patient. So it's important to understand this. Besides this, I have not added FFP. FFP is also a bone of contention whether to give or not. Again, in only if there is overt bleeding in the presence of coagulation abnormalities will you give FFP. If just the coagulation abnormality exists and there is no overt bleeding, you will not give FFP. So there are three kinds of bleeds in dengue. One is a mucosal bleed, which is a minor, say an epistaxis or a skin bleed. You really don't need to treat that. The other would be an overt bleed, which is usually either a hematemesis or a vaginal bleed in an adolescent female. And here you need to do the CBC and see if the hemoglobin has fallen down to 8, you will give blood. If there are coagulation abnormalities, you will give FFP. If the platelets are less than 50,000, you will give platelets. And the third is occult bleed. Again, you have to look at the GI system, see if there is a bleed happening inside, and again do a CBC, and accordingly, if the HB is less than 8, blood. If there are coagulation abnormalities, plasma, FFP, and if the platelets are less than 50,000, then platelets. So I think this brings me to the end of the presentation, and I would just end it with these beautiful words from an illustrious son of Bengal who talks about education being the key to a world of endless possibilities. And I must say that I have big thanks to Dr. Gundu sir and Dr. Jaideep and Dr. Khea for keeping the torch burning and for their commitment to education. And thank you so much for your patient listening. Wonderful audience. Thank you.
Thank you so much for your beautiful deliberation. You have covered almost every aspect of it. Thank you so much.
Thank you, sir. Sorry, sir? Achha, implication, medical legal. So, sir, our guidelines, including our national guidelines for children, say that you should give platelets only less than 50,000. So, guidelines are national guidelines. And if you give, and if the child gets some sort of an anaphylaxis or TRALI, acute lung injury, you're going to be in trouble if it's not indicated. So, and understand that thrombocytopenia gives us a sense of doom, but actually mostly children do not bleed because of thrombocytopenia. They may have a minor epistaxis or something. The clinically significant bleeds which lead children into trouble are those who are in prolonged shock with, say, a hematemesis or a vaginal bleed. These children will usually require blood FFP also. Only platelets will not cure it. This is the point I wanted to make.
Yes, please. One.
Thank you.
Ma'am, I have a question. Ma'am, since we are giving fluids crystalloid only, But in neonates, we start fluid therapy. If needed in NICU, we give 10% dextrose. So if neonates have dengue, neonatal dengue, which fluid should we give on the day 1 or day 2? So should we start giving NS?
Who said you get 10?
No, see, if you see the osmolality of neonatal blood serum is same, 275 to 295. So you need to give isotonic fluids only.
Okay, madam. Okay.
So,
wait.
Yeah, Dr. Manglik and Dr. Shakil, 2 questions. Last 2.
If the questions are tough, Dr. Kundu will answer.
It's very simple. Please follow the guidelines.
Yeah.
If you are giving transfusion and if not indicated, then it's an act of commission. And if you are not giving transfusion where indicated, then it's an act of omission. So please don't fall into the trap.
So, last question from Dr. Shakil, please.
Ma'am, if you have a child who has a mucosal bleed, and if the platelet count is above 50, take it around 60, 70,000.
No need
Would
to
you
transfuse. No,
Even
but
if the child is
keep
having
in the
bleeding.
hospital, keep a close watch, do regular CBCs. There's
So
no
even
need.
if there are bleeding?
Yeah, if it's an epistaxis,
Or
it's a
mucosal
mucosal
bleedings.
bleed or a skin bleed, you do not need to transfuse platelets.
Thank you so much. So thank you, Dr. Tapisha. Thank you, Dr. Swapan Rai. It's a pleasure. May I request Dr. Tapisha to please hand over a token memento to Dr. Swapan Rai. The next session will be a bit atypical session. Some issues on dengue. I am not going to reveal it. May I request 2 chairpersons, Dr. Ashok Datta, who is the past president of West Bengal Academy of Pediatrics and also professor of Bardhaman Medical College, and Dr. Arup Rai to please come and chair the session.
Good afternoon. We are in between lunch and the last topic.
না না অনেক দেরি আছে লাঞ্চ আরে কে কে তুই খাওয়ার কথা ডায়াবেটিক লোকের খালি
The speaker is none other than Ritapatha Kundu. Everybody knows Ritapatha Kundu. Nothing to be introduction of our Ritapatha Kundu. He is the main, he and Joydeep and Khyas, the main pioneer of the infectious disease in West Bengal and national also. So I hand over the mic to our co-chairperson, Dr. Professor Ashok Datta, to say a few words.
I think this is the most important topics for discussion now, whether regarding the dengue vaccines. And because of the fact, 2 important things, that antibodies which are produced by the dengue in the first infection, they without any utilizing the second infection is enhancing the reactions, causing severe damage. So what should be the nature of the prevention of the dengue? Whether you should stop antibody to prevent the damage, or whether you should change some messenger RNA so that the viruses epitopes are destroyed. These are the various important points are coming in 2025. Several papers are there. I think Sir will highlight these, and please listen carefully about dengue vaccines. Very important topics today. Thank you. Sir, please start.
Thank you, chairpersons. And it is very heartening to see the whole auditorium full. So there's a serious debate going on whether at the end of the day dengue vaccine will help you or is going to do a problem, because you know the dengue is a disease which causes antibody enhancement. So first I'll explain little bit about antibody enhancement. You should first know, should have a very clear idea. So let's recapitulate a normal immune system. Whenever a pathogen enters your body, there are antigen presenting cells like dendrites, macrophages. They patrol the body. They take the pathogens and goes inside the lymphatic follicles or the red pulp of the spleen. There they present it to the B cells. The B cells, with the helper of T helper cells, they produce antibodies. And ultimately after some time, some of the B cells transfer into memory B cells. So if you encounter the same antigen again, in the future they will produce the antibodies. At the same time, some of the antibody presenting cells also present it to the T cells. And the T cells, they divide into two cell types. One is T helper cells and T cytotoxic cells. The T helper cells helps the macrophages who has ingested the virus to kill it. If T helper cells are not there, macrophages alone can't kill it. And there are cytotoxic T cells, they can destroy the cells which has already taken up the virus. So this is a normal thing which is going on, and also there are certain memory T cells. So whenever you come across the same thing again, this whole thing will be reacted and you are protected. But so your defense contains of three things. One is innate, another is humoral, another is cell mediated. Innate immunity is the antigen presenting cells, macrophages, they have their own capability. They can detect the toll-like receptors in the pathogen which has intruded your body, and they produce cytokines and they produce other things also. They can also able to kill, but they cannot kill all of them. And the cytokines released give signal to the body, so more and more macrophages, more and more neutrophils will come. And ultimately they will go inside and a humoral immunity will take care. Now, the antigens in dengue which are going to cause problem is of few class. Number one is membrane antigen. Number two is the envelope antigen. And number three is the non-structural antigens. Of these non-structural antigen NS1, E and M, these three can be prevented by antibodies. So the B cell producing antibodies against these M, E and NS1 will be able to destroy them. But rest of the non-structural antigens you need cell mediated immunity to kill. So this is how it goes in dengue. Now the innate immunity, as I have told you, the innate immunity, the first line responders, they produce chemical messengers, cytokines alert neighboring cells to infection. The humoral antibody acts against M protein, E envelope protein and NS1 antigen. Antibodies to E protein, antibodies to M and E protein and NS1 antigens. And the cell mediated immunity, the third part acts from here, NS2 onwards to rest. So it is usually non-structural proteins are more frequently targeted. Cytotoxic T cells kills directly the virally infected cells, whereas helper T cell supports macrophages to kill the cells which they have engulfed. Now, a good antibody should have a good affinity and good avidity. What do you mean by affinity? When an antibody binds with an epitope or the antigen, this binding should be very strong. This is known as affinity. And what we mean by avidity? A antigen or an antibody has multiple binders. So the antibody should bind with all of the epitopes the antigen is going to present. It is known as Velcro effect. If you try to remove a Velcro, you will feel resistance through and through. Not that the resistance gives away suddenly. So that happens, so a good antibody should have a high affinity and high avidity. Now what happens during dengue primary infection, when you are infected with first dengue, your antibodies will be produced. But these antibodies will have high affinity, high avidity to the first serotype which has infected you. But after some time, usually months, 18, 20 months after that, those antibodies will be able to give protection against the other serotypes for only few months, and thereafter these antibodies, they lose their affinity and avidity. So cross-reactive adaptive immune response do not confirm a long-term protection. It loses after say 18 months. then if you are infected, these antibodies won't have good affinity and avidity. So for a homotypic infection, if you are supposing you are infected with dengue virus type 2, the antibodies against dengue virus type 2 will persist for a long time, and these are very good quality antibodies, high affinity, high avidity. But if you are infected second time with another type of dengue virus, they will give protection only for a short period of time. Thereafter, the antibodies will go down below the protective level. Not only they will go down, the antibodies will be of not that good quality. So secondary infection with a different serotype poses the significant risk of severe dengue because of a phenomenon called antibody dependent enhancement. What exactly it is? The different serotype, not only the antibodies level will come down, but these antibodies will be of very poor quality. Not only poor quality, it will be also of dangerous quality. How? So, when does it happen? So, risk of severe dengue is highest those who have a previous infection with a different serotype. The risk of dengue may be influenced by sequence of dengue infection. Not all dengue viruses have the same, because if you are infected with, say, dengue type 1 first infection, second infection by dengue type 2, then chances of developing dengue, severe dengue or dengue hemorrhagic dengue like this is 500 folds. So with each different dengue serotype, the risk varies. And dengue 2 serotype is often the most notorious. First infection dengue 1, second infection dengue 2, 500 fold chance to have a very severe infection. So the antibodies you are harboring against the serotype with which you are not infected in the first time are actually enemies, but they are hiding inside your body just like a Trojan horse. So what happens when your body now comes across a infection with a virus of a different type? These antibodies are of different quality, they are of very poor quality. So what they will do, graphically representing, these antibodies will bind the dengue virus, different type of virus, but this binding is not good binding. Binding is such that it will help the virus to get entry into the macrophages in amounts much higher. Very young virus which has not yet matured, they will also gain entry inside the virus, inside the macrophages. Once inside the macrophages, they will produce a severe cytokine storm. This cytokine storm is not going to help you. It is going to put the whole system, your capillaries, you're in danger. They won't give any protection. They will produce a cytokine storm, and there will be enhanced replication, and you will have a very severe dengue. So now, primary dengue infection is predominantly a mild disease and results in lifelong immunity. Primary infection is followed by short-term immunity against infection with the second type of dengue virus. And secondary dengue infection with different dengue serotype carries a high risk of severe disease. So, but does a vaccine can cause this? Because you are giving a vaccine, but the vaccine which is currently coming, if you see the structure of the vaccine, this vaccine has a backbone of dengue 2 virus. But the two important antibody producing M and envelope antigens, M antigens and envelope antigens has been taken out from the dengue 2 virus and has been replaced by dengue 1, dengue 2, dengue 3. So this vaccine contains the antigens of both 4 types of dengue virus, and there is but the NS1 antigen remains same, that of dengue 2 virus. Because of the backbone of this new vaccine, which I'll discuss in detail later, is that of a natural dengue virus. So here what happens, their chances of antibody enhancement is much less. So it elicits a broad spectrum immune response and provides a durable protective immunity from natural exposure to severe disease. So it is capable of producing antibodies, good type of antibodies, almost against all the 4 types. So unlike a natural dengue infection, the dengue vaccine in question does not give rise antibody enhancement. The next important discussion which I'd like to do is, as you know, Japanese bee vaccine is a flavivirus vaccine. Does this vaccine has to do anything with dengue virus protection or deterioration, what? So if you see the epidemiology of the flavivirus, there are 5 flavivirus. Yellow fever we don't have in India. West Nile, though India shows yellow, it is only present in some parts of the forests of Kerala. Zika is not that prominent, but these 2 are very prominent in dengue and Japanese encephalitis. Now, both dengue and Japanese encephalitis occurs only in this part of the world, that is East Asia. If you see, it has gone up to this. The mainland China does not have dengue. The mainland China gives 2 doses of very effective Japanese encephalitis vaccines. In our early days, in 2000s, it was thought that this good Japanese encephalitis vaccine gave protection to dengue. Subsequently, studies, so if you see the flavivirus, all the flavivirus shares the same antigenic background, though there are certain difference in the amino acid sequence. 60 to 70% similar, 30 to 40% different. They have the same M antigen, E antigen and NS1 antigen, and also the non-structural antigen. So the structure of the virus is same, all these flavivirus. So the initial studies, and if you see the Japanese encephalitis vaccine, it is also affects a huge amount of population, but this is a very dangerous disease. 30% of the patient with Japanese encephalitis is going to die. 30% is going to suffer for lifelong disability, mostly neurological disability, and 30% will escape unscathed. Whereas in dengue virus, though the number of cases is very high, the mortality rate is very low, only 1%, but it causes a very much morbidity, anxiety and other things, and it is a very costly disease to have, and most of the cases people do against the hospitals because of this dengue. Bill at the end of the day 10 lakhs, 15 lakhs, 20 lakhs because of the extensive monitoring you have to do. So initial studies, so antibody dependent enhancement, whether this occurred with when you are having an infection with another flavivirus or not, these were the dilemmas. So the first study was done in mice, and mice it was shown that Japanese encephalitis vaccine elicits a strong cross immunity and protection against dengue virus, indicating that inoculation with Japanese encephalitis vaccine may influence the distribution of dengue virus in core circulated areas, and cross protection induced by Japanese encephalitis vaccine against dengue virus. We are very happy that Japanese encephalitis vaccine gives protection. Subsequent study was done in Thailand, where 942 children who were given Japanese encephalitis vaccine was studied for a period of 4 long years, from 1998 to 2002, and of the total number of children, 3,687 included in the study, 942 developed dengue, and it was seen that prior Japanese encephalitis vaccine given, that means prior existence of Japanese encephalitis vaccine neutralizing antibodies was associated with increased probability of symptomatic dengue as compared to asymptomatic dengue. So it said the Japanese encephalitis vaccine doesn't give protection. Not only it does not give protection, it might increase the severity of the dengue. Further studies were done, and it was shown that this problem is with all the 4 types. There is no difference between the dengue serotype 2, 3, all the 4 types showed more chance having severe disease if given previous Japanese encephalitis vaccine. Next, a study was done in Nepal. Nepal is such a country where immunity against Japanese encephalitis vaccine disease is high, because in Nepal they give 2 doses of Japanese encephalitis vaccine, and a cohort of 46 participants was studied for 3 dengue seasons. I'll record 1 or 2 minutes time. 3 dengue seasons, and the ultimate conclusion was that the data indicates enhanced MC, degranulation and augmented dengue disease in patients with Japanese encephalitis immunity, patients especially with intermediate titer of Japanese neutralizing body. So mid-range neutralizing antibody titers were responsible for more severe dengue. So the results that a waning immunity to Japanese encephalitis vaccine should enhance the severity of the dengue disease. So it was recommended to maintain a strong immunity against Japanese encephalitis vaccine, so that your dengue, you don't have a severe dengue. So ultimately the take-home conclusion is there is an interplay between both Japanese encephalitis and dengue viruses, but because of the incidence of hospitalized illness in dengue hemorrhagic fever is lesser, the duration of symptomatic disease is also related, hence it is crucial to give both the vaccines. So whenever the dengue vaccine will come, it is a must that if a child receives Japanese encephalitis vaccine, he should have a high immunity, and also you should give a dengue vaccine. So third point I come, should dengue vaccine be given in hospital settings only? Why? I was reading the epidemiology WHO position paper on May 24 about dengue vaccine, and there I found at the end of the paper a small number of anaphylactic reactions have been reported in vaccinees without a history of anaphylaxis. WHO recommends the vaccine in question, Takeda vaccine, be administered only in settings where anaphylaxis can be treated. Until more data are available, all vaccines should be observed for at least 15 minutes following. You expect anaphylaxis after giving any vaccine, but what is the difference between the two? The difference is that when you have an anaphylaxis, your initial symptoms will be skin rash. You will find difficulty in breathing. There will be tightness in the chest. Thereafter, weak pulses, shock, and other things. And there are 2 ways how do you assess an anaphylaxis. One is the Brighton collaboration, another is World Allergy Organization anaphylaxis guidance. And the rate of anaphylaxis is calculated per million of doses, that means per 10 lakhs of dose. And it is expected that a vaccine should have up to 10 per million doses. You should not have anaphylaxis more than 10 per million doses. But in the vaccine in question in Brazil, it had 36 cases of anaphylaxis per million. And next question. Next question, why anaphylaxis rate was higher in Brazil? The reason that was found out due to duplication of the recording. The people who developed anaphylaxis was both recorded according to the Brighton scale and also recorded according to WHO scale. So the same person has 2 different scales, and so that means that the mentioned formula was twice, so that's the reason why it was high. Number 2, in Brazil there was extramural vaccination. Vaccination was given in the shopping malls, vaccination was given in the schools, vaccination was given in the community halls, not in the hospital setting or setting of the doctor. So this contributed to the higher rate of anaphylaxis because nobody cared to ask how the patient was doing before vaccination, and nobody cared to ask the patient should wait for some time for vaccination. So ultimately what the Brazil government has suggested, none of the reported post-vaccine anaphylaxis case result to death. So Brazil Ministry of Health maintained to continue the Takeda vaccine. To date, based on the data obtained through post-marketing pharmacovigilance, the benefit of vaccine is much higher than not taking the vaccine. So the recommendation given by the Brazil government is to train the whole healthcare profession about anaphylaxis, post-vaccine observation up to 30 minutes. A history of anaphylaxis to any component of the vaccine is a contraindication. And if anaphylaxis occurs, then you don't give certain. So even if the anaphylaxis rate is little bit higher, because the reason I have explained to you, it is high. So under no circumstances you should deny a vaccine thinking that it might cause more anaphylaxis. So with this, I thank you. These are the three important issues I found.
You told that this particular vaccine, Takeda vaccine, will produce homotrophic antibody against all four.
Now, homotrophic antibodies, especially against M and E antigens. All four, because they contain four.
What about the cell-mediated immunity? It is only antibody-mediated. What about the cell-mediated?
Because the structure, the main structure of the vaccine has a dengue backbone. Unlike the previous vaccine which had a yellow fever backbone, the antibody cell-mediated immunity against this is also good. Because the test of the pudding lies in eating. When I'll tell you the vaccine, what are the side effects, how they fare, you will find they have good antibody, cell-mediated immunity also.
Sir, another thing. Last week it came that the Brazil have already phase 3 trial is already done, and they came up with a vaccine with a least anaphylaxis. And
Brazil is using this vaccine only. They will come. Actually, I'll talk today about this because the new vaccines of phase 3, phase 4 trials are, I think, I don't know whether it has been, at least as far as I know, that the trials are not yet complete and not yet published. So we'll have this.
Sir, Dr. Subhasis, there are 4 vaccines declared in 2025. Different 4 vaccines, new vaccines. So they are under trial. Sir has rightly said these are under trial. Now remember, whenever there is any production of antibodies, they must first, they should catch up the cells. Cells should catch up the antigen first. So T cells will be there initially. So whenever the T cells are there, T cells will give like 2 components. One is memory cells, another is B cells producing the antibody. So sir rightly said, though it is the antibody productions are there, but T cells will be there for further use. So this is the basic of your first question. In the second, there is some modification of messenger RNA and others, the antibody induced by the cells, and the 4 vaccines are there under trial, and they are not till finalized now. Thank you.
Thank you.
Thank you.
Thank you so much. So may I request the chairperson to please hand over a memento to the speaker, Dr. Ritobroto Kundu. Once again, just after the break, sir, please.
Thank you. ছবি তোল ছবি তোল কি আশ্চর্য
And may I request Dr. Ritobroto Kundu to please hand over memento to the chairpersons. So the next, we move on. Next, we move on to a very important aspect, because complicated dengue is a big challenge. If a child develops complications of dengue, then it's a challenge to the physician, it's a challenge to the healthcare setup also. May I request Dr. Suhas Prabhu to please moderate this session, and may I request the experts, Dr. Tapisha Gupta, Dr. Joydeep Das, and Dr. Chandrai Bhattacharya to please come as the experts for this very important session on the management of complicated dengue. So the experts, please.
Okay, thank you again. I think this is the second time I'm standing in front of you, so no, I want my panelists there first. I can't ask questions without that. Okay. So I'll start off with a panel discussion on complicated dengue. The first question that came to in my mind is, what do you mean by complicated dengue? What is that? And see, we know the usual course of dengue fever is you have fever, systemic symptoms. Of course, you also have asymptomatic dengue also. And then in some cases, you have this third spacing AD effect, plasma leak, its consequences, bleeding, platelet drop, everything. That's the usual dengue. That is not complicated dengue. But very occasionally, the dengue virus can affect other organs of the body or have very unusual features. So this is what I have taken to mean is complicated dengue. We're going to discuss some cases where this happened. Now, it's not just me, even WHO is talking about this. You look at the 2013 guidelines. This was shown to you earlier about probable dengue and dengue with warning signs. And what we really look at is severe plasma leakage and severe bleeding is what we expect in about 4 to 5% of cases. But if you look at what WHO has mentioned, also talks about severe organ impairment, and this is mentioned at the bottom as very high liver enzymes, CNS symptoms like impaired consciousness and seizures, and also involvement of heart and other organs. So I'm going to talk about these cases which actually WHO has also included as severe dengue or complicated dengue. So let's start with the first case in which I am going to talk about an organ that is affected, and that's your hemopoietic system. We don't really think of the hemopoietic system as a system, but it is an organ. And in fact, as Osbert Sitwell says, blood is that very fragile scarlet tree that we carry within us. So it's very fragile. So lots of problems can happen there. We of course know that low platelet count can happen as part of the original dengue complication of ADE, but I'm going to talk about something beyond that. This is a 7-year-old boy, and I must confess that these all cases have been given to me by my panelists. So I thank you again for that. They are very nice cases. 7-year-old boy, fever for a total of 7 days, fever and anorexia for the first few days with flushing. This was mentioned in the morning also. You can see the typical flushing with the fingerprinting. NS was positive on day 2 with low normal counts on CBC. So what would you advise this patient? Who can take this? Anybody wants to take this?
So here, any fever who is in the verge of more than 7 days is a pinch of salt. So fortunately NS1 is positive and there is no localizing sign, but one thing is there is anorexia and vomiting. So this is a danger sign, especially
this was in the first few days.
In the background of NS1.
First few days, not now.
Yes, so 7 days. Its total duration is 7 days.
Yeah.
So I will definitely ask the mother that are there any evidences of danger sign, pain abdomen, your urine output, your paleness. So any bleeding from any orifice.
Yeah, as doctors rightly said, we should be thinking, of course, about the standard ADE-like complications with vascular leak. But I think this is a little bit too late for that. We normally see that between 5th, 6th, 7th day. It's a bit too late. It's 8th day now. The second thing is typically those kind of things, sir, will happen when the fever is gone. Now this patient, the main thing is the fever is still persisting after 7 days.
Yes.
So this is the time when you think of some other complication, not your standard dengue kind of thing. So anyway, what was done earlier was same thing. Paracetamol, high fluid intake, but now again he has come. This time you asked for the symptom now, sir, I'm telling you. Now again he has vomiting and poor intake, lethargy, and he has some bleeding from the gums.
Yes.
So now what are your thoughts?
Yes, so bleeding from gums is again a marker of danger sign, and again is categorized by WHO as severe dengue. So I have to check the PCV and also the platelet.
Okay. So would you think of complicated dengue? That is the question.
Yes, it is a complicated dengue. It is a severe
And again,
dengue.
this is not because of the vomiting, poor intake or bleeding gums that can happen in your standard dengue with ADE. It's only because the fever is gone on for more than 1 week. I think that's a very important clue. If the fever lasts more than 5 or 6 days, then you should start thinking of some problem. Okay, let's look at the case further. The child is febrile, irritable, there's some doubtful icterus, the pulse is 118, which is a bit high for a 7-year-old. The BP is 86 by 54, the CRT is just borderline 3 seconds. Slight tachypnea with retraction, but the chest is clinically clear. There are some petechiae present, obviously there's bleeding from the gums also. And this child has now hepatosplenomegaly. CNS shows no focal deficits. Can I ask Dr. Chandre or Dr. Tapisha, you want to take it? Yeah.
So just wanted to say,
What
sir,
are the possibilities now? That's the
So
question.
now we know that this is a sick child. He has icterus, the sensorium we are not very sure, has hypotension and some mild tachypnea. And what is really raising a red flag here is a spleen of 3 centimeter we usually don't expect in a child with dengue. And of course hepatomegaly. So we have to now think of, obviously this is severe dengue, and we have to think, what if there is a co-infection, is there a malaria happening alongside, or is there something else?
Whether there's a secondary infection, whether there's a co-infection, whether this is a particular complication of dengue.
Very good.
There is definitely severe dengue, there's no doubt about that. But what exactly is causing the fever for 7 days to extend? Dengue fever is not supposed to last for 7 days with splenomegaly. So there's a
Absolutely.
possibility that something is happening, as sir mentioned, with the hematopoietic system.
Absolutely right. In this case, there is no doubt there is dengue because the NS1 was positive. So one thing you think of is complicated dengue, but don't close your mind to something else that is happening along with this. Maybe some simultaneously some malaria because there's splenomegaly or some other bacterial infection as a complication. Okay, so these are what you would think of: prolonged illness due to severe dengue, some secondary bacterial infection or malaria. Dengue shock syndrome, would you think of? Generally, you don't get splenomegaly there. And one of the things you would think of now is HLH. So let's see, what investigation would you like to order keeping these thoughts in mind? This is your possibility. I would also include malaria there. So what test would you like to do?
Yes, so fever more than 5 days, hepatomegaly, and there is bicytopenia. So this is a clinical clue that probably I am dealing with some HLH.
Yeah,
or
this is what you're thinking of.
Yes,
Don't
I am
exclude
thinking
malaria
of. So
or bacterial
I'll
infection.
rule out one after another.
So what would you like to do?
Yes, I would like to do a blood test with which tell us to rule out the HLH profile. So I will do a ferritin, I will do a hemoglobin, I will do a platelet, and also I will do the PCV.
Okay.
And
So, Dr. Chandra, would you agree with that,
yes,
or you
sir,
also want to look
especially,
at other
yes,
things
sir.
first?
In case of HLH, due to hypofibrinogenemia, ESR will be low, CRP will be high.
Yeah, Dr.
Yeah,
Chandra.
for all the possibilities, yes, whether there's a co-infection, whether there's a malaria, whether there's a typhoid, whether there's a secondary bacterial infection, all those I'll send. I'll send off cultures, I'll send off count, I'll send off a CRP, I'll send off a ESR.
Correct.
And along with that, I will check ferritin, fibrinogen, LDH,
Fine.
D-dimer.
Okay. Dr. Tapisha, you agree? You have anything to add?
Absolutely agree. Yeah,
Okay,
first a
so-
CBC itself will give us a lot of information.
Yeah, and what would you give treatment in the meanwhile while you're waiting for these results?
While we wait for the results, we have to make sure of the hemodynamic stability so that the bleeding stops. If there is any transfusions to be given or not based on the counts and the coag parameters, and give antibiotics, cover infections, and wait for results to see what the final possibility
Would
is.
be safe to start an antibiotic even though
Yes.
HLH is on your mind, because you can't
Yes.
not really ruled out a
Yes,
bacterial
I'd like
infection.
to add one thing.
Yes,
so
sir.
it is for all fevers. Any fever more than 5 days or in the window of 5 to 7 days can cause HLH. And if you suspect, the suspicion starts with the clinical finding, because clinically I can pinpoint there is bicytopenia and your hepatomegaly, and here it is splenomegaly. So, child will be very sick. So,
Correct. Child is very sick.
yeah, he is very sick.
But it could still be falciparum malaria.
Yes, so if you, point is to rule out HLH or other.
Okay, fine. No, I mean, while we are talking about dengue today, so doesn't mean if the patient comes to you clinically, you must say that I would also think of other things. Right? And there can be co-infection with a bacterial infection or even with malaria. Both diseases happen in the same season. So I think it's prudent to really think of that.
All infection can lead to HLH.
No, but if he has malaria, sir, you have to treat that in addition to the HLH. So you'll have to look for malaria. That's what I'm trying to tell you. Okay, so anyway, this is what was done. And you are coming to that point, This is the repeat counts now. The platelet have dropped to 28,000. There's deranged liver function, as you can see. The CRP is 66, the ESR is 8, blood culture sent. Result is awaited. So, now what are your thoughts?
So there is
Yes,
high
I think the
CRP,
doctor already mentioned
high
that.
CRP, low ESR, liver enzyme involvement, uh, bicytopenia definitely, hemoglobin is also on the lower side.
Right.
So tracking towards pancytopenia, HLH is a very strong possibility here. And as sir has already mentioned that cultures have been sent while we await, we have already started with antibiotics, fluids and all supportive managements.
Fair enough. And if it was a typical usual dengue, the hemoglobin should have been rising, not going down. Yes, antibiotic.
As per hospital policy,
Yeah.
usually third generation cephalosporin.
Yeah. No,
No,
we are not
preventive
thinking, we are talking
coverage
about
of
bacterial
malaria
sepsis.
scrub is not there in the guideline.
If there's malaria detected, yes, you will treat as for malarial guideline. Okay, so anyway, this is, doctor already mentioned what tests you do to diagnose HLH, and we did that. Ferritin is very high, triglyceride. We saw one case in the morning, so I don't think we'll go much into that. It was discussed in the morning also. Decreased fibrinogen, elevated LDH, and bone marrow was done, showed hemophagocytosis. So there's no doubt that this is HLH. So how do you make a diagnosis of HLH? Dr. Tapisha, we have guidelines on, I think this was also mentioned in the morning.
Discussed in the morning. So in this child we have fever and splenomegaly, and we also have a positive ferritin. So more than 3,000 is quite indicative, although more than 500 is a cutoff. And in addition to that, we have the criteria also being fulfilled. That means fibrinogen and triglycerides.
Right. So like 8 factors are mentioned here on the left, out of which 2 are not easily available. Number 6 and 8 are not available. So we are left with actually 6. And of those 6, I mean the others are, of course, one is of course prolonged fever, which this patient has got, and the other things are pretty easy to do. Now that leaves us with only the bone marrow, and you might say that yes, it's not always possible to do bone marrow in the periphery and detect it. If you are lucky, you can see hemophagocytosis in the peripheral smear. So if you don't have somebody to do the marrow for you, ask somebody to look for hemophagocytosis. Very rarely it can be present. But the point is, even if 5 out of 8 are present, you have made a diagnosis of HLH. So you don't really need a marrow to show hemophagocytosis. Our patient showed it. And this is the pathophysiology of HLH. Would anybody like to discuss this, Dr. Chandra? Okay. Okay, this was discussed in the morning, so we'll skip that. It's essentially an overactive
and inflammatory cascade.
Yeah, an cascade that doesn't stop and keeps on going on. So to come back, HLH following dengue is not very common. So when do we really think of it? There are very small clues. On clinical ground, there are certain clues, and on laboratory parameters. Sir, you were talking about them earlier also. I'll ask you only the same question. When do you suspect HLH in a case of dengue on clinical grounds?
Yes, fever more than 5 days,
Correct.
universal criteria, hepatomegaly and bicytopenia. Because clinically you can say the pallor and clinically you can say the low platelet.
Correct.
So,
right.
and laboratory low ESR. I do not need ferritin or your triglyceride or bone marrow. On this basis, I can
Suspect. But you are not going to treat unless you prove it.
Yes, yes.
Because the treatment is like, I mean, it's quite intensive. So high CRP, low ESR is mentioned there, and what is the reason for that, sir? Can you explain why you get a low ESR?
Yes, because fibrinogen is less.
Okay, the low fibrinogen drops the ESR. So high CRP, low ESR, prolonged bicytopenia, and very important, multi-organ dysfunction like this patient had. There's liver involvement, there's splenic enlargement, and so on. Okay. First of all, the fever will not be continuing in dengue. When the patient crashes in dengue, that time the fever is gone. And that's the time when your hemoglobin is going up, here the hemoglobin is going down. So it's quite different. So yeah, you can have a biphasic fever and the second phase does not subside, or the initial phase only continues for 7-8 days like happened in this patient.
Many of the severe dengue with refractory shock and bleeding dengue are actually complicated with HLH. So it is kind of an overlapping spectrum. These are not always discrete entities. If the fever is persisting, there are multiple. We have had so many in last 3 years. If we see that it is absolutely. No, no, definitely. But if there's a refractory kind of a severe dengue, we always send off HLH. And most times it is positive than not.
It is high index of suspicion.
That's the most important.
Yes. If you do not suspect, you lose the baby.
Dr. K, I think if fever
Because
is
it is
continuing,
treatable.
Yes,
you think of
absolutely.
HLH.
See, the
But otherwise,
dengue,
they're very overlapping symptoms. I agree. Lots of people have said the symptoms are overlapping. I
Yes.
agree. But my question to you, Dr. Chandra, is if you are doing testing and you are finding out that there are a fair amount of HLH in all these patients, what happens to those if you don't test and don't find out? What happens? Those patients, all what happens to them?
If there is significant HLH, it is not the infection that is killing the patient, it is the inflammation that is killing the patient. So it was previously thought that
stop the inflammation.
secondary HLH for whatever infection, if you treat the infection, the HLH will go away. That was the concept to start with for secondary HLH, not for primary. However, nowadays it is said that the infection's effect is almost over. The inflammation is continuing unabated. Even in secondary HLHs, like in dengue HLH, you may have to treat with steroids.
Okay.
If you want to salvage
So,
patients.
okay.
And the age is less than 1 year, you may not know, it can be genetic HLH. So
Correct.
that's why your window should be open, otherwise you will miss.
No, but the point,
Yes,
yes,
in
it
ICH.
can be primary. And so, but the point I'm trying to make is that, as Dr. Chandra rightly said, and it's my opinion also, that you do get a small amount of HLH-like features in a many patients. They are mild and they are self-limiting once the primary infection is tackled. And therefore, you can get away by not diagnosing HLH and not giving any specific treatment. That's what happens in a fair number of cases. But yes, there are some patients who become very sick, and then you have to make a diagnosis and you have to treat. Dr.
That
Tapish,
is
how
why
do you treat?
spontaneous remission of fever is a very good clinical indicator.
Yes,
If there
all
is
the symptoms
spontaneous
go away.
remission
That
of
means the
fever,
patient.
yes, mild HLH is taken care of.
Dr. Tapish, how do you
Yeah.
treat HLH?
So, sir, treatment.
I don't
we
think we'll go into details.
No,
This
I'll
is
just
dengue,
make a
not-
short comment. Yeah, so there are treatment protocols are there with etoposide, etc.
Yeah.
But I think steroids, dexamethasone does the trick. And the cases that we have treated with dexamethasone for a total of about 4 to 6 weeks, and
Yeah.
they've done very well. Within 48 hours, the fever came down.
Yeah, almost all the patients will respond to steroid alone, and some patients I've used etoposide on the advice of my colleague, Dr. Nitin Shah, who works with me at Hinduja Hospital.
So,
4 to 6 weeks is correct. You need to taper after 2 to 3 weeks. Yes,
So,
you have something to add?
for us, we have, in our hospital, we have had a sizable number of dengue HLH cases in the last 3 years. Most of them recovered with steroids. Etoposide we have not used. There has been 3 cases of very severe dengue HLH causing MODS with ferritin more than 1 lakh. We had treated them with anakinra.
Okay.
We have had reports from our institute as well.
Okay. So anyway, there's a revised protocol talking about cyclosporin, but I'm not a hematologist. Huh? No, usually they recommend dexamethasone
It's the
because of
protocol.
better
Dexa is
CNS
the
penetration if it's a
protocolized
young
steroid.
child.
10 mg
But you
per
can
meter
use
square.
methylprednisolone in an older child. Because otherwise you have to add intrathecal drugs, because methylprednisolone doesn't penetrate into the CNS as well as dexamethasone does. So it's always better to use dexamethasone. And of course, as Dr. rightly said, if it's an infant, you don't stop here, you investigate for genetic or primary HLH and you do the genetic test. Perforin or whatever else. There are 5, 6 different types of primary HLH. Can we go to the next quiz or any questions on HLH? No.
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 In fact, what happens is within 48 hours, the platelet count starts rising as the HLH gets suppressed. So, yes.
Sir, we have done a study
Yes.
of the secondary HLH.
Yes.
And we have given a very short course of the methylprednisolone followed by oral prednisolone. And we just took it off within 3 to 4 weeks. That is published, and we have also presented the case in the West Bengal Academia Pediatrics, the dermatology chapter. And it was well accepted. So for the secondary dengue due to infection, as well as if you just take care of what she has pointed out, a very short course of steroid will save the children.
Yes, you have to suppress the inflammation.
You're right.
So,
If you see here, no, if you look at this, there's a very wide range. Between 4 and 8 weeks is
2 weeks
almost double
also.
the length. So it actually depends, as the panelists has rightly said, on what is the response. If the response is good, the fever goes away in 2 days, the counts rise after 2 weeks, I would be happy to reduce after 2 weeks. But some patients do need for longer time. The protocol says you can give up to 8 weeks. So it's variable. You don't have to give 8 weeks. I agree with that. Okay. William James said, is life worth living? It all depends on the liver. So can the dengue virus affect the liver? Look at this case, 9-month-old boy, month of August, fever for 4-5 days. Some mother says, yeah, there was a little bit redness on the trunk and limbs after the next day. But she went to a doctor who did not do any tests, only symptomatic treatment was given, no tests were done. On the 4th day, the child is now vomiting, has abdominal pain, irritability, is also drowsy, which is a little bit unusual for your dengue ADs. Most dengue ADs appear alert, although they are almost in shock, unless they actually go into shock. And now he has one episode of hematemesis and reduced urine output. So, which panel is going to take? Okay, let's talk about the examination, then I'm going to ask the question. You look at the patient, he's afebrile, he's drowsy, appears confused. Look, the boy looks confused there. His tachycardia, the BP is on the lower side, mild tachypnea, icterus is present, you can see that very clearly. Hepatomegaly, which is tender, spleen not palpable, and there's some pedal edema. What are the possibilities?
Yeah. So we know that there is icterus, also there is some alteration of sensorium, and again this is a sick child with the BP borderline. So we have to think of hepatitis also, viral hepatitis, and of course...
Acute viral hepatitis would be the first thing. I mean, so just because I'm standing on a dengue platform, that's not the first thing I'm going to think of. Yeah, acute viral hepatitis is one. Anything else? Dr. Chandra, would you think of falciparum malaria?
Multiple infections can cause
Yeah,
significant
lots of
liver
patients.
involvement. First is the hepatotrophic viruses, which are like the common ones. Hep A in the season,
Yes.
definitely. Malaria,
Yes.
severe enteric, leptospirosis. Dengue actually comes a little bit lower down in the
Yes,
spectrum.
I put it
Though
last
it's
in
a
the
dengue
list. I agree
panel,
with you.
It is lower down in the spectrum. The diagnosis here is dengue, but it is lower down in the spectrum.
You think
so
of severe
we rule
malaria.
out all
you,
of these infections.
You also think in Mumbai we think of leptospirosis in the month of August.
Happened
because you
here
get
as well.
Yeah.
Happens here as well.
So you must think of, because leptospirosis can also affect the liver, you can get jaundice, you can get all the features that you have seen in this patient.
Scrub.
Scrub typhus,
enteric.
yes, I would add that, but I don't see it in Bombay, so I didn't think of it.
We have an outbreak
You do see, okay.
every rainy season.
Yeah,
And
I would add
complicated
scrub
enteric
typhus.
as well.
If the epidemiology warrants, you would add
Yes.
it, definitely.
Yes.
Okay, so what investigation will you do? You have a long list of differential diagnosis. Now, unfortunately, in this patient, like in the first, nobody had done the NS1. So you didn't know in the beginning it is dengue. So now you think whether it could be.
So provisionally fast diagnosis is acute infective hepatitis. So we have to rule out that with IgM hepatitis A and your bottom line hemoglobin, PCB, platelet and WBC. And definitely they will give us information and along with liver enzymes. So if there is high enzymes, then probably it is in acute infective hepatitis, already discussed since morning.
Yeah.
So to cut short, so I have to definitely rule out dengue here, along with your, I will say, scrub, malaria, everything.
Correct.
So within,
you'd like to rule out. So you'd like to do a
yes, within fast
malarial antigen test, a smear for malaria, blood culture,
Yes.
and test for leptospira, whatever are available. In
so,
Mumbai, we have
IgM
PCR.
hepatitis and everything will come in first 24
And
hours.
how do you diagnose the dengue?
Yes, dengue.
How do you say it is dengue? We said all the rest. What about dengue?
Yes, dengue, if causes your rise of liver enzyme and icterus, then it is organ failure and it is a severe
Now, how do
dengue.
you- yeah.
And here we have to do this, first of all,
serology, because this is day 5.
Yes, day 5, we have to do serology plus NS1. If you are lucky, you will get both or IgM only.
I think it's too late for NS1. So this is the patient where I would look more at the IgM and
Serology,
IgG,
yeah.
possibly the IgM. And what interim treatment?
Yes, interim treatment is absolutely supportive.
Yeah.
And
You won't start an
yes,
antibiotic?
if it is
Of course, it
prolonged
can be
T-time,
sepsis.
yes.
Which antibiotic
Sepsis
would you
enteric.
prefer?
Again, we have to go for third generation cephalosporins. There is something. there is something which I had to recently read because I had a child with jaundice with a significant amount of fever with no cause I had for diagnosis. Ceftriaxone versus cefotaxime actually doesn't cause any difference in liver enzyme derangement. It does not. Only, 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 only it causes more cholestasis, ceftriaxone, but not liver enzyme derangement per se. It is very rare.
No, I would
It
agree
can
with
still
that.
be
It's
used.
more causing cholestasis rather than liver derangement. So it's okay
But
to
I
use.
think, sir, if we look at the
Except in a
epidemiology,
newborn, except in a newborn where we worry about bilirubin.
so perhaps treating
Causing
a rickettsial
encephalopathy. Yes.
infection would be a better choice as a,
No, but I think the
if
beta-lactam
we
is
look at the
important.
epidemiology. Yeah.
The beta-lactam is important if you want to cover leptospirosis. But if you're thinking of scrub typhus, your beta-lactam is not going to cover that.
Yes.
So then you may have to use
One
more
may
than
have
one
to use-
antibiotic because you won't have an antibiotic that covers both leptospira and, yeah, you can add doxycycline. Okay, fine. But anyway, that's interim treatment. So anyway, let's see what we got. Hemoglobin 10, WBC is on the lower side, platelet 42,000. Check for malaria negative. Enzymes are quite high in thousands. With high bilirubin 6.4, direct 2.1. INR is deranged, so definitely there's bad liver involvement. Creatinine is 1.4. CRP is 12, blood culture sent. So I think we have ruled out now malaria. We've ruled out a bacterial sepsis, unlikely, if the CRP is only 12 and this kind of picture. Okay, so we end up with either viral hepatitis, leptospirosis, or a complicated dengue. So what other investigation now? I think you already told me, so let's look at that. We did all these things in this patient. Not we did, they did. They're not my patient. Glucose was 56. Why would you look at glucose? Why was glucose done? Chandri, I think is your patient.
Not my patient per se, my hospital's
Yeah, okay.
patient. Yes, of course we send sugars, electrolytes, create LFT for
liver
all sick
failure.
patients you have to do anyway.
So you
And
look for
here
hypoglycemia.
the particular, it will be a kind of a warning sign because the reports that we saw, INR deranged, LFT's enzymes are sky high. So we are dealing with a ALF basically and that causes severe hypoglycemia, must be corrected.
Correct. Very true. And of course, electrolytes, you look for hypokalemia. You look at the ammonia because you want to worry about hepatoencephalopathy. Viral marker sent, sir, like you said, all negative. And you mentioned hepatitis A, but I would send at least hepatitis A, B, and E. That's what I would do, not just A. Because we do see a fair amount of hepatitis E also in Mumbai. I don't know whether, and a lot of our children have received hepatitis A vaccine, so they are unlikely to get hepatitis A. And why hepatitis B? If you talk to any hepatology, they say anytime a patient has jaundice, you must take the opportunity to make sure he is not a hepatitis B carrier, only from that. I'm not saying this is hepatitis B. This is a recommendation because we know that hepatitis B vaccine is given routinely, but there are some patients who are non-responders and they need additional boosters. So from that point of view, even hepatitis B, I would do, that is a HBsAg. Okay, then dengue NS1 is negative, but IgM is positive. NS1 negative, no surprise because it's after 5 days. So IgM is positive, dengue IgM. You did an ultrasound, it shows hepatomegaly and some ascites as you can see there. So what's your diagnosis now?
This is
hepatitis?
dengue ALF. This is dengue hepatitis, not even that. It has caused acute liver failure.
I agree.
Yeah.
Yes, no, not just hepatitis, liver failure. On what ground you say that, ma'am?
Sorry, ma'am?
On what ground you say it's failure?
Yes, INR deranged. It's already
INR
critical
deranged.
criteria.
Altered sensorium
Altered
already.
sensorium is there.
And
actually, we'll have to send off ammonia to see.
Ammonia we have done.
Yeah,
Is 62.
to see how much it is. Yeah.
Is 62. And one more thing, of course, which is not done yet, I don't know, I think you didn't send me, I would look at the albumin. Remember, this patient has pedal edema. He is probably hypoalbuminic, which is also a sign of acute liver failure.
Directly.
From albumin, pre-albumin is most important here.
Yeah, so, but
because
it's
very
not
early.
here, but the pedal edema is an indicator that possibly he has low serum albumin. Okay, how do you manage this
INR is
patient?
deranged here already.
How do you manage this patient? Who will
It
take
is
it, Dr.
absolutely
Tapish?
symptomatic management.
Okay.
Yes, symptom maintenance, electrolyte maintenance of IV fluid, and all supportive therapy.
Correct. There's no specific treatment separate like any other liver failure. This patient also has hematemesis, you might have to pay attention to that. Otherwise, the standard hemodynamic status management is mainly supportive till the patient responds and recovers on his own, just like any other viral hepatitis. So you maintain the cardiorespiratory. Yes. Yes, oral antibiotic,
All-
ball
it is- it
preparation,
also
lactose, yes,
includes
all that.
in the suppurative,
Let's
yes.
not get into treatment of acute hepatic failure. I think that's not the management. And rarely, of course, some patients might need a transplant. Did any of your patients need transplant?
So sometimes we've also tried NAC infusion.
Okay.
N-acetylcysteine
Yes,
infusion.
N-acetyl
It's
infusion
also
can go.
recommended in the position statement of, in the Society of Critical
Fine.
Care Medicine.
Okay. Let's come to the third case now.
Sir, our patient did not need transplant, but two of our patients did require CVVH, plasma exchange, etc.
Okay, but they all recovered.
Yes, they're
You
surviving.
please tell everybody where's your institute. We can send all your patients.
Please, sir, this was
It
only
is
2
Apollo.
kids. It's only
So-
2 kids, sir.
So you have to consider pocket also.
But you have Dr. Sibal there in Apollo waiting to do transplants. Okay. You also have a transplant team here?
Yes, Dr. Roy's team here.
Okay.
Transplant.
It's Isaac Asimov who said the human brain then is the most complicated organization matter that we know, and I think this is absolutely right. And something as complicated this can be badly damaged and deranged by a simple virus. 5-year-old girl, fever for 4 days, initially no focal symptoms. On day 2, luckily for us, so that we can say we are in the dengue symposium, NS1 done is positive. Symptomatic treatment, high fluid intake advised, but on day 3, she developed severe vomiting and headache. And very next day, she developed two convulsions and then became unconscious. There's no history of any prior neurological illness. So what do you think of? Okay, let's take the examination first, then I will ask my panelists. On you examine, there's altered sensorium. She's not responding well to verbal stimuli. We have a GCS score there. High fever, tachycardia, BP is fairly okay, 92, a little on the lower side. Irregular respirations with intermittent apnea. Pupils are reported as equal reactive, but generalized hypotonia is just limp. But there are no focal deficits. There's some hepatomegaly. And nothing in the chest, cardiorespiratory findings. So Dr. Tapisha.
Yes, so sir, we have to think of dengue encephalitis because there is fever, there is a positive NS1, there is altered sensorium, and of course we have to rule out other viral.
Okay, so I think earlier we talked about an AES. Who was it, Dr. Rita Pratap spoke about? Here, fortunately, we don't have that big differential diagnosis because we have an NS1 positive. If NS1 was not positive, we would have referred to Dr. Rita Pratap's list of AES. So this is, of course, this is one of the rare inclusions in AES, dengue encephalitis. So can I ask the question is, how many ways does dengue virus affect the brain? Somebody can come with an answer?
Yes, so it can cause direct cytopathic effect, generalized edema, or it can cause white matter hyperintensities, or it can cause deep subcortical structures like your basal ganglia.
Correct.
There are 3
No,
mechanisms in
yes.
which dengue virus can cause an encephalitis.
Right.
One is, as sir said, direct cytopathy due to the viral replication.
So an actual encephalitis,
That is
invasion of the brain by the
encephalitis.
virus, yes.
And it can be immune mediated as well.
Right.
That is number 2. Number 3 is dengue trigger demyelination. These are the 3 sorts of encephalitis and encephalopathies that dengue can cause.
Correct. Now about this acute viral encephalitis, does it look somewhat like Japanese bee or what? After all, they are brothers. They are both flaviviruses. Do they look the same?
No, Japanese bee, like the picture you have given, unlike Japanese bee, because Japanese bee affects the posterior circulation, lots of dystonia. But here there is no dystonia or tone changes, it is global. So when
Dystonia
it is
is
global,
very
no
classical of
focal,
Japanese bee.
yes. When it is global, no focal, no cranial nerves. So it is generalized pathology, probably generalized edema, and it causes your sympathetic drive and your rise of blood pressure, rise of tachycardia and low BP.
Correct.
Sir, I really don't know how we can differentiate on clinical examination, but definitely MRI findings are quite similar.
Correct.
In both Japanese
Yeah, we
as
look
well
at the
as
MRI findings.
dengue. And
So-
the difference is that in dengue you may get hemorrhages which you won't find in JE.
Absolutely right. So in JE, generally you don't get CNS hemorrhage, which you do get in some cases of dengue encephalitis, and that's because of actual necrosis in the brain. So it's something they call acute necrotizing encephalitis, or ANEC, which is an extremely dangerous condition. Let's see if our patient had that. We're going to find the tests. But one more point I wanted to make about the way dengue affects the brain. The viral invasion will occur early, like in this patient. 4th day, 5th day is when you would see that kind of thing. And in fact, the ANEC typically happens within the first third or 4th day. It's very rapid.
Early.
It's on the third day, typically, like this patient. Third, fourth day, she suddenly becomes very sick after appearing. That's typical of an ANEC. You need to be aware of that because it requires a different type of treatment. There are some patients who will develop an encephalitis, low grade or moderate grade with seizures. They generally recur. ANEC has a high mortality, and that's the one that comes early. The autoimmune mediated ones that Dr. Chandra mentioned typically occur after a week, and they can come like an ADEM or some other demyelination kind of thing, and they present later. So the timing is different. In this patient, I would not think of the autoimmune type because it's only third day, fourth day. We just said the IgM doesn't become positive till 5 days. How can it be autoimmune mediated? It cannot be immune mediated. So it has to be an acute viral. Okay. There are some other things you might think of in this patient because we know that there is dengue. Is it just an epilepsy unrelated?
Unlikely. Unlikely.
Unlikely. No, but see, we know that, for example, an epileptic status can be triggered by any acute viral infection. So while we know this is dengue and we are tempted to say, the dengue has gone in the brain, it may not have gone.
NCS can cause encephalopathic pattern.
So you can get, it might be like a febrile status, a patient who's seizing, unless you do an EEG, won't know. Remember, in dengue also, you can get low platelet count and bleeding. So is it a cerebral bleed? Again, we'll need to look at that by imaging. Let's not jump into dengue encephalitis just because I said the dengue virus can go into the brain. It can be a metabolic disturbance. Look at that earlier patient. That the patient didn't have seizure, but had hepatic dysfunction and ended up with altered sensorium. So hepatic encephalopathy can also cause seizures and altered sensorium. Direct viral invasion, ADEM and ANEC. Okay, these three last men, Dr. Chandra already spoke about that. Okay. So let's see. How do we try to make a diagnosis of dengue encephalitis? What test you would like to do? Who would like to take it? Anybody?
So,
I have not distributed the cases. They are answering whenever asked. Whoever answers is fine. The cases are not distributed.
So, clinically, it is a global encephalopathy with Glasgow Coma score of 8. So, I have to rule out some investigations for diagnosis, some for prognosis and monitoring. So,
now I'm talking about diagnosis.
Yes.
Monitoring, yes, we'll have to do a lot of monitoring in this patient.
Yes. So diagnosis of AES, idea is to detect the culprit from the blood or from the CSF. So especially now there are many panel and biofire, so we can send it.
So you would do a CSF?
I will do a
Come
CSF.
to the point. Yeah, if the patient is stable enough, you
Imaging
definitely
first.
do a CSF.
With a GCS
you
of
do
8,
imaging.
I will not prick first. I will
this
do an
patient
imaging
I would
first.
worry, but if the patient is stable, you definitely want a CSF.
Yes, imaging followed by CSF, or if it is global with raised ICT, definitely, guarded
Guarded CSF. Okay, fine. Okay, but you'd also like to rule out the other stuff. So this was all done. HB is 11, WBC is 4500, platelets low. Not surprising in dengue. This is the kind of WBC I would expect on day 4 or 5. But there's elevated liver enzymes. And bilirubin is sort of borderline. Glucose is 102, electrolytes are normal, so metabolic is unlikely. CRP is 18 milligrams, smear for MP is negative, RMAT negative. We thought it prudent to rule out falciparum malaria. Dengue IgM is positive, so there is no question that this is now dengue. So what about the CNS imaging? You spoke about imaging. Yes. MRI, Dr. Tapisha already mentioned this, that the MRI picture looks almost similar to what you see in JAP-B. You see the basal ganglia being involved there with diffusion restriction, but what is so peculiar here is you see hemorrhage. You see hemorrhagic foci, which makes a diagnosis of ANEC. Once you see hemorrhagic now, don't ask me to read the MRI, sir. I'm reading the report.
Yes, sir, one small point.
Yes, yes, bolo.
Here the description which we have given is not matching with the MRI. Because there is global encephalopathy, so there is no cerebral edema here. Because gray-white differentiation is
might have been
clear.
Done after some
maybe
or something.
With anticongestive therapy,
I don't
edema
know.
disappeared, maybe. But clinically, we have given the respiration is of upper pons. Clinically, we have given your pupils are normal. So it's not that matching.
Okay.
Sir, is dengue a neurotropic virus?
Dengue can become a neurotropic virus. It's not typically a neurotropic
virus. It is written in microbiology.
It's like saying, is EBV a hepatotropic virus? Yes, it generally is. But many other viruses normally don't affect the liver, but they can once in a while. Typical hepatotropic viruses are A, B, C, D, E, F, G. No, there is no F. A, B, C, D, E, and G. Those are what we call typically hypertrophic oil. Okay, CSF was done. I don't know how it was managed. BIFI is done. You said negative, so we have ruled out other stuff. Culture is no growth. CSF is unremarkable, really speaking. So this is not really an encephalitis. If it was encephalitis, you would see cells there and you would see some increased protein. Protein is borderline. And EEG showed diffuse slowing with occasional epileptiform discharges. So diagnosis is what here?
Yes, so it is classical picture of dengue involvement of your basal ganglion thalamus.
And with this background,
so
with the NS1 positive, IgM positive, you are going to say
yes.
this is dengue encephalitis.
Closely it mimics
Yes,
radiologically.
Yes, it looks like NX. So how do you treat NX?
Yeah, it's very
Let's not
dangerous.
go into this. Is general
Yes.
management. All of you know how to manage a comatose patient.
If you want to,
how do you treat NX?
Yes, if you want to save the structure, you have to give immediate IV gamma and methylprednisolone because you have to damp down the inflammation and body's immunity.
Yes, NX
Then
is
you
like,
can survive the structure.
NX is like a cytokine storm which damages the neurons. It's believed to occur in certain type of people. In fact, they've correlated with certain HLA body types as well as some RAB2 genetic defect. So they're pretty rare, and that is why an average child who gets dengue does not end up with NX. But those who have the genetic predilection can develop. And as he rightly said, you give steroids, immunoglobulins, plasmapheresis, and even tocilizumab has been used, and IL-6 receptor antagonist. So I think, yes. DEXA is first. If you can't, yes. But then you can use, you might have to use intrathecally methylprednisolone.
Now, because here it's a mimic, NX mimic plus your severe.
Yes, it doesn't penetrate as well.
As well, but the
see, for example,
here,
sir, if you have,
pulse dose has to be given.
tuberculous meningitis, we do use steroids. I don't know how many of you use dexamethasone and how many use prednisone. A lot of people use prednisone. They say that you still get a response.
See, idea of giving dexa and methylprednisolone is to suppress the plasma cell.
Sir, his question is which of the two?
Yes, anyone, because it may not go to the brain. We do not need. We need to suppress the antibodies because it is antibodies mediated damage. Yes, we suppress the inflammation.
It's actually cytokines, sir, not really
yes, cytokine production will be less.
Cytokine storm is an
kill
abnormal
the
immune
cell.
response. Okay, anyway. I think this is too complicated for me. I don't know about the audience. If you want to discuss how this happens, cytokine storm. If there is a hematologist in the audience, can you enlighten us? Anybody?
For what?
Okay. Now time is up, so I'm just going to summarize. Complicated dengue is rare, but one should always be on the alert for such cases. HLH can occur in any age group following actually any viral infection that includes dengue. And if you treat, you generally get very good results. We never lost a patient with HLH. Dr. Chandari also agrees she's never lost a patient. If it occurs in an infant, as I said, do genetic testing. Acute liver failure is uncommon, needs conservative management and very rarely transplant. CNS complications can be of different mechanisms or multifactorial. NX is a rare complication of dengue which requires very prompt specific treatment. Actually, you're supposed to give that tocilizumab within 24 to 48 hours of making a diagnosis for the best results. Otherwise, there's a 30 to 40% mortality, or those who survive also generally end up with residual CNS damage. Thank you, panelists, and thank you, audience.
Thank you, Dr. Shivash Prabhu and the panelists for the wonderful discussion. May I request Dr. Shivash Prabhu to hand over a small token to Dr. Chandra? No, she has got. Yeah, photo. Very pretty. This color? Yeah, maybe. You're the organizer. সুমনদা ফটো তুলে দাও না সুমনদা তুলে দিই because you got it through the
post-lunch session. I call upon the delegates. We are starting the post-lunch session, please. Those who are still outside, come in, please. After the post-lunch session, we are starting the proceedings. I hope you have enjoyed your lunch. The fish fry was good. At least I enjoyed it. Fish fry to ভালো ছিল না? Right. So now we will have another very important topic, that is how to monitor a dengue patient in critical phase. Our moderator is Dr. Sananda Mukherjee, and may I call upon on the dais Dr. Subhash Prabhu, Dr. Abhishek Poddar, কোথায় রে? অভিষেক পোদ্দার and Dr. Khea Ghosh Uttam, organizer. আরে খেয়া ঘোষ উত্তম।
হ্যালো
At last he has come. Give him a clap.
I'm doing a replacement, so I think I can.
Welcome back, everybody, from the lunch. This is the post-lunch session. No, it's okay. So, welcome back after the fantastic lunch. And to keep this session interesting, we have make it very interactive and focus on critical phase and critical monitoring of dengue. So, welcome our panelists. And so as we all know, dengue is a disease of the tropics and subtropics, and every year, so there's a slight seasonal variation, but year round we get dengue cases. And severely untreated dengue has, though it is low, but the case fatality rate, it depends on the timely initiation of treatment. So treatment and monitoring in dengue goes hand in hand, and with early identifications of sign and lab parameters, we can actually reduce the case fatality rate to almost 20 folds and reduce the mortality. So coming to the, what is the critical phase in pediatric dengue? So I will, my question is to Dr. Prabhu.
Yes. The concept of critical phase is very important. It's the phase or the period during which the patient can become critical. Doesn't mean that he will become critical. And it typically occurs in the 4th or 5th day, can sometimes occur as early as 3rd day, but typically 4th, 5th day when the fever goes. Now, we talk about a critical phase is that this is the phase when you have to monitor the child very carefully. If the child is admitted, of course, you're going to do it in the hospital, but otherwise this is the time when you have to tell the parents to monitor at home. So this is the critical phase. We know that all children don't necessarily have plasma leak, but this is the case, time when they will have or they might have, and therefore this concept is there of a critical phase.
Yeah, so the parents may feel falsely reassured that the fever has gone away, so now my child is going to be okay. But actually when the critical phase is starting, it is more intensifying monitor should be started in order to identify the early signs of complication. Now, my next question is to Khea madam. So what are that we talk a lot about plasma leak. From morning we have been hearing this. So what is the signs of significant plasma leak clinically, and what are the lab signs as well?
So as Dr. Prabhu already mentioned, and we are discussing it from the morning, that not all of these babies will go into the critical phase. Only 5 to 10% goes into critical phase. So most of the babies from the acute febrile phase, though they get into convalescent. But the signs, the monitoring is very, very important. So why there is plasma leak? The important is there is a cytokine storm and which leads to vasculopathy and that also leads to coagulopathy. So the main problem is the critical phase is the vasculopathy and coagulopathy. So when there is vasculopathy, what happens? The epithelia becomes leaky. So there is a loss of protein-rich fluids. So we know the plasma is a protein-rich fluid. It goes into the third spacing, what we call that we see in very severe any infection. So we will have features of the fluid going to third space. So we can have edematous extremities, puffy face. We can have accumulation of fluid in the lungs, pleural effusion, pericardial effusion, rarely, ascites. So initially we will have a fluid in the hepatorenal pouch or in the pouch of Douglas, and then you can have a massive hepatitis A, massive ascites. So these are all signs of fluid spacing in the third space. And as there is fluid leak from the vascular compartment, so you will have features with low vascular volume. That might affect some organs, like you might have organ dysfunction in the form of acute kidney injury, prerenal type of acute kidney injury with decreased oligomer, decreased urine output. You might have some mental confusion with decreased perfusion in the brain. So this organ dysfunction starts it, and the actual things are heart rate becomes tachycardia because, as we know, it's the volume into the heart rate which maintains the cardiac output. So as the volume decreases, the rate increases. So heart rate increases, the pulse pressure becomes narrow. So the systolic remains in the initial stage normal, but the diastolic becomes raised to compensate. So these are the, and you can get a peripheral perfusion is reduced. So CRT may be prolonged. So these are the signs and symptoms that you get.
Yes, as Madam has correctly said, so we may see a child who is puffy and looks like his volume overloaded, but actually intravascular volume may be low and the child might be in shock. So this is very tricky situation to manage.
Can I add something, Dr. Sanan?
Yes, sure,
See,
sir.
we would normally even expect that there will be fluid in the subcutaneous tissue, pedal edema, boggy eyelids, but don't rely on that. You have some patients who have a lot of pleural effusion and yet have nothing on the outside. So you do have to resort to looking at the internal leak rather than just look at the subcutaneous leak.
Yes. And also the narrow pulse pressure is also a quite late finding. So the child has developed fluid shock at that time. So initially when the child is going in compensated shock due to fluid extravasation, tachycardia, prolonged CRT, this has to be, we have to be mindful for these early signs. So, Madam, what are the laboratory perspective of the early markers of plasma leakage?
I think again we have discussed a lot on this.
Yes.
So whenever is the plasma leak starts, there will be hemoconcentration because so you will have a higher, if you have a baseline hematocrit, you will see there is a rise in the hematocrit. And of course, as there is loss of protein rich here, the albumin also will become loose. So these two are the very, very important marker. Thrombocytopenia may be or may not be associated. So I think platelet count less, it's okay, but it's not always the factor. But rising hematocrit and decreased serum albumin. And I have mentioned in my previous year also, this fluid in the hepatorenal pouch. So this is the earliest area where the fluid accumulates. The pouch of Douglas and the hepatorenal pouch. So if you see a chink of fluid, because I also do bedside ultrasound, whenever we see in between the liver and kidney, we're getting a chink of fluid, that means early fluid accumulation has started. And you might get gallbladder wall edema.
So vital parameters monitoring is very, very important. And ideally, blood parameters should be monitored every 4 to 6 hourly or 6 to 8 hourly as feasible. In the depends on the unit. Okay. We will come to that later.
That's definitely important.
So, Dr. Abhishek, what is the warning signs of dengue? And what sir has said, critical phase, not everybody is critical. So, how do we identify which patients are critical?
This is very important. I think it is important for everyone as to know when the child is going into the critical phase, because when the child goes into the critical phase, the warning signs start appearing. If we look at the warning signs, we'll see that usually these patients come with us with vomiting, abdominal pain. Many times it can be disregarded. Parents do disregard the abdominal pain or vomiting, or 1 or 2 episodes of vomiting in the beginning. But ideally this should be taken with a little bit of caution, because the amount of abdominal pain and that the child is not eating, alongside that vomiting. These are the warning signs to begin with. And obviously then we come to the clinical signs of fluid accumulation, as already has been mentioned by ma'am, that there could be edema, there could be internal edema in the form of fluid collection in the peritoneal cavity, in the pleural spaces, and even around the pericardium. That is also important. Alongside that, some of these children complain of significant lethargy and restlessness. And I think one of the signs which especially many of the adolescent children complain, that I'm not feeling well from inside, and a feeling of thirst, that these are two signs of impending doom that we should recognize early, because these signs tell us that this child should be treated with a little bit more of close observation. Alongside that, obviously, if the liver enlarges, there is increase in hematocrit. Alongside the platelets fall to a count of less than 1 lakh, then these are also taken as the warning signs. But these should be identified in the early phase of dengue so that we can start the treatment early. Because many of times we've burnt our fingers, we see that they come late, and once they come late, that period of going into a significant vicious cycle of dengue or complicated dengue starts.
Yes, as you
I
have
wanted
said.
to add a point about tourniquet test that is mentioned. In the morning it was said nobody does it anymore.
Yes.
We need to understand a couple of things. The tourniquet test doesn't actually correlate with the platelet count, number one. So there's no point in doing it for a follow-up. You can't do it now and say, now there are so many spots, next day so many spots, and tell you platelet is down. It in fact also reflects the capillary fragility, which is part of what is happening in the pathophysiology, rather than the platelet count. So if at all you use it for diagnosis, if at all, but as I said, we don't do it because we have ready-made counters now which can tell you the platelet count.
WHO still mentions it, so. Are there, Dr. Abhishek, are there any specific risk factors in children that increase their likelihood of progressing to severe dengue?
Absolutely. The most important thing is the younger the child, especially if it's an infant, we as intensivists and we as pediatricians fear that this child may worsen and may worsen significantly. So an infant coming with dengue is one of the red herrings, number one. Number two, alongside that, if the child is immunocompromised or is getting any form of immunosuppressive therapy in the form of steroids, or has received some sort of immunosuppressive therapy in the form of a rituximab, then these become, then these add to the danger signs. Alongside that, obviously, if there is a pre-existing disease like an asthma or a chronic kidney disease, alongside that, one of the important things is, which nowadays we see, is obesity. And any obese child, I think most of us would agree that an obese child coming with dengue, we all fear, because these children have a relative higher morbidity as well as mortality, of course, to be very frank in that purpose. So an obese child and an infant is something which we very worry in, especially in children with dengue. Alongside that, any other co-infection, not only as written here it's COVID-19, but any other co-infection, maybe with a scrub typhus or a typhoid or a malaria, adds to the comorbidities. So in children, though they are relatively free of comorbidities, these add up to the comorbidities and should be dealt with caution.
I think along with that, hematologic, any patients with hemolytic anemias, so anyone,
because
and
their result
chronic
is-
heart disease. So these are patients we often see, and especially in tertiary centers. So these are also a very high risk factors for dengue.
Mota dengue and chota dengue.
Huh.
Mota dengue and chota
obesity,
dengue.
because not only because they are here, because you have to modify the fluid calculation in
Yes,
obesity.
and then
so that is
securing an
very
access
important.
is also very
If you
difficult
take into kg as the per kg, you will definitely going to overload that child. So this is very, very
Mota
important.
dengue sent to the next hospital.
Mota dengue with yes,
Yes,
that is
yes.
very important.
And also for infant and obese patients as well, securing a central access or any access for that matter, it is very
It's
tricky. And especially when the child has already gone into shock, it is very difficult.
Because already we have platelet dysfunctions, so it will exaggerate that.
Chance of bleeding.
Or the platelet function, or the count.
I think it's the platelet
Function, and the
Function,
chance
not
of
the
bleeding
function.
is more.
Because didn't platelet
But increase the
functions
chance of bleeding.
So to Dr. Prabhu, what are the additional labs to consider for dengue with warning sign?
Okay, let me break this up. First, I want to do tests to find out whether there is a plasma leak and what is the extent of the plasma leaks. How do I do that? You already mentioned that you need to repeat the hematocrit. And you can repeat it as often as required depending on how sick your patient is, sometimes as often as every 6 hours. Second, if you look at the plasma leak, Dr. K has already told you we need an X-ray. A chest X-ray will tell you fluid in the lungs as well as possibly a pleural effusion, and you might find a globular heart if there's pericardial effusion. That's not that common. A better modality actually is the sonography. Sonography will show you fluid in the chest, will show you B lines in the lung, and of course will show you ascites and even fluid in all the various pouches. Bedside ultrasound is also very useful for looking at the venous filling. I think you are an intensivist, madam, and I remember when many years back, there used to be a lot, patient would be in the ICU would get a central line. And even Swan's-Ganz catheters we have put in those days. Why? Because we want to see the IVP, SVP pressure, and you don't need to do that anymore. You can do it very easily by doing an ultrasound. You can see the venous filling, you can see how much is the pressure there. There's a big danger in putting a central line in these patients because they are likely to bleed, their platelet count is low, it's not. So this is a great option to look at the venous filling or the pressure by looking at ultrasound. Next, I want to look at his cardiovascular status, especially this is a warning sign, but if he's already in the hospital or in the ICU, he's going to deteriorate. Of course, if he's hypoxic, I want a blood gas. I want to look for acidosis, so I might want a blood gas for that also. Then I would like to look at his renal function, because if he has renal compromise, I'm going to have problems in my fluids. I'm going to also look at his metabolic homeostasis. We'll look at that, but in my opinion, it's totally a waste. I'm sorry to say that, but you have to do it because you want to do it. But you hardly ever see a dengue patient with hypernatremia, hyponatremia. No matter how much fluid you give, in my experience, the sodium remains normal. So does their glucose. Unless they have some underlying disease. But still, we would like to look at that. So that's the other thing you look at. I want to look at his other organs also. Particularly, I want to look at the LFT. Because several reasons. Because if the LFT is high, the enzymes are high, it tells me that you are more severe dengue, so he's more likely to develop complications. If his SGPT-OT is plumb normal, the chances are less. Secondly, if he has liver dysfunction, he is more likely to also have a coagulopathy. If he goes into renal failure, and that's going to complicate your low platelet count, and these chances are going to bleed more. So in that kind of patient, I might be happy to, give him vitamin K as a prophylactic, or send blood for grouping cross-matching, do an INR. So those tests will come up in front. So this what, and of course, if there is some cardiac abnormality, not so early, but later on, sometimes you see bradycardia. I might want to do a ECG or 2D echo to see what's going on, whether there's myocarditis, which sometimes happens in dengue. So I think that's about it. These are the kind of tests that I would like to do.
Just want to add a couple of points, very practical points regarding to doing a cannulation. As sir mentioned, doing central lines nowadays, as central line checking CVP is out of vogue. But definitely, if you are doing a central line, you have to be 100% sure that you are pricking it once, only with using an ultrasound as a device under ultrasound guidance. Because many times what happens, because these patients have low platelets, these patients are coagulopathic, and if you have pricked an artery or a vein inadvertently, they keep on bleeding, and you may have done the line in 10 minutes and they have gone, put on a bandage and gone. Then after 6 hours, the sister will come and tell you that area has swollen up. So that is something which is very important. Another thing, doing regular hematocrits using from a vein is very difficult. So every one of us should learn the experience of putting in an external jugular line. EJ lines are very helpful. They not only are seen from outside, and they can be used as sources for collecting blood as well. So I think these two are very important practical points.
Yeah. Places where there is no facility of measuring IVC, I have noticed that two things which works. You can give a catheter in the bladder, and every hourly what fluid you are giving, what is urine output. Monitor that, that works very well.
Definitely omitted to mention urinary catheterization and urine output monitoring is very important.
Yes.
That's not a lab test,
Yeah, that's
but
for
that's
vital
very
signs
essential.
post-it is
First thing you do when you go into the ICU is you get a urinary catheter.
But once
I have noticed, apart from narrow pulse pressure, and breathing test I used to do in OPT, and third is orthostatic hypotension. That also works very well to detect
Very rightly said, sir, that
Sir, in mild to moderate, but when you are managing a severe case, this will not work, sir, because you cannot test for postural hypertension, number one, and already if there is prerenal failure, setup has been done. OPD, yeah, in the OPD, it's yes.
In fact, the complaint typically is child is quite all right, but when he stands up, he complains of feeling giddy.
They come and say, we have a reading.
And putting in a catheter, as you said, catheter measuring the urine output hourly helps us to manage dengue patients what amount of fluid we will change. Even if you are not able to do a hematocrit, even that hourly urinary catheter giving the urine volumes is very important, and especially when you are going into the to the recovery phase where you have to cut down on the fluids. That is also very important by changing the urine. The color, not only the color, the amount, the volume the child is passing.
So your daily fluid balance?
ml per kg per hour is a routine thing in any
Yes, ICU. And you're not only...
That's why I didn't mention it.
And not only your daily fluid balance, it's also the cumulative fluid balance. Like, so today you might see it is only positive 500 ml, but in the previous 2 days, if you look at the chart, it is 800, 900, so more than 1.5 liter positive in 3 days. So that should ring a bell that maybe our fluid resuscitation needs to be tailored now.
And one more thing, in dengue is one more disease where we usually don't follow the normal rule which we follow in our intensive care, that if a child is more than 10% positive weight by volume, then they will require some sort of renal replacement therapy. But that dengue is one disease where this rule is not followed. Even if the child is significantly positive, they usually start recovering, as we know, by day 6, day 7.
In the convalescent phase. So you talked about putting central line and how we should be careful. So in your unit, do you routinely top up platelets before putting central line?
No, the usual dictum is the same. If required, then only we put central lines. Otherwise, we try it through other cannulas. Mostly we try the EJ, especially in bigger children, 6, 7 years and above. You can do the EJ very easily. And only if it's a very sick child, then only we do central line. That too, if the platelet counts are well maintained, because it is not only the platelets, it's the...
Urine output, balance, positive or negative balance.
That is... What we do is that we check in our ICU chart, we do not only per hour, we do a daily cumulative urine output, day 1, day 2, day 3, and even if you look in dengue, by day 5 you may be almost 20% positive. But from day 6 you will find that again the urine output has significantly, he or she is becoming negative. So that cumulative usually doesn't count in dengue. You only see as a cosmetic thing that the child is getting bloated and swollen up. You won't require any form of renal replacement therapy usually in majority of the dengue patients.
Okay. So this is very important for primary practitioners in OPD especially, or in the emergency room. So how do you triage the dengue patients?
Okay. So we have to triage, unlike in Sri Lanka, where once you find dengue positive, they admit every patient. So there's no question of triage, everybody gets admitted. But we've learned quite a bit from Dr. Lakumar's studies. One of the very important things, I'll come to your question, but I just, in relation to one very important thing that come out from the study is the fact that the leaky phase doesn't last more than 48 hours. So as you said, you can give fluid, but after 48 hours, you should start tapering immediately. You should expect that the fluid which has gone out is going to come back so that there's no fluid overload. So that's one very important thing we learned from it. Of course, we should not imitate everything and admit every patient. So we need to try it, because if you want to admit every patient with dengue, it's, I think, an economic burden, plus not all parents like to get admitted and we don't have enough beds. So how do we decide? So before I talk about how I'm going to admit somewhere, let me tell you what I will not look at for admission. That one is the height of the fever. There is a parent who will come and tell me, the child 104 fever, please admit. That's not an indication for admission. So height of the fever has nothing to do with the need for admission. So that's one. The other thing is very important is I will decide on which day the patient has come to me. So somebody who comes to me on the first day, and I just told you that the critical phase is on the 4th day or so. If he comes on the first day, if he's willing to come back after 2 days, or I don't really need to admit him on the first day. So the day on which he presents is also important. Height of the fever is not important. Clinical symptoms like rash, presence of rash, itching, nothing is important. What is important to me really is the most vital question I ask, and I go by it by a lot, is how much is the child able to eat and drink? That is the most vital question for me. If the child is able to eat and drink, then it's okay to manage him at home. If his appetite is very poor, if he's vomiting, or he's not vomiting but he's refusing to eat or take fluids, that's a big danger sign. So having said that, let's say how we will decide. The one group of patients we are going to send home. I think you have labeled that as group A, yeah, mild dengue group A. Those are patients who don't have the symptoms of any of the warning signs. They are able to eat and drink and look relatively okay, and otherwise maybe very early in the illness, like first or second day. I'm never going to admit those patients. And that I'm not going to admit irrespective of the fact that even if his platelet count is on the lower side. Dr. Surendran, I disagree with you. I agree with you, the patients insist on the admission, but if on day one the platelet count is 1 lakh and the child is otherwise okay, I would not really admit the patient. So in fact, Dr. Surendran's point is right. The patient says, no, platelet is 1 lakh. Suppose it goes down, the child will bleed. So a couple of things I tell these patients. I hope I can have a few minutes to talk about this. Yes, so one thing of course is the fact that 1 lakh is a diagnosis of thrombocytopenia, but the real bleeding starts after below 50,000. I think Nitin Shah says if it's 60,000, you can even do a lumbar puncture and not worry about it. So 1 lakh is not really a cutoff from a clinical practical point of view. So that's one. Secondly, I take the opportunity to tell the parents, look at the hemoglobin rather than the platelet. If the hemoglobin is not going up, I am not worried, don't worry about the platelet. So this is what I would do for those patients. I'm coming to that. So when we send this, I'm coming to that. So what do? I tell these patients, you can go home, and of course, I generally write out the warning signs. I won't go into that, he has already described that. Write out the warning signs on the paper and say, if any of these you come back, or if it's not during my clinic hours, you go straight to the hospital. Yes. This is what I tell them. Now your question is, how often should they return? That depends on what day he has come to me. If he's come on the first day, and there are many parents on the first day only, they come with NS1 report. Then I say you come after 2 days, because I know second day nothing much is going to happen. If he's come on the third or fourth day, I'm going to call him every day. And if he has any little bit of warning sign, I'll say do it twice a day, also come and see me in the evening. So that's the frequency. So that's for group A. Group B are those who have warning signs, they have even the slightest signs of dehydration or poor intake. That makes me group B. Even if he has no swelling, no ascites, nothing. Because I know that by tomorrow he'll become group B. He'll become moderate dengue. Severe dengue is of course who are those who have in shock or so they're going to. Now one more point. A, B and C have written. If you have high risk category, which Dr. Abhishek has already listed, A becomes B, B becomes C. Yeah. So high risk never are sent home. They are always admitted.
So, Madam, for patients with moderate dengue without shock, who are in the group B in the previous slide, so how do you administer a moderate IV fluid therapy? Since monitoring and fluid therapy, it goes hand in hand.
So as said by Dr. Shivash Prabhu, so not only moderate but mild dengue with dehydration also needs an admission. So actually what we say in the case of moderate dengue, this is approximately we calculate the dehydration to be around 5%. So I think I have mentioned in my talk only. So usually it is the normal maintenance is around 3 ml per kg per hour. So half maintenance is 1.5 ml per kg per hour. So when we consider around 5%, we think it to be 5 ml per kg per hour. So the good thing is you start with 5 ml per kg per hour. You can make it 5 to 7 also according to the dehydration status assessment after assessing the hydration status of the baby. And it is very, very important you monitor every 2 to 4 hourly. The one thing I would say, never give an IV fluid order in a dengue patient for 24 hours. It has to be every 4 hourly. If not possible, at least 6 hourly. You cannot give for 1 day. Okay, so you cannot reassess a baby after a day. So its monitoring is very, very important. Moderate degree, you can start with 5 to 7 and come down after every 2 to 4 hours, depending if you think the baby has become stable. If the baby was hemodynamically unstable, you can give a bolus dose and then you can come to the maintenance dose. But every time you have to see how the baby is becoming, whether the baby is becoming stable, whether the hematocrit is started to decrease or increase or stabilize. These are the things which you have to monitor. And then you will gradually come down from 5 to 7 to 3 to 5 to 2 to 3. Whereas in case of severe, maybe you will start with 10 because if there you think it is 10% dehydration. So then your starting initial fluid becomes 7 to 10. So accordingly we come down or we go. And regarding the type of fluid, it is always crystallites to begin with. So we don't want colloids. So we want crystallites, and normal saline is the best because it's isotonic. And we can also go for ringer lactate.
So patients with...
I think PCV is not so high. 5 to 7 ml is also not good.
That's why I said 5, sir. But if you take 5% dehydration, it is around 5 ml per kg.
We started 5 to 7 ml. We used to have a lot of problems. Now we have cut down into the 2
Sir, if there is no dehydration, you can just give the maintenance. That is 3 ml per
PCV
kg.
is not raising, then you can come
Yeah,
down
yeah,
to
sir.
your
So, like, if it's at the beginning of the critical phase, as sir was, it is around 48 hours. So, on that 48 hours in the beginning, the baby has admitted. And if you see there is no dehydration, you can start with 3 to 5 also. So, 3 is the maintenance, 5 is the with dehydration. And but if the baby has already come at the end of 48 hours of critical phase, you are thinking already. So here there is a chance that it will come back. So you can go to a lower. So it is, everything has to be monitored.
No, I understand where Dr. Surendranath is coming to, and he's very right. The big danger in dengue is overhydration. And most patients will die because we overhydrate rather than the other way around.
Not start fluid
So,
if there is
so
no,
there are situations where you will give lowered, you look at the baby. So these are guidelines, and somebody has given a very wise quote. Guidelines are guidelines, but the best guide is the baby, and your best friend is his kidney.
Yes. So,
heart rate also tells you.
No, his kidney is going to correct all the mistakes you made.
It would be better to start off with a little bit higher fluids and then come down based on the hematocrit.
Because shock correction is very important, shock or dehydration correction.
It is 1 to 2 hours we are telling. But in the practice,
1
what
hour.
happens is they just keep it and forget.
No, we can't do that.
She said it very clearly. Every 4 hours you have to assess the fluid. You write fluids only for 4 hours.
Hartmann's is a ringle acted only.
Yeah,
It's a compound solution, similar to ringers.
we don't use it. Actually, in pediatric ICUs, we tend to use the balanced salt solution, which is more ideal composition to the plasma, but it is expensive. So I think best alternative is to use normal saline. No, it is available readily.
Balanced salt solution is nowadays readily
Plasma
available,
Light
and nowadays
by the brand name.
And nowadays in cases where in cases where you are
No, sir. So if with these measures, we have to closely monitor and we titrate the fluid. So then gradually we titrate if the patient is improving, vitals improving, urine output is good, and after 24 to 48 hours we stop it. So this is how it's a rough estimate, how we...
So what I was telling, this is half maintenance, 3 is the maintenance, this is 5% dehydration and that is 7% dehydration. Okay, sorry.
But we have to be very careful while we escalate and de-escalate, and de-escalation is very, very important, and promptly we have to do it.
The most important part of this graph is the x-axis. It ends at 48 hours.
Yes. Yeah. This is what Dr. Surendranath's answer is. So you have to know when you are starting the fluid and act accordingly.
So now coming to Dr. Abhishek, it's core ICU topic. So given the high chance of fluid creep, what are the strategies you recommend to optimize the titration?
as sir rightfully mentioned, that what is more important is also not over giving extra fluids to the child, so that the child does not fluid overloaded. So a few strategies is what we generally follow is that organ perfusion. your organs, vital organs have to be perfused. If you have to give some sort of fluid, make sure that your vital organs, especially the kidney, is something which you get to know instantaneously. Just look at the urine output. If the urine output for that hour is more than 0.5 ml per kg for a bigger child and 1 ml per kg per hour for a smaller child, that means you're giving sufficient fluids. Don't keep on chasing the hematocrit because at times you may see that because majority of the cases we don't know what is the baseline hematocrit for the child, because the child comes to us with a hematocrit maybe of 40. We don't know what was the baseline hematocrit, whether it's 30 or 35 or was it 40. So you just keep on chasing the urine output and just keep on seeing the child's sensorium, because the brain and the kidneys, these are two most important organs which you keep on chasing. And if you see that the urine output is maintained just at a bare minimum and the child's sensorium is good, just keep on giving the same amount of fluid. Don't rush on to higher fluids just because the hematocrit is going to 40, 45, because many a times we have seen that even in spite of a good urine output, the urine output is 3 to 4 ml per kg per hour, but still the hematocrit has gone slightly up. So just keep a close watch on the urine output. That is the first and most important thing. Fluid resuscitation at the cost of respiratory worsening, which many a times happen because you are keeping on giving fluids maybe 4 5 ml per kg per hour, you are continuing for 24 48 hours, and then one fine day you notice that there are creps in the lung bases and the child is having a little bit of respiratory distress requiring oxygen. That is also not warranted. To just keep the fluids at a bare minimum so that the child's perfusion is maintained. Lung ultrasonography we'll discuss next as to what we see. Basically, you look at the pleural effusions and you look at the pleural lines, especially the B lines, to identify, that will come in the focus part, to see whether the child is accumulating fluid. If you have those advanced gadgets, or if you have a USG machine to check for regularly. Otherwise, keep a watch on the child's respiratory distress, keep a check on the saturations. If you see that after giving 6 hours, 8 hours of fluids, the child's saturation was 98% and it's coming down to 92, 91, that means definitely there is a fluid leak which is happening in the lungs, and you have to be a little bit more careful with the fluids. So just don't keep on giving on fluids, be a little bit careful with the fluids. Just maintain organ perfusion, because you know at the back of your mind that you are requiring that 48, maximum 72 hours, and after that everything will return to normal.
And sometimes the fluid creep can happen in the peritoneal cavity, and it can give rise to abdominal compartment syndrome. So sometimes in severe cases we monitor intra-abdominal pressure, which is nothing but just
Though we keep on check intra-abdominal pressures in some cases of severe dengue, but the dictum is that never put in a needle into any of the cavities, because these patients usually have a lower platelet count, and even if you think that I'm going to give platelets and put in a needle or a tube into that cavity to drain out the fluid, that is usually not done. Just close monitoring, because at the end of the day, again, you are knowing that 48, 72 hours and the child will again return back to normal.
in the patient with moderate dengue with the 5 ml per kilo per hour fluid, if patient is not improving, hematocrit is rising, then what will be our next steps of management?
Okay, this is when you really have to be cautious. You don't want to overhydrate. But at the same time, I think one bolus of 10 ml per kg over half an hour should be okay to see what is happening. Or this might, or if you are already reached a level in an older child, like say 150 ml per hour, then you really don't have room to go ahead beyond that. So then there might be the time to give a colloid, 10 ml per kg. Albumin is the best bet. We need to remember one thing, and those of you who saw that chart very clearly, it said the protein-rich fluid is going out. So when the protein-rich fluid is going out, as Dr. Kea mentioned, the albumin is going to come down. So you're going to have problems for the fluid to come back because there's not enough osmotic pressure. And when you keep giving crystalloids, you're not giving any colloid, and therefore this might be the issue. So one bolus with an albumin will work. Albumin is generally recommended. 0.5 or 1 gram per kg is what we would give. If you don't get hold of albumin, you can try dextran, but that's not the best choice. But after you do this, you might want to give that higher dose of fluid, say 10 ml per kg per hour, but just for maybe 1.5 to 2 hours. And I would step down very rapidly, go down every 2-3 hours down to 7 ml and then 5 ml per kg.
But when it is going towards severe dengue, the colloid rescue comes here, and which is more important instead of giving more and more crystalloids.
I think we as intensivists usually have the tendency to give a little bit more of colloids if we see that severe dengue child. That because the moment you are giving 5-7 ml per kg and continuing, you will see that the child is definitely developing some signs of fluid overload. So it's better in those states to start with a colloid bolus and then with
Studies which have shown that if you give colloids in that, if you have scenario like this, it will have a better outcome. So one dose of colloids in that case, it's much.
And rather, after that colloid bolus also, we tend to give an albumin infusion, cutting down on the crystalloids. That helps, really helps.
So if, madam, now we have given bolus, we have given crystalloid, now you have given a colloid bolus. Patient has improving. Now what are we going to do?
So as I said, as he said, you should again check. So if the patient is not improving, it's a separate scenario. Then you have to think of whether there is any internal bleeding or not. Look at the hematocrit. So rarely you may require, though it is not required, blood transfusion is always bloody, what we always say. But in some cases you might need. But one thing regarding the colloid is you have to give the hyperosmotic colloid. It's better to give than albumin. Dextran is also hyperosmotic, but it have some problems. Sometimes they have increased tendency of coagulopathy, though many of the studies have shown there is no increased incidence of coagulopathy if you use dextran. Isotonic colloids like Hemaxil is not usually used. We usually use albumin, as said by, I think, agreed by all of us. Yes.
The question is only about cost.
Yes, the cost is a very important factor. Yeah. In that case, you can go for Hemaxil. That's what I'm saying. If the next step is, you have to see the hematocrit. If it is decreasing, falling, hypotension is occurring, you might think of an internal bleed, and you might have to go for a whole blood, or better a packed cell, packed RBC in that 5 ml, and if you give whole blood 10 ml. But if you see that the hematocrit is maintained, it is more than 45, I think what he was telling, we should continue albumin for a little while and then come down to crystalloids.
So Dr. Abhishek, if we are going to severe dengue and shock is not getting corrected, so now in this stage, do you start inotrope, and how do you monitor, how do you guide your fluid therapy? Is there a role of focus?
I would rather differ on you in this aspect, because in dengue, usually inotropes do not have any role. In dengue, is basically something which we deal with fluids, and it is depending on what fluids you are using, whether you are using colloids or not, and how significantly sick the child is. Obviously, if the child has an alongside that episode of bacterial sepsis, then probably where you are seeing that from the low pulse pressure to it is shifting to a wide pulse pressure, then obviously your role of giving some sort of a noradrenaline or some sort of an inotrope comes in. Otherwise, doing a POCUS, a carefully done POCUS, will give us 3 to 4 important things. First of all, most important, as someone was asking in the audience, as to the IVC assessment. Collapsibility in a spontaneously breathing child is a very important parameter for assessing the fluid status. If you are seeing that the collapsibility is happening at more than 50%, then you can be sure more or less that definitely your child requires fluids. If the collapsibility is less than 20% with respiratory variation, without that much respiratory variation, then probably the child is fluid filled, and then probably you can decide that probably you are not going to require that much of fluids. Inotropes will help in that manner. Again, alongside the IVC, you're doing a cardiac assessment, checking the cardiac functions, as because many of times we see that there is an element of dengue myocarditis where there is cardiac dysfunction, where the cardiac functions may come down to around 35-40%. Also, we can check the abdominal cavity for any fluid in the peritoneal cavity, and what is the pressures depending on whether there is fluid in the where is the fluid accumulated. And last but not the least, regularly doing POCUS and checking the lungs to see fluid, the Curly's B lines, what we see on the X-ray, it comes as B lines on the POCUS also, to identify fluid accumulation even prior to pleural effusion has happened.
So to summarize, the fluid overload, shock, fluid overload, and coagulopathy, these are the 3 major things we need to monitor and treat accordingly. And escalation and de-escalation of the fluid, it requires close vitals monitoring and lab parameters monitoring. Hematocrit, albumin, it can guide us in the treatment, but and in nowadays POCUS is also a very useful clinical tool, bedside tool. So thank you. Any questions?
No, thank you. I think we have to proceed. It's a fantastic, it's a intensive management of dengue that we wanted to know. And thank you, Dr. Shananda, for moderating such a lively panel discussion. Thanks to Dr. Prabhu, Dr. Abhishek, and Dr. Khea. May I request Dr. Khea to hand over a small token to Shananda and Dr. Abhishek, and please, if you may come. Now for the next session, see, till now we have been dealing with how to manage dengue patients in intensive care unit. But the next session will be how not to refer patients to intensive care unit by dengue prevention. So for the first time today in this intensive dengue session, we will have a dedicated, please load. We have a dedicated session on dengue prevention. And may I request Dr. Ritobroto Kundu to please moderate the session. And we have 3 panelists, Dr. Surendranath, Dr. Puneet Kalra, and Dr. Manjari Mitra. Now incidentally, Dr. Surendranath and Dr. Puneet Kalra both were in Gorakhpur yesterday. And thank you, Dr. Surendranath, to cut short your UP Pedicon stay and be with us. And I take this opportunity to wish a belated happy birthday to Dr. Puneet Kalra, who had happy birthday yesterday, but still from Gorakhpur he traveled to Delhi. I don't know how many minutes he spent in his home, but again he has come today, so thank you. And we have Dr. Manjari Mitra. So the next few minutes is dedicated to dengue prevention. Thank you.
Dengue prevention panel. Now, Master, so, good afternoon, everybody. So, I'll be talking about a vaccine which has not yet arrived and which we know very little about it. And with me, Dr. Puneet Kalra is there, though he belongs to the Takeda group, but here he is with us for not for the company, but for the science, isn't it? And Dr. Surendranath and Dr. Manjari, you all know I did not do. So, at the outset, disclaimer is that I don't have any incentive for talking about the vaccine, and this is the moderators. So, actually we don't have any idea about the prevalence of dengue, how many cases. In those places where the dengue seropositivity, that means you have antibody against dengue, below till 9 years above 60%, we call it high transmission zone. Seropositivity above 9 years, till 9 years, above 60%, or the maximum amount peak incidence of dengue related hospital admission is in children below 16 years, then you call it as a high transmission zone. But we don't know which zone we. So my first question, anybody of you, how huge is the dengue burden? Any one of you can take.
Yeah. As far as the dengue burden in India is concerned, it differs from region to region, in fact. North, south and east, west have different incidences. As far as south is concerned, the maximum incidence is there. And next comes east, I think. These two are the regions which are almost about 77% in the southern region, and western is 62, and the north is 60. So overall incidence is about 60 to 70% as far as India is concerned. And as you said, the 9 years 60% prevalence has not yet been there as far as India is concerned. We still doesn't come under the WHO criteria of endemic area.
So yes, we exactly don't know. It's reported.
So if I may add on to it, published literature mentions 56.14% as the seroprevalence in India, which technically does not fall under the SPR less than 960%. But the fact of the matter is there is massive underreporting of dengue.
Yes, that's
Underreporting is huge. Every year, National Vector-Borne Disease Control publishes around 2 to 3 lakhs cases, but the actual number could be 30 to 50 million. India happens to be the global epicenter of dengue, and a recent paper from AIIMS Patna mentions that 90% of DLI, dengue-like illnesses, which were being reported in AIIMS Patna were actually confirmed dengue cases. So there is massive underreporting, intentional or unintentional, I'm not commenting upon it, but the burden is huge.
And the concern is 30% of the infected cases are severe dengue, which is our concern.
Now, we only report those cases which are admitted in the hospital. Rest of the dengues we don't report, nobody knows. Now, we know that we have been taught that control of vectors goes in a long way to prevent dengue. But one thing I say, as long as there is water in the earth, mosquitoes will be there. Mosquitoes have recently reached Iceland. Antarctica is still left out, but we expect within a few months or years it will go away there. So even if you control the environmental sanitation, water supply, does it really works in the long run? Dr. Puneet, is for you.
Well, actually, in terms of WHO, when we talk about the management of dengue, it requires a multifaceted, multi-sectoral, integrated approach. And just like for any other infectious disorders, vaccine along with vector control measures, along with sustained serosurveillance, along with communication strategies, along with community advocacy, form that cycle. So there has to be a cross-pollination of effort, but then there are challenges. We know against dengue, there are no effective antivirals which are available. And the fact of the matter is that vector control also has limited approach. So vaccination as per WHO could be an important part of prevention algorithm. And I would leave it over to Dr. Manjari and other experts to comment on that.
One thing I like to add in this regard, Singapore is a country where you don't have mosquitoes. They don't use mosquito nets also. But what has happened, still dengue is there in Singapore. Now what has happened in Singapore, instead of dengue, which is a disease of childhood, now has become a disease of older age. There is an epidemiological shift. If you control mosquitoes, not to the 100% extent, what you will have shift in the epidemiological, because you don't develop any antibodies against the dengue. First attack of dengue common, second attack still, but you rarely have third or fourth attack because you develop immunity. But you won't develop immunity unless and until you give a vaccine. So here lies the importance of vaccinating. So my next question is, what seroprevalence? Which are the serotypes which are common in India?
Yeah, we all know that in India, the type 2 and particularly the type 1, these are the most common, and type 2 is the most common across globe. And that is one of the reasons why the vaccine has taken the type 2. And the severity is also with type 2. Now, routinely we don't do the serotypes, but because the vaccine is coming, because the prevention and vaccine has become very important globally, so the vaccination, even the serotypes are done, and we have seen. And if you can look into the 4 regions in India, there is a variation. And in eastern sector, we have seen the type 2 is most important, but 4 hardly we see. So 3 and 4 is a question mark. Hardly we see 3 and 4. Even from the vaccine perspective, we will see. But type 2 and 1 is important, and type 2 is the most important.
So if you see the orange and the type 1 blue, these two are maximum everywhere.
And there may be some seasonal
and type 4 is practically non-existent, only reported in few places of Andaman Nicobar Islands, and type 3 is also very less. A study was done in Thailand where they have shown that if dengue 1 is followed by dengue 2, then there is a 500-fold of having dengue hemorrhagic fever. Dengue 3 followed by dengue 2, 150. Dengue 4 followed by dengue 2, 50 folds. So the dangerous combination is this two. Dengue 1 fold. So any vaccine should, one thing you should keep in mind, it should have a very good coverage against these first two. So this is the burden substantially growing, Acha. What are the major antigens against
Dr. Kundu,
which?
one important thing in the previous thing, now this is a global concern on climate change. Recently I hearing lot of thesis is going on climate change, and that is maybe one of the reason dengue has sharpened so much. Mosquito has changed to dengue and the globally, and what else will come we don't know. So this is an area of interest which I'm
This
seeing.
is the first lecture which Surendranath has already given of these things. So now what are the major antigens against which immune response is mounted following a natural dengue infection? And why secondary dengue infection is more serious, we won't take, we have already discussed that. But anyhow, what are Dr. Puneet, what are the most important we target?
Okay, so when we talk about dengue virus, it's a polypeptide which contains of 10 proteins. So you have 3 structural proteins and you have 7 non-structural proteins. The structural proteins obviously are starting from outside capsid, membrane, and envelope protein. CPRM, capsid, premembrane, and envelope, followed by NS1, 2A, 2B, NS3, NS4A, 4B, and NS5. Out of all these proteins, PRM and E proteins, that is premembranes and envelope, are extremely important in terms of generating the humoral immunity against the virus. This is where humoral immunity comes into picture. Secondly, NS1 is the only protein which is extracellular. It is responsible for cellular immunity, and it is also one protein which is secreted during infection as a diagnostic factor, and it causes the endothelial hyperpermeability of the virus, which subsequently leads to all this tissue lysis, cytokine storm, DHF, DSS, and even shock. So for any effective protection against dengue virus, NS1 protection is extremely important to control severity of the infection. Similarly, the protection against against PRM and E is extremely important for humoral immunity. So
to sum up the whole thing, it is the membrane protein, envelope protein, and NS1 protein. Antibodies act against this. Rest of the things, the cell-mediated immunity is very important. So this is in very short and basic. So now my next question to Surendranath, why we need a dengue vaccine?
As Puneet told that as far as the incidence of the dengue is concerned, we don't have the correct pic. And we see the outbreaks of dengue and we run short of the beds in most of the hospitals. If an outbreak of dengue is there, almost all the hospitals are filled with the beds. And another problem is severe dengue is almost 5% of the cases go into severe dengue. And some of them, as you said, they may have a moderate dengue which require admission. And taking these things into consideration and parental concern, any vaccine, if it is acceptable by the community, now if a dengue vaccine is introduced, I think most of the parents will come and ask us, when are you giving the dengue vaccine? I mean, it is the community which has to decide whether they require the vaccine or not, depending on the epidemiological pictures. As far as India is concerned, we have a lot of cases and lot of morbidity and mortality is also there. Definitely we need. And as you said, measures against the mosquito are not so helpful. Definitely, to some extent, they will be helpful. But taking all these things into consideration, definitely vaccine is required. And in the morning, we have already discussed that the burden of the disease is growing enormously over a period of time. And recent times, it is one of the most important vector-borne disease. So if the vaccine is there, definitely it is going to help.
Normally what we have seen over the years, the vaccine has come and then we start discussing about the vaccine, the scientific. But this is the only vaccine where we have started discussing the vaccine before the vaccine has come in the market. The only reason is because we had an experience. When globally there was an experience of a vaccine which was the Denvaxia, which had a catastrophe which we had already discussed in the morning.
We'll discuss about that.
Yeah. So that is the reason we have to think of the positive minds about this vaccine.
So only one thing I'd like to add, dengue is the only one virus which does not give a lifelong protection. If you have a chickenpox infection, you're protected for life. hepatitis A protected for life.
So
But
can-
because there is no cross protection, not only that, the second attack is going to be far more sinister than the first one. Yes.
So,
yeah, protection against the particular serotype which the infection is there, you will have. The protection against all the other three serotypes are transient, and over a period of time that whatever cross-protecting antibodies are there, they are going to decrease. And we do not know at what level, when you have the infection with other serotype, you may likely to have a severe dengue. It is the common observation that the second infection with the other serotype is going to be more dangerous than the primary infection most of the time.
So herein I would like to add a few perspectives, having worked earlier in Pasteur and now currently in Takeda dengue vaccines. So the era of low-hanging fruit in terms of vaccine development is far from over. Most of the vaccines, most of the diseases which could have been easily catered to have been conquered, and the next generation of vaccines which are coming are against DTT, difficult to target pathogens. Dengue is one such pathogen. The fact of the matter that we still do not have an effective antiviral against dengue, it provides ample testimony to the fact that what a challenging virus dengue has been. Attempts to develop an effective dengue vaccines have been going on since early 1940s. The great Albert Sabin had made, the inventor of IPV had made those attempts, and the very fact of the matter is that 70 years down the line, we still don't have an effective vaccine. It shows how tough the vaccine development has been. The earlier vaccine had some challenges, and we had a few learnings, that, okay, I'll just come to that. So I think I can continue in the same way. So when we talk about the challenges with the earlier vaccines tried to utilize the concept of heterotypic immunity. One thing we were pretty sure about, that the monovalent approach in this vaccine would not work, because each of these four viruses, dengue 1, 2, 3 and 4, are like separate subspecies in themselves, because they share only 60 to 70% similarity at the structural, phenotypic and genotypic level. That is why each species, it was like developing a 4-in-1 vaccine. Secondly, in the earlier generation of dengue vaccines, they had utilized a yellow fever virus backbone.
We'll coming to that.
Yeah.
What are the structural background of the Takeda vaccine and other vaccine? I like to take this question. So if you see very carefully, the first vaccine, which was a catastrophic vaccine and which was ultimately withdrawn, started in Philippines.
Sir, we can't call it as a catastrophic like rotavirus vaccine. It had some advantage. The disadvantage is you cannot.
It has many disadvantages. People
But anyway,
who
it is
took
going
the
to be
vaccine,
stopped, I think.
they had more severe attacks of dengue subsequently. The problem with that vaccine was that its backbone, because all the flavivirus has same structure, its backbone was yellow fever vaccine, on which only these two were changed, membrane and envelope protein. Now the vaccine we have has a backbone of a dengue 2 virus, which is the most dangerous of all the 4 dengue serotypes. And we have membrane antigen, envelope antigen of each, so it resembles a natural dengue far more than the vaccine which we are previously. The third vaccine I am not going to discuss, because still the vaccine has not been licensed, and it has been licensed very recently, and that too in adults. So let us forget about this. So this is the vaccine we will be talking about, the structure of the vaccine. With this, what is the structural basis or immunological mechanism of the vaccine? I think we already told that it is the against E and M we have antibodies, against NS1 we have antibodies, and rest of this we have cell mediated immunity. So let's not talk where other important things are there. So if what this vaccine does, it resembles a natural infection. Once you give the vaccine, it calls the dendritic cells or the patrolling cells. These patrolling cells, they take the vaccine and present it to the B cells. Now the humoral response comes. B cells releases antibodies against E protein, envelope protein and the NS1, and then it stimulates the T cells, which produces CD4 and CD8 lymphocytes I have discussed already. So this is how the vaccine works. It works in three phases. It works in the innate immunity, in the humoral immunity, and in the cell-mediated immunity.
So just one pointer.
Pointer
regarding just to understand the clarity better because of the Denvaxia and what is the current vaccine. Now Denvaxia, what we heard, was developed with a yellow fever vaccine as the backbone, and this has been developed with the most common backbone, and then it was genetically engineered. With the other three type serotypes, particularly the two surface proteins, that was the pre-membrane and the E envelope. This engineering has given rise to this extensive immunity aspect, the three aspects, the innate immunity. Immediately after giving vaccine, you have the innate, then you have the blocking the infection, and then you can prevent the severe disease. This was not thought of not thought of, I won't say. It is always very difficult to develop a vaccine with 3-4 serotypes. That was happened, and then the experience have shown, Denvaxia experience have shown that if you give the vaccine in a seropositive, the efficacy was good. But not as good as this, definitely, but seropositive. So whenever this vaccine, before this vaccine came, there were certain countries in the world where Denvaxia was used because of this. And in ICH, we were supposed to do the trial of Denvaxia. I am fortunate that we have not done the study because it had a catastrophe in Philippines. So that is one of the reasons this vaccine has taken care of that advantage. Maybe subsequent vaccine can also have certain more advantages.
Yeah, to put that, what Madam has told is, previous vaccine is yellow fever vaccine, backbone is utilized. What it had led is, I mean, for a seronegative individuals, for the children when the vaccine was given, after 18 months or 2 years, when they had the infection with others, any dengue infection, it was a severe infection and deaths have been reported. For a seropositive individual, seropositive means he has already had one infection, the vaccine acts as a second infection, they are protected. For a seronegative individuals who has not been exposed to the dengue at all, those people, if the vaccine is given, Denguvaxia, which was introduced previously, had a problem for a seronegative individuals. So for this reason, I think that vaccine in Philippines has been withdrawn, and now all over the world, I think Sanofi has stopped producing the Denguvaxia. There is no need to talk about that because the vaccine is going to be withdrawn because of lack of purchasers. Because if you want to give that vaccine, the individual has to be seropositive. How do we know? We have to do a pre-test before giving the vaccine whether he is a seropositive or not. In a community-based vaccination, it is very difficult to do seropositivity and give the vaccine. So in the national immunization program, it is impossible. And even in practice also, you can't ask somebody to get the seropositivity report, then only we'll give the vaccine. So that vaccine, I think, will not be in demand. I think Sanofi has stopped producing that vaccine.
And that was one of the reasons WHO has given the guideline for preparing this vaccine, that you have to take both seropositive and negative. So in the 20,000 population,
so
we had 70%.
we'll come to that. So Dr. Punit, how the vaccine, this clinical development of the TAC 003 was done?
Sure, I'll just throw some light on that. Before that, I would like to remind what Dr. Kundu had told. You know, in terms of creating that extra net of safety net of, T cell immunity, B cell, CD4 plus, CD8 plus, the quantitative and qualitative, both aspects of antibody development were considered. That is why, besides the neutralizing antibodies, all the antibodies were highly affinity matured, they had high affinity, complement fixing properties.
Talk about that.
So I'm just reminding the audience about that, what is the importance of that. Now let me take you back to the clinical developmental program. So as per the WHO guidance, there were certain guidelines which needed to be adhered to in terms of doing testing on both seropositive and seronegative, having a large sample size, having a multi-country involvement. That is why a global program in more than 14 countries, 88 sites with more than 20 phase 1 to 3 trials and more than 28,000 participants aged 1.5 years to 60 years in both baseline seropositive and seronegative population has been done. So these trials have been done both in Latin American as well as European countries. India is also a part of this trial. The landmark trial was TIDES. that is tetravalent immunization against the dengue efficacy study, which was done in 8 dengue endemic countries. In Latin America, we had countries like Brazil, Colombia, Panama, Nicaragua, and Dominican Republic, while in Southeast Asia, we had Sri Lanka, Thailand, Philippines, all these countries. So this again was done on a sample size of more than 21,000 subjects. All the WHO guidelines in terms of having a large sample size in both seropositive and seronegative population. So I'm just coming to the study design.
You also continue how the study was designed, this tetravalent study.
Okay, so the landmark study TIDES was done on a large sample size, 21,000 subjects across 8 countries, 8 dengue endemic countries. The age group was 4 to 16 years. The adolescent and the pediatric age group was taken because this is where dengue hits the hardest. So the randomization was done in a ratio of 2:1. So almost 13.5 thousand subjects were vaccinated, while the placebo arm was around 6.5 thousand. This was done to maximize the safety as well as maximize the number of observations, both in terms of safety and efficacy. As per WHO guidelines, the seropositive to seronegative ratio had to be more than 20%, and this was adhered to. Since these were mostly dengue endemic countries, we had around 72% baseline seropositive and 28% baseline seronegative population. And this trend continued individually in dengue 1, 2, 3, and 4, though those were not the primary endpoints. And again, the WHO wanted a long-term follow-up. So 4.5 years follow-up was done. WHO had asked that for all the next generation dengue vaccines, a minimum of 3 to 5 years follow-up needs to be done. And there were reasons for that, because the earlier safety signals with the earlier generation of dengue vaccines, which everybody's been talking about, the safety signals were seen around 1.5 to 2 years. They got stabilized, and by the end of 3 to 5 years, they started dying down. To effectively rule out all safety aspects, minimum 3 to 5 years of follow-up was desired by WHO, and we did a 4.5 years of follow-up, and recently that has been extended to 7 years, and it's not yet published, but we have 7 years safety results as well. So the primary endpoint of this trial was the overall vaccine efficacy against virologically confirmed dengue of any severity. Now, how do we define VCD? So for virologically confirmed dengue, we were doing RT-PCR. Serotype specific RT-PCR was done for every single case because that is what the gold standard of dengue diagnosis is. The secondary efficacy endpoints were vaccine efficacy by serotype, baseline, serostatus, and hospitalized VCD. Vaccine protection in terms of dengue hospitalization reduction, which is very important from public health perspective, because dengue is a disease which comes in epidemics and it just overwhelms the healthcare systems. It cripples, hospitals. So that is why efficacy against hospitalization was considered as a key secondary efficacy endpoint. And then we had exploratory endpoints in terms of long-term follow-up of efficacy and safety data.
Just one pointer, that all those 20,000 subjects were in the immunogenicity year, or we had taken a small subgroup?
No, we had done the,
For
all the vaccine subjects, there were only around 13,000.
20,000 samples. Placebo was
6.5.
No, my question was, everybody was in the immunogenicity group, or you had taken
immunogenicity group now. They were taken like this, blindly. Then first, before giving the vaccine, an immunological assessment was done. It showed that 72% was baseline seropositive and 28% was baseline seronegative.
My question
And the vaccine efficacy, what is efficacy? So we see how many of the placebo recipient has developed dengue and how many of the vaccine recipient has developed dengue. That points the vaccine efficacy. So let's see the results.
Not 20,000.
So this is the secondary endpoint. So secondary endpoint, we judge the vaccine efficacy on the basis of serotype, whether the person who received the vaccine was previously seropositive or negative, severity of the disease, and how many of them was hospitalized. So first let us see,
I have one more question. This study where I was seeing in the published paper, there was a subgroup who was given a booster dose. So can you just opine on that?
Yeah, so the
Booster
boost,
will come later. Booster, as of now, booster is not indicated.
No, in the published paper it was there. Indication is not there, just to understand.
am I allowed to answer this question?
ठीक.
Okay, thank you. Thank you, Dr. Kundu. So basically, when we talk about what Dr. Manjari is referring is to the TIDES 54 months publication. At the end of 3 years, we saw some dip in terms of efficacy, which is not significant again from hospitalization perspective. But against VCD, the vaccine efficacy, which was around 80% at the end of 12 months, was around 61.4% at the end of 4.5 years. That is why we explored the role of a booster at the end of 4 years. So it is still unpublished data. On around 9,000 subjects, the booster was given, and what we found out that booster had no significant benefit against it. Is giving some moderate benefit in terms of raising the efficacy from 61 to 74%, but efficacy against hospitalized VCT even after booster, which was pretty high, to the tune of around 84%, it again increased to 90%. More important thing, if you look at the Kaplan-Meier statistical curve of efficacy, which is shown in the graph, in the earlier vaccines, they were dipping, they were dying down. So the Kaplan-Meier curve was still, they both were running parallel. That means efficacy was still continuing when the
So
trial
the
was.
question is, when we are in an endemic zone, boosters are not mostly required. That's the.
So
let's see
again,
what happens.
there is natural boosting also, but
So don't make things complex. Let everybody understand. Make things simple.
I'm
So
asking the question that-
when we study a vaccine, we study two things. First is immunogenicity, whether your body is producing antibodies against the vaccine. But immunogenicity does not mean protection. You will produce antibodies. You produce so much antibodies against typhoid. Vidal test, modified Vidal test, rapid Vidal test. We have so many antibodies, none of the antibodies are protective. So we see the efficacy. So first we see immunogenicity, then we see efficacy. So what was the immunogenicity results? Anyone of you?
So as I mentioned, both from a quantitative as well as qualitative aspects, and neutralizing antibodies were assessed. So first of all, we are pretty sure that it is the neutralizing antibodies which we are assessing. Non-neutralizing antibodies were not assessed. And within the non-neutralizing antibodies, all the antibodies had high affinity, they had high avidity, they were affinity matured antibodies, they had complement fixing properties, they had serotype binding properties, and serotype specific as well as cross-reactive broad neutralizing antibodies were also seen. And yeah.
So if you see,
what was important that both the seropositive and seronegative.
Now what is important is that a vaccine is effective. Usually it is taken, it should be more than 10 times here. But what you see, it is not more than 10, it is nearly about 100 times. Especially if you are seropositive, then you produce antibodies to a very high level, nearly 1,000 times for all the 4 serotypes. If it is seronegative, that means the child who has received the vaccine, who had never had dengue before, even his antibodies level is more than 100 times. Not only that, this immunogenicity persisted for 51 long months. So it is, antibodies are produced and it goes for a long time. And so this was the antibodies against this envelope protein and membrane protein. If you see the antibodies against the NS1, also you see it is a high antibody levels. In seropositive it is more high, and in seronegatives it is high, more than 1.5 log. That is means a very good. If you have more than 1 log, this is good. It is more than 1.5 log. And NS1 is notorious for causing all the problems, endothelial damage, leak and other things.
How can you explain that the DEN3 and DEN4 is not eliciting the
I'll come to that. How do you explain? I'll come to that. There are all explanations of that. Why DEN3, DEN4 is not showing as DEN1, DEN2 showing. So what is the efficacy of this vaccine against dengue? The first efficacy we have done is vaccine efficacy in virologically confirmed dengue and hospitalized hospitalized virologically confirmed dengue, irrespective of whether they are seropositive or seronegative. Dr. Puneet.
Yeah, so it was 80.2% at the end of 12 months, which was the primary efficacy endpoint, and efficacy against hospitalized virologically confirmed dengue was 90.4% at the end of 18 months, which was one of the key secondary efficacy endpoints.
So what is important, it is irrespective of the seropositivity or seronegative, irrespective of the serotypes, we punched all the 4 serotypes together, and we punched all the 2 groups, seropositive, seronegative together, and this is the result. Now, you proceed, what happens against seropositive, seronegative? Dr. Puneet, please explain the graph.
Okay, so again, talking about the graph, this is a Kaplan-Meier statistical curve. So what you can see is, you can see the placebo is in the, are the solid lines which you are showing, while the dotted lines are referring to the vaccinees. So obviously you have the cumulative incidence of VCD on the x-axis, which seems to be lower than vaccine. And this shows the vaccine is effective, and you can see the early separation of both these graphs. That means the protection is early and it is sustained because the graphs are not dipping. Even at the end of 57 months, they are still persisting. So the primary efficacy endpoint was achieved in terms of initial efficacy of 80.2%, persisting to 61.2% at the end of 4.5 years. In terms of seronegative, it was 53.5, seropositive slightly higher, 64.2%. So, but 1 lakh, when you extrapolate that to 1 lakh cases, the vaccine was preventing around 5,064 cases in seropositive and 4,393 cases in the baseline seronegative population.
So Puneet knows much better than me, so his explanation, we don't understand that much. I tell you in very simple points, what happens, your homogeneous protection against all 4 types, as I've told you, even if you are if you have only one type of dengue, lasts for say 18 to 24 months. There is heterogeneous protection, the proof is there. We expect if there is only homogeneous protection after 18 to 24 months, this protective level curve would have dipped. But it has not dipped. It is continuous, parallel. So it proves the vaccine not only gives against all the 4 types, not a single type. So it gives both homogeneous and good heterogeneous protection also. That means a vaccine giving good protection to all 4 types, but a shade better in seropositive individuals. But again, what we did, this vaccine efficacy is done against seropositive, seronegative, but we didn't do individual serotypes, which Shopon was going to ask. We will come later to individual serotypes. So this is against efficacy against hospitalized. Same thing. For seropositive it is high, for seronegative it is low, and these 2 lines are going together. It has never dropped. This is the number of dengue cases in placebo. This is the number of dengue cases in vaccinated group. So it is giving a very good protection both against seropositive and seronegative. Never the line has dipped, it maintains a parallel relation and going side by side, brother hand in hand. So giving both homogeneous and heterogeneous protection to all the 4 types.
And per 1 lakh case, when you extrapolate that to 1 lakh, exactly the same number of protection. 1780 both in baseline seropositive and seronegative.
So this has been mathematically calculated. Our sample size was 20,000 something. If you project it in 1 lakh, it has given a very good. Now you come to the question Shopon was asking. What is the protection against individual serotypes?
Sir, one thing we have to see that at the end of 4.5 years, hospitalization rates are not reduced that much compared to the first 12 months.
18 months, 90 months.
Yeah.
They haven't.
Yeah, 18 months rates and compared to the 4.5 years rates, they have not reduced that much compared to the vaccine confirmed diseases. Okay. So that we can prevent the hospitalization much better than vaccine
That's right.
So I think what I think you mean to say is that for any vaccine, the main endpoint is reduction of severe disease and reduction of hospitalization. From a public health perspective, this vaccine is achieving what we want, right?
Almost 85% reduction.
Yeah, so I think that's a good
So
indicator.
now vaccine efficacy against individual cell types, vaccine efficacy against vaccine confirmed dengue, as usual for dengue 2, because the vaccine has a backbone of dengue 2, is very high. It's good with dengue 1, dengue 3, it's okay, dengue 4, it's okay. But if you come to the hospitalized, you see one thing, for dengue 2 it is very good, for dengue 1 is good, for dengue 3 is okay, but for dengue 4 is 100%. Anything 100% means there is some garbar. So what is the garbar? We will come later. We will come later. Why this has happened? So now if you carefully divide, we can divide the whole dengue patients into 8 groups. Number 1, seropositive dengue 1, seropositive dengue 2, number 2, seropositive dengue 3, number 3, seropositive dengue 4, number 4, seronegative dengue 1, number 5, seronegative dengue 2, number 6, seronegative dengue 3, number 7, seronegative dengue 4, number 8. So if you see the first seropositive in all 4, the forest plot line, all the pointers are on this side, so it means very good effective. For seronegative, for the first 2, dengue 1, dengue 2, it is good. But if you come to dengue 3, dengue 4, it is going to the other side. It is not showing improvement, it is showing there is some deterioration. Also, if you consider hospitalized, it also shows. And now the most important, so what our conclusion after seeing this slide, so this vaccine shows very good efficacy in seropositive individuals and good efficacy in seronegative only against dengue 1 and dengue 2, but not in dengue 3, dengue 4. Now, Puneet, why this discrepancy has occurred?
So why this discrepancy has occurred? Because if you look at the sample size of dengue 3 and 4 seronegative, you have these 4 circles and you can actually visualize how small the sample size of dengue 3 and dengue 4 was. So the statistical significance was not there because it was not the primary endpoint, because if you look at the natural epidemiology of dengue, it's serotype 1 and 2 which always predominate. If we were to obtain efficacy against dengue 3 and 4, sample size should have run in lakhs, which is not possible for any dengue vaccine trial to do. This is a challenge which other vaccine companies are also facing. In the Butantan, which a question which somebody had put forth, even they did not get a single case of dengue 3 and 4 in their 5 year of study. We at least had some cases. So this is a challenge which we are facing.
So
okay.
You'll be only there was 3 cases in dengue 4, and
but there are certain perspectives which I would say, in the interest of time, dengue infections are not occurring as a monotypic infection. Almost 47.7% of infections are there in which dengue 1, 2, 3 and 4 occur simultaneously. Okay, so there this vaccine should benefit. Secondly, the ratio of dengue 3 seropositive to seronegative and 4 is 70 to 30. So in a dengue endemic country like India, out of every 10 dengue 3 cases, we can expect vaccine to work in 7 cases. Similar for dengue 4. This is what I...
Actually dengue 3, dengue 4 was very less. So they are doing another study where dengue 3, dengue 4 subjects in large number included. I hope that will show efficacy.
Sir,
2 doses are given because 1 dose shows lesser protection, 2 doses better protection. It is effective in adults, yes.
Yeah. At present, I think we don't have any dengue 4 cases, so we need not worry about the efficacy of the dengue 4 as on today.
We don't have dengue 4 here, only in few cases in Andamans only. And also, so also is dengue 3. Safety of the Takeda vaccine is very good. My time is over. I don't want to, this is, will you please explain the forthcoming events?
There's one error. The only error is 6 to 45 years. It is 4 to 6 years in Indonesia. So every country in the world has a 4 years plus indication. So now the vaccine has been approved in more than 41 countries. 21 million doses across the world have been given. It is a WHO pre-qualified vaccines. It appears in the national immunization program of Brazil, as well as Argentina, in the state immunization program of Indonesia. So, and as I told, it's a WHO pre-qualified vaccine, and regulatory reviews are ongoing in multiple countries, including India, wherein our phase 3 studies are going on.
And I think the last important point you should mention, 21 doses have received and 20,000 of the trial, none had any death.
No.
There was no
death,
SAEs.
no serious adverse events. So I think the take-home message you have already understood. India is getting the DCGI clearance. Most likely we will have it in January.
Most probably the first quarter of next year.
And now you are coming with a new vaccine which will be really effective. And thank you for your patient hearing.
Yeah, thank you, thank you.
Huh? No, it is 60 years old.
I think good thing about the, sir, good thing about that, no, Takeda vaccine, good thing is that till now I think that we have not seen any antibody enhanced disease following the vaccination. That was the worry, in fact. Fortunately, since last 5 years, the surveillance has not shown any increased incidence of the.
Oh, thank you, Dr. Kundu and the esteemed panelists for an excellent priming us for dengue prevention. And we have a wonderful session on extended spectrum dengue. Dr. Prabhash Prashungiri will moderate that. May I request Dr. Kundu to hand over the memento to... So very, very important topic, the extended spectrum dengue by Dr. Prabhash will moderate the session, and we have Dr. Madhya Zainab, Dr. Archan Sheel and Dr. Dona Banerjee as a panelist.
A very good evening. Firstly, I want to express my sincere thanks and gratitude for the organizers for let us finish this wonderful CME with this complicated and difficult topic like extended spectrum dengue. I can remember when I was an undergraduate student, I hardly read 1.5 pages about dengue in the microbiology book, that's Anantanarayan Panikar. And I came to know that dengue is not happening in India, it's an African disease, came from a word that is called Swahili word, that means that breakbone fever, ki dengue pepo, this is the word. And when I was doing my internship or house stuff almost 18, 19 years back, then I came to know that few of the dengue cases are happening in Delhi and few of the deaths are there. And when I am the first year MD pediatric resident in ICH, I saw how dangerous it can be, and a 10-year-old boy walking and then died within a couple of hours. So these things completely changed our understanding about dengue. Possibly we have never understood what is it. There are lots of caveats in there, lots of gray areas in understanding of the dengue, and research is still going on. So dengue can cause anything. It can present in varied presentation is there, typical, atypical, rare presentation is there. So sometimes I tell my residents that dengue can cause everything except pregnancy. That was used to call at the time of tuberculosis. So let us come to the topic, that extended spectrum dengue. So what is extended spectrum dengue? It's a group of unusual organ-specific or immune-mediated complications of dengue. Each and every word is important, that are not classically described in standard dengue presentations. And these manifestations may occur during the febrile phase, during the critical phase, during recovery phase, or even weeks after acute infections. They can cause significant morbidity even when classic plasma leakage may be absent. So why does it occur? The extended spectrum manifestations are caused by mainly immune dysregulations. Cytokine storm, it may be due to direct viral invasions, endothelial dysfunctions, coagulopathy, and definitely secondary hemophagocytic activations. It's often seen in secondary dengue infections, adults more than children with coexisting comorbidities, and if there is a hyperimmune post-response. So we'll go by few cases, our journey, as we have witnessed these cases of extended spectrum dengue in our ICUs. The first case is 5-year, 1-month-old girl, has a history of high grade fever for last 4 days, vomiting for last 2 days, gradually deteriorating, altered sensorium for last 1 day, recurrent episodes of convulsions for the last 12 hours. There was no significant past history. Developmental history was normal. Dr. Dona, what should be your provisional diagnosis? This is the history.
Yeah, so we are looking at a child who has presented with acute onset fever, and there is deterioration of the higher the sensorium, and then there is convulsion. So probably we should be going for managing this child in line of acute encephalitis syndrome or AES with and immediately shift the child to a setup where there can be close
So definitely the
monitoring.
diagnosis must be an acute encephalitic syndrome that is presenting with this triad of acute onset fever, changes in the mental status, and seizure. So on examinations, the child was febrile, peripheries were warm, chest was clear, cardiology was normal, deep liver just palpable, heart rate 130, respirated 32 per minute. CNS examination revealed child was irritable, altered sensorium, GCS was 10/15, no obvious cranial nerve involvement was there, tone increased in all 4 limbs, superficial reflexes were within normal limits, deep tendon reflexes were exaggerated, plantar bilateral extensor, pupil, normal. So how do you manage this case, Dr. Madhya?
Okay, thank you. So this is a case of acute encephalitis syndrome. So at present the child is, you can see here, it's febrile, having altered sensorium and increased tones in all 4 limbs. So as we go in ICU management, A, B, C, D, E, we put the child on oxygen, give IV fluids. We start on give load with anticonvulsant, midazolam short push, followed by load with levetiracetam. We can go 60 mg per kg loading, followed by maintenance. If we find that your seizure is not getting under control, we can add another anticonvulsant. And we cover with empirical antibiotics like ceftriaxone, acyclovir. In this case, I would also like to add doxycycline because the child is having fever, vomiting, altered sensorium for more than 4 days, covering your scrub encephalitis here. And another thing very important is neuroprotection. Since the child is having encephalopathy, seizures, neuroprotection is very important. So we load with 3% NaCl, 3 to 5 ml per kg, and we target a sodium of around 140 to 145 at least here. And then we see how the child is
So
behaving.
most of the cases of acute encephalitic syndrome is actually infectious in origin. In our setup, usually start with ceftriaxone or cyclovir, as Dr. Madhya already told you, doxycycline. Anything else you want to add? This role of azithromycins or doxycycline, Dr. Madhya already told. Our when we are the students, artesunate has been added empirically. Query vancomycins. What do you think?
Yeah, we should be adding, as she has already mentioned, doxy, because nowadays we are seeing a large number of cases of scrub meningitis and scrub encephalitis, and also not to forget cerebral malaria, of course. And that's all.
So, Dr. Archan, what are the investigations you want to send?
Okay, so this is a case of acute encephalitis syndrome, acute febrile illness in tropics. So baseline investigations we will send first, CBC, metabolic profile, LFT, urea creatinine, inflammatory parameter, CSR, CRP, then the tropical infections which are considered in such settings like dengue, malaria and scrub. So serology for all these 3 should be sent.
So definitely all has been sent. The total count was on the lower side, platelet was on the lower side, lower normal. CRP is almost normal, dengue NS1 was positive and scrub typhus was negative. So we are quite surprised that the patient presenting, we are expecting some JE, some HSV, enterovirus, and dengue NS1 was a high titer positive, came out to be positive. So any further investigations, Dr. Madhya, you want to do?
Yes, so here we got dengue NS1 positive. So dengue encephalitis, here I would like to go for an MRI brain with contrast along with lumbar puncture. So you know that's CSF here we find that there are 0 cells as expected. Encephalitis, dengue encephalitis, we may not get any pleocytosis. MRI brain should give us idea regarding the etiology of this encephalitis.
So another tool that we used to send in cases of encephalitis when you do a lumbar puncture into send a CSF PCR or CSF biofare. So if you send us as a PCR, at least you should to exclude the herpes simplex because this is very sensitive. If the PCR is negative, you can jolly well omit acyclovir if your PCR is so much sensitive is there. So MRI brain has been done. You can see that MRI brain revealed two typical changes. This is the brain stem, the severely affected brain stem, and we can see that this bilateral thalamic involvement with some basal ganglia's involvement is there, and almost a symmetrical involvement is there. So what can be the causative organism? If you are just getting this MRI picture with the background of AES, what organism that should first come to your mind?
Japanese encephalitis is one of the
Definitely.
DD.
So if you see these types of MRI pictures with acute encephalitis, the first diagnosis that should come in your mind is the JAP. Then the thing is coming as the dengue NS1 is positive, it may be a dengue-induced ANE, means acute necrotizing encephalitis. So these are the differences between Japanese encephalitis and dengue-induced encephalitis. That's the lesions may be unilateral asymmetrical but have poor demarcations. The lesions are typically bilateral, symmetrical and well demarcated. Other areas involvement, basal ganglia and cerebral cortex is common, and basal ganglia cortex are typically spared in ANE, mainly typical thalamic involvement. A double donut sign is less possible in JE as distinct radiological features in DANE. And pathophysiology, direct viral invasions, usually the immune mediated. It's not properly visible actually. So this kit has recurrent convulsions loaded with AEDs followed by midazolam infusions, ultimately intubated, ventilated, went into refractory status epilepticus, needed midazolam up to 20 mics per kg per minute. Any further treatment options? Dr. Orchan. So this is a confirmed case of dengue-induced encephalitis. The MRI is suggestive, typical. This is ANE. Patient is refractory seizures, very poor, so intubated, ventilated. Any further treatment options?
Yes, so the basic pathophysiology of ANE, acute necrotizing encephalopathy, is immune mediated. It's not directly due to the virus. So this is the basic difference between JE and dengue ANE.
Exactly.
So we'll have to hit the immune pathway. And there are various options. So for countries like us, we obviously will start with steroid, which is the poor man's immunomodulator. And in that case, we can go with high-dose steroid, high-dose methylprednisolone, 30 milligram per kg per day for 3 days, followed by oral prednisolone, gradually tapering within 2 weeks. Then the option is IVIG. IVIG we can give by 1 gram per kg per day for 2 days. If the patient is refractory to these initial immunomodulators, that is IVIG and steroid, then comes the other treatments like Plex plasma exchange, plasmapheresis. And as these ANE is mainly mediated by the pro-inflammatory cytokines like interleukin 1, interleukin 6, TNF, so those blockers, specific blockers, interleukin 6 blockers, tocilizumab in refractory cases, and interleukin 1 blocker, anakinra, although it's costly, but nowadays it has started to become available. So tocilizumab, anakinra we can go for in refractory cases.
So the prognosis depends how first you have diagnosed this AME and how first you hit hard with this ANE with steroids and IVIG. Sometimes you need to delay after doing a CT, now patient is very sick, we cannot shift to the MRI. No, do the MR first. CT is not the diagnostic of imaging modality of choice. In these cases, CT cannot pick up these subtle changes of ANE. So you have to do the MRI as soon as possible and hit hard and hit fast. But the prognosis is usually not good. Okay, so dengue-induced encephalitis, in most of the cases, if it present like ANE, and there is a definite role of immunomodulators. Now coming to the case 2, the 7-year-old boy admitted with a history of gait instability for 3 days, right hemiparesis for 2 days, decreased sensorium for 1 day, and 2 episodes of GTCS in last 12 hours, and there are definitely urinary retention. History of dengue fever with compensated shock, admitted in our hospital and discharged just 2.5 days back, again came back. So Donali, so what do you think? This patient, the parents are very much anxious, they were in the ICU,
so,
they went back.
So we are getting a child who has come up after getting cured from dengue apparently, and then he has presented with a feature, a constellation of features which are pointing towards CNS.
Exactly.
Most likely because there is right hemiparesis. If we go clinically to localize the lesion, it may be in the cerebral hemisphere. Again, there is gait instability, which will point towards like some ataxia or in the involvement in the cerebellum. Again, there is urinary retention, which may be due to the involvement in the spinal cord. So what we are looking at is maybe a diffuse involvement in the CNS. So we have to go for some imaging at this point
Definitely.
of time.
So this patient admitted for pure capillary leak with dengue compensated shock, discharge, maintenance was completely normal. Now coming with some features that typically telling that some central nervous system involvement is there, and there may be some bladder bulb as the bladder has been involved, maybe some spinal involvement is maybe there. So what should be your differential diagnosis and how are you going to manage this case?
So we are going to, first of all, I would like to look for a neurological imaging, that is one MRI, and to see the clinical picture is like it's a diffuse involvement, okay? But, so an MRI would
so this
suggest.
MRI has been done, and you can see that there is a diffuse involvement in the periventricular white matter as one gray matter, deep gray matter.
That is in the gray and white matter interface, we can see the signal changes,
and
right?
there are definitely some periventricular white matter involvement is there.
And also a screening of the spine also should be done.
So further investigation, Dr. Maria?
So from the MRI we saw there are basically there are a lot of demyelinating changes, both in the white matter and gray matter involvement is there. And there is diffuse, there's involvement of the insular cortex, as sir said, gray matter. So suspecting ADAM, so in this MRI I would also like to cover the optic nerve cut sheet also. I would optic nerve sheet, optic cut, I want to see look for optic nerve. So eye opinion is very important. CSF analysis, again, to look for CSF pleocytosis. Even in ADAM, we have CSF pleocytosis, but lymphocyte predominance will be there. Protein will be mildly elevated. And along with this, one MOG antibodies also we should send, because this ADAM, MS all comes under MOGAD spectrum.
Yes.
As child is also having features of urinary retention, MRI whole spine with contrast is also indicated.
So in these cases, the routine CSF and eye checkup and MRI spine is mandatory, and if possible send a MOG antibody, because most of the cases that has been diagnosed previously as ADEM, now we are considering as MOGAD, MOG associated disease. So CSF revealed 40 cells, all mononuclear, protein, sugar and ADA was normal, CSF PCR was negative, gram stain CVNet was negative, eye checkup revealed bilateral optic neuritis, and MRI spine showing myelitis in the cervical spine. So this is a case where these things are present, encephalopathy was there, neurodeficit was there, white matter changes in the brain is there, and myelitis was there. So definitely no doubt the diagnosis is ADEM. Now, Dr. Archon, again, treatment. How to treat this patient?
So again, it is the immune-mediated complication of infection. So again, same thing, we'll start with steroid, high-dose methylprednisolone, 30 milligram per kg per day. Nowadays, they are advocating low doses also, little bit 20 in the range of 10 to 20 for 3 to 5 days, followed by oral prednisolone. Here, as compared to A&E in dengue, here the duration, we should taper oral prednisolone for more longer duration, 4 to 6 weeks. Then IVIG, steroid, if the patient responds to steroid, well and good, then we should follow it up with oral steroid and taper it down within 4 to 6 weeks. But if refractory, then we can go for IVIG. And if refractory to IVIG also, then comes the biologics. And here also, there are literatures which have described the role of rituximab, the role of cyclophosphamide even, and then the maintenance phase.
So definitely the difference between the immunotherapy of A&E and dengue-induced A&E and dengue ADEM is there. In A&E is very catastrophic features. They are very fulminant. So it's better to hit hard and hit fast, give IVIG and steroid at the same time if the patient is affording. And in this case, the ADEM first gives steroid. Most of the patients are very well responsive to steroid. And in A&E, you do not need to taper up the steroid for a prolonged period of time, but ADEM you have to taper it over 6 to 8 weeks. And most of the patients are improved on the steroid. If they are recurring, then the other options are there. If the MOGAD antibody is positive, you can go by the monthly pulse methylprednisolone, you can go by the IVIG. But most of the centers usually prefer monthly pulse methylprednisolone. If not effective, then can give MMF, cyclophosphamide or retux like this. Yes, there are few studies that are showing even a dexamethasone, dose of dexamethasone, even a lower dose of methylprednisolone, like 10 to 15 milligram are effective. So this is a extended spectrum dengue that presented with the ADEM after being discharged. Case 3, this 11-year-old boy that presented a compensated dengue shock with capillary leak. It's a day 1 afebrile. Hemodynamically stable, now on day 7 of illness, day 1 afebrile. So as we learned, the capillary leak time, danger period is 48 hours. So day 1 afebrile. But there is a progressively deteriorating LFT from day 5. And on day 7, when he's hemodynamically stable, everything is doing well, he developed a acute liver failure. And if you can see this master chart, you can see day 3 to day 12, not that much change in the hemoglobin or total count, PCB, You can see then this time period, this was a leaky phase, the platelet came down and came up. CRP is always negative. You can see the rising of serum bilirubin from 0.6 to day 3 to 12, 20/6 on day 12. In conjugated bilirubin also increasing, you can see the SGPT from 87 to 1000, 4000, 1500 again coming down. SGOT is same pattern, but INR if you see that 1.7, 2.5, 2.8, 4.7 is increasing. The epithet is showing no coagulations. Albumin is also coming down. Ferritin initially was a bit higher side. Ammonia we have not done initially, then you see the progressing rise of the ammonia. So from these things, we can see that the patient is developed complete ALF. So though there is a decrement in the liver enzymes, the bilirubin is quite increasing, ammonia is increasing, and there is no coagulation. So possibly the patient is developing fulminant acute liver failure with hepatodengalopathy. So is there any difference in the management of dengue ALF, Dr. Dona, from the other ALF? Is there any difference in the management?
So basically the treatment should be supportive. There is no difference, and we have to be more cautious because we have to understand why the ALF has actually occurring. There are many modes of injuries like direct cytopathic effect of the dengue virus or hypoperfusion, even the drugs like paracetamol, because we know the child had been having fever and so had taken paracetamol again. It might also might have some role in causing. So the child should be treated in ICU with close monitoring. The circulation, airway, breathing should be all stabilized.
So if you see that there are 4 types of mechanism how dengue ALF can develop in dengue. So first is the direct viral cytopathic effect. This typically are subacute onset. They usually start around day 5, day 6, day 7, and peaks in day 12 when the patient is out of the capillary leak phase. Then again cytokine storm. The patient is coming in the very bad stage, bleeding, refractory shock. They are coming with a very bad stage. Day 1, the liver enzymes is 10,000, 14,000. Total cytokine storm. In this period of time, you need to cut down the cytokine storm. You need to use immunomodulators that can have effect on the liver failure. Then the patient is not in cytokine storm or in cytokine storm, but severe shock, this shock liver. So in these cases, your SGT will be sky high than your SGPT, and LDH will be very high because it can cause liver necrosis. And then definitely a drug-induced injury, that the patient was presenting in the just late febrile phase with some liver failure because they are giving paracetamol every 3 hours too early. So I have seen a patient, that a 2-year-old boy, that presented with a day 4 of fever with a ALF due to paracetamol overdose because they are giving paracetamol drop instead of paracetamol syrup, the same dose. They have called the doctor, my age is 10 months, 2 years, 10 kg, how should we give? He gives 3 ml paracetamol 250. He has a paracetamol drop. He has given 3 ml every 3 to 4 hours and developed complete liver failure on day 4 or day 5. So each and every liver failure has a different mechanism, and depending upon the mechanism, you have to treat it. In this case, the role of paracetamol toxicity, you have to give NAC. In these 2 cases, you may need to give some immunomodulator. In these cases, only the supportive therapy. So what are the options, Dr. Madhya? And the options of NAC, plaques, other extracorporeal support, other promising therapy, what about this?
So this, we are dealing with a fulminant hepatic failure. As we know, it's multi-pronged pathology. One is paracetamol, and NAC is very much recommended, and it's a drug of choice in paracetamol-induced liver failure. But even when it's not indicated, even if it's not paracetamol induced, then also the role of NAC is very well established because NAC reduces your free radicals. As we know, there is a lot of oxidative stress in this immune-mediated injury. There's a lot of pro-inflammatory cytokines release. So NAC, it will help in reducing the inflammatory pro-cytokines. It will act as a oxidative stress-reducing agent. So NAC is very well indicated in all cases of even non-acetaminophen induced liver failure. Regarding plasma exchange and extracorporeal therapy, this liver failure is having very high ammonia. So high ammonia will lead to cerebral edema. So we have not commented on the CNS status. So usually with this type of liver failure, the child is already in grade 3, grade 4 encephalopathy, already intubated, ventilated. So there is definite role of extracorporeal therapy, and CRRT is one of the best extracorporeal methods, which reduces small molecules like urea and ammonia. Regarding plasma exchange has a very important role, and it is well documented and is well recommended in adults. High volume plasma exchange. What does plasma exchange do? There are a lot of immune mediated complex circulating in our body, all the toxins which the liver is not being able to detoxify, it gets accumulated. So plasma exchange, we do a high volume plasma exchange. It will remove those plasma and we are replacing it with fresh plasma. So that will help reducing our ammonia levels and the cytokines. But these are all bridging therapies. Because as we all know that liver has to recover itself. So before going for transplant or awaiting transplant, these are the bridging therapies which can help improve the patient's status.
Very, very well summarized, very well summarized. So even there is no paracetamol toxicity and you excluded that metabolic cause is there and hypoxic liver injury, an act should be given, definitely. So this patient ultimately had to be transplanted, had airlifted to Delhi and ultimately transplanted. So case 4, this 7-year-old boy admitted with a history of fever, pain abdomen, vomiting and dengue NS1 positive from outside. There was a decreased urine output, capillary leak, compensated shock, no bleeding. Managed with crystalloids and colloid boluses. Even after restoring intravascular volume, urine output did not improve. But hemodynamic stability achieved from day 3 onwards. So on day 3 of admissions, usually, as I told repeatedly from morning, that capillary leak only 48 hours, capillary leak only 48 hours. For day 3 onwards, to stop capillary leak, there was no hemodynamic instability, but urine output was not improving. Again, Dr. Madhya, so what urine output we target in the critical phase in dengue?
In critical phase, only urine output is not the target. As we saw the case that hemodynamically the child has improved, his perfusion has improved, his peripheral pulses has improved, BP is better. So here we can target a urine output of more than 0.5 ml per kg per hour. Here we do not have to target a very high urine output. The moment we start targeting the urine output to be more than 1 ml per kg per hour, obviously we will be giving more fluids and that will cause
exactly.
more
That is the importance of treating dengue and from other septic shock or fluid deficit patients in the ICU, where you target usually around 1, 1.5, but in dengue usually 0.5. Even if the obese kids are there, you can even target 0.3 or 0.4. Remember one thing, if your patients in dengue in during the hospital stay is passing more than 3 ml per kg per hour of urine, that means you are giving overfluid. And if something happens to this patient due to some unrelated cause, it goes to the court, the commission and everyone will target to these things, because I have faced few of the cases. I know that, oh, urine output was 3 ml per kg per hour, so you are giving more urine, so you are giving more fluids, so you are giving more fluid that the patient expired. So don't, if you are in a stable patients, more than 3 ml per kg per hour, cut down the fluids, otherwise you will be blamed that you have given more fluids. So this patient present to us, as I told that from day 3 the hemodynamic stability was there. Dunadi, what or you can see in this table? The patient is hemodynamically stable from day 3, but reports are unstable.
What we are seeing is hemoglobin is falling down along with that PCV, and platelet is showing a dramatic fall. From 90,000 on day 1, it has become around 6,000 on day 5.
So whenever we see that in a dengue patient, platelet is falling, hemoglobin is falling, there may be some internal bleeding. So patient must be hemodynamically unstable, but this patient is hemodynamically stable.
But another thing, yes, we are concerned is like we can see the urea and create. It is like it was normal, and from 0.5 to on day 1 to it has become 4.8. So definitely some renal issues have cropped up.
Yes. So from day 3 onwards, you can see that hemodynamic stability has achieved, but thrombocytopenia has not coming down. Your urea is increasing, your creatinine is increasing. So we sent few of the other investigations. So you see that LDH is 6,890, ferritin is 8,900, and triglyceride is high, INR is borderline, lipid is normal, fibrinogen is normal. Archon. So
Yes.
ferritin is 8,900.
Yes.
You must be very happy.
Yes. So ferritin is a non-specific kind of thing, but here in this case, ferritin is expected to be elevated, acute phase reactant, so it's expected to be elevated, but it's not going in the direction
That
of
direction.
That direction, HLE's direction. It is going in the direction of. Can I see that? Yes. So this is the peripheral smear. So there are cystocytes. So hemolysis, LDH is elevated, uremia is there. So this is nothing but dengue-induced hemolytic uremic syndrome. So microangiopathic hemolytic anemia.
This is only one case of dengue-induced HUS that I have seen in my entire critical care career, this patient. So we were not able to understand that what's happening. Everything is coming down. So this is basically this anemia, thrombocytopenia, cystocytes, uremia. So dengue-induced HUS is there. So it's very rare, definitely very rare. So any further investigations, Dr. Archon, about these things?
So regarding the management and stratifying the treatment options in cases of dengue-induced HUS, there are few more information required. One information is complement system activation. If complement system is activated in dengue-induced HUS, the treatment options will be a little bit different. So we'll look for C3, C4. And if C3 is reduced, it is taken as the complement activity in dengue-induced HUS. And the other thing is ADAM-TS 13, that is, if it is severely reduced, that is less than 10%, then it will go towards the TTP. And again, the treatment options will be different.
Exactly.
So,
exactly. So in all dengue in this HUS, in all cases, complement is not activated. So if the complement is normal, then wait and watch. If need, you give RRT, the patient usually recovered. But most of the cases of dengue HUS, though very rare, usually complement system is activated. The C3 is low, C4 is normal. That means you have to do something else. And definitely ADAM-TS 13 is definitely. So how to manage this case? Indication of RRT, Dr. Madhya. In this patient, if you see this chart,
Yeah.
urine output is very less.
Yes, this urine output is less, so there is progressive rise in urea creatinine. So one of the indications of RRT is oliguria and anuria. Along with this, some other parameters also we have to see, like hyperkalemia, persistent hyperkalemia is there or not.
Fluid overload status.
Fluid overload, because here we are going to give blood. Your hemoglobin is dropping, so that fluid overload is also one of the indication. And it's refractory metabolic acidosis.
Because one thing about platelets that we recently started doing is that immature platelet fractions. That's very much important. So sometimes some dengue patients, the platelet is just standby. 40,000, 40,000, 40,000, 45,000 every day, another day we are doing. It's not improving. Parents are tense, doctors are tense. Just go by immature platelet fractions. If your immature platelet fraction is increasing and is beyond 10 or 15, that means your platelet will ultimately increase. It is basically a surrogate marker like reticulocyte count. So in these cases, immature platelet fraction will help you to discharge this patient even on platelet count of 60,000, 70,000. So Dr. Archon, do you want to do PLEX in this patient or roll up any other immunotherapy?
yes, so the indications of PLEX will evolve around 3 to 4 points. One is the severity of HUS, severity of anemia, severity of thrombocytopenia, multi-organ involvement, and there is markers of inflammation. If there is associated MAS, macrophage activation syndrome, or too much elevated ferritin. So in this case, there is severe anemia, severe thrombocytopenia. If there are indications of multi-organ involvement and elevated inflammatory parameters, including ferritin, so I'll go for PLEX.
Definitely.
So another CNS involvement, like if this child starts
CNS
having
involvement,
CNS,
then TTP should be
sensorium
think about, and
starts,
ADAM-TS 13 should be
depicted
taken.
also.
And there's another promising role of eculizumab. It's very expensive immunotherapy. That's promising role in HUS.
So eculizumab is actually monoclonal antibody against C5.
C5.
So it will block the membrane attack complex formation. But eculizumab is very costly. So it's a more kind of theoretical option.
So we go with fast. So case 5, this 11-year-old boy, dengue NS1 positive, admitted on day 4, warning signs are positive, developed capillary leak on day 5, shifted to PICU. On arrival to PICU, ERS was maintained, mildly tachypneic, saturation of 95% in room air, cold extremities, feeble peripheral pulses. BP was 82/56, heart rate is bit tachycardic, GCS normal. Dr. Dona, how to manage? Very rapid.
Oh, so this child is landed in shock, and so we give bolus. Initially, we start with 20 ml per kg over 15 to 30 minutes. Then we monitor the vital status and the
so all the management will taper around the fluid management. So after hemodynamic stability has been achieved on 6 hours after one bolus and maintenance fluid, heart rate came down to 112 per minute, blood pressure is normal, peripheral pulses better, extremity is not so cold, passing more than 1 ml per kg per urine, and hematocrit definitely decreased to 34 from 42. So after 6 hours, so we are very much happy the patient is improving. And there was no bleeding, sensorium was normal. But condition deteriorated over next 8 hours. That's the dynamicity of ICU. That there was a persistent tachycardia for the last 4 hours, over the last 8 hours, 4 hours tachycardia. Again started having febrile pulse, low BP. Again the PCB and hemoglobin was depleted. It's same almost. It's not that PCB is coming down or hemoglobin is coming down. Respiratory distress is there. Hepatomegaly is there. Capitation in the chest, desaturating, child is intubated, ventilated, invasive BP monitoring has been done, central venous line done, started on inotrope. So suddenly the patient went into respiratory distress, severe shock. We are not able to identify what's happening, we just go by supportive therapy. We intubated this patient, ventilated, we started on inotrope. What happened, Dr. Madhya? This patient with a compensated shock, we have given a fluid therapy, patient improved, everything going well. Then again the next 8 hours patient suddenly deteriorated.
So this child is still in the critical phase. So after giving fluid therapy, my PCV and all came down. Again, the child developed tachycardia, having very feeble pulse, low BP, along with respiratory distress and hepatomegaly. This points towards cardiac. Cardiac dysfunction is there. So most likely this child is going dengue myocarditis per se. Another possibility here is we always think is fluid overload or pulmonary edema, something like that is happening around. But there are features here which is not suggesting that. One is, the most important thing is my pulse. That pulse pressure is very low, feeble pulse, very poor hemodynamics here. That the child is needing to be ventilated and has to be
So
started on
definitely,
inotropes.
after intubation, we saw that almost bilateral whiteout lung and ultrasound revealed the loss of pulmonary edema was there. So we are confused that whether we have overloaded the fluid, the patient with the fluid, or there is something else like dengue-induced myocarditis is there. Definitely calculate the fluid that we have not overloaded. So this is the dilemma, that whether there is fluid overload and pulmonary edema or a dengue myocarditis, and how to differentiate between them. Sometimes it's very difficult to differentiate in the bedside, but there are lots of things are there. And in fluid overload, the tachycardia appropriate for the distress. In dengue myocarditis, disappropriate tachycardia. In blood pressures, usually in fluid overload, the BP is normal or rising, and myocarditis is hypotension. Chest finding is almost same, but in myocarditis we can get at the gallop. In chest X-ray, diffuse bilateral alveolar infiltrates the cardiomegaly usually absent. In myocarditis, cardiomegaly may be present. So echocardiogram is the most important in fluid overload state, usually a normal LV function or just a borderline decreased LV functions. IVC is very much big and plethoric, and myocarditis is the global hypokinesia and dilated lungs are there, heart is there. And myocarditis is definitely we got a elevated marcus. A response to treatment is that you suspect this fluid overload is there. You give the rapid fluid clearance like furosemide, and myocarditis a little improvement of the diuretics, it may be harmful, and you have to give some inotropic agent. So we know that myocarditis present our blanket therapy, you give IVIG. Any myocarditis, it's a MISC-induced myocarditis, non-MISC myocarditis. So what should be done in case of dengue myocarditis? Should you use immunotherapy? No, very
Yes.
rare.
So in some percentage of cases, so echo and MRI may help in order to detect the myocardial edema. But otherwise, if it's not responding to the initial line of management, definitely as dengue myocarditis can also be immune-mediated myocarditis, so you can use IVIG steroids. And if refractory to IVIG steroids, even we can use the plasmapheresis and some biologics like tocilizumab and anakinra.
So dengue myocarditis is usually not due to the direct viral invasions, unlike of dengue ALF, that is sometimes due to direct viral invasions. So this is usually immune-mediated, and definitely there is a role of IVIG and steroid is there. So last case, combined together, case 6, case 7, case 8. Case 6, 8-year-old boy, history of fever for 5 days, dengue NS1 was positive, FAL for 8 hours, multiple episodes of vomiting, presented with shock in A&E, fluid research done as per protocol, very bad shape, altered sensorium, refractory shock, bleeding, intubated in next couple of hours with irreversible shock, hypotension, tachypnea, profuse bleeding. First investigations on hospital arrival, PCV is 48, platelets 21K, SGOT, SGBT on thousands, INR 12.9, ferritin 44,000, fibrinogen 1110, LDH 1200. Case 7, this 8-year-old boy, history of fever, dengue NS1 positive, present with the pain, abdomen, vomiting, lethargy, features of capillary leak, not that sick, but definitely sick, compensated shock, improved hemodynamics over next 6 hours with IVF, mildly tachypnic, 1 liter O2 in nasal cannula, still in ICU, urine output is just borderline, IVF NS is 8 ml per kg per hour, GCS a bit irritable, GCS 14/15, initial PCV was 44, after 6 hours is 38, platelet 61, after 6 hours 44K, TLC is almost same, the SGBT SGBT in hundreds, 6,000, 600, 400, INR elevated, ferritin 14,000, fibrinogen 210, LDH 780. These reports come after 5 to 6 hours. Similar boy, 8-year-old boy, hemodynamically stable, day 9 of fever, dengue NS1 was positive, persistent febrile even on day 9, mild features of capillary leak, bit pleural effusion, bit of ascites, stable hemodynamics on maintenance fluid, eating a bit. There is a nuance of splenomegaly, liver enlargement, enlarged than previous, urine output is good, disease is normal. This is a lab flow sheet, you can see the total count is coming down from 4,600 to 1,900, day 9, still febrile in day 9. Hemoglobin from 11 to 8.3, PCV is 33 to 25, platelet is 1110K to 44K, ferritin was 2,300 to 10,000, fibrinogen from 287 to 116, patient is otherwise hemodynamically stable. So I want to take an unbiased opinion for our panelist, Tonadi. So do you think that all these 3 patients are in cytokine storm and all, or HLH, whatever may be the name, what's in the name, or you want to use immunotherapy in all these 3 patients?
The first one and the third one is definitely, the first one and the second one definitely looks like they are in cytokine storm, obviously. For the third one, yeah, all the 3 are in
Dr. Madhya, what do you
Yeah,
think?
new
All
onset
these three patients?
splenomegaly, yes.
Cytokine storm, but regarding treatment, first I would like to treat multi-organ dysfunction is there with high ferritin. Regarding the second case, I would like to observe and see the trend as the child is a bit better. We have been able to reach out of the compensated shock has improved. The platelet, the total count is holding. Platelet is just dropped, and I would like to see the trend instead of treating upfront. And in the third case, the child is going into HLH, but here I would also like to rule out some co-infections because this new onset splenomegaly fever is still persisting. So any other tropical infections I would like to exclude before going.
Dr. Archon, your take?
So all three patients are in cytokine storm, but difference in is the clinical spectrum that they are presented with. First patient is in shock, so definitely I'll go for immunotherapy managing the cytokine storm. The second patient is in compensated shock, so immunomodulatory therapy, but little steroids can do. And the third case is clinically stable, so I will wait and watch.
So what happened in these cases? That this patient presented with a severe cytokine storm, severe shock, very bad. We have given everything, whatever available in our hands. Patient collapsed within 8 hours of hospital admission. This patient has lots of doubts whether to give steroids or not to give steroid. I did not give steroid. We wait and watch the patient. This patient gradually improved over time. This patient, there was a very much pressure from the outside that you have to give steroid, you have to give steroid. We are about to give steroid, but day 9, we got a report, blood culture, that enteric fever, Salmonella typhi is positive. Patient was not on any antibiotics. So I've given ceftriaxone over here, and your everything is started coming down. So all these three patients are basically in cytokine storm. As this patient has developed hemodynamic stability, you can wait and watch or give a bit small dose of 1 or 2 dose steroid depending upon the situation. These patients, no doubt, you have to give all out. And these patients, after 7 or 8 or 9 days, you have to exclude the hospital-acquired sepsis. You have to exclude the co-infections like scrap typhus, dengue, hepatitis in these cases before giving steroid. And this patient, there should not be any doubt. So cytokine storm in sepsis, severe sepsis, infection, immune dysregulations, antibiotic have been the main cornerstone of management. However, despite optimal supportive therapy, mortality has not come down significantly. So in dengue, what is cytokine storm? When to give immunomodulator? Lots of therapies. We don't know actually that whether to use the immunomodulation in prevent the critical phase or to use these immunomodulators when to halt the progression of the critical phase, or you give in the established organ dysfunction like case 1, first case. So in case of cytokine storm, sepsis associated, dengue associated, 4 things must be there. There must be a DIC, there must be hepatobiliary dysfunctions, must be high LDH and hyperferritinemia. Per se, in dengue, most of the severe dengue are presenting with DIC. The INR must be elevated, 1.5, 1.6. And low platelet count is a part and parcel of dengue. Dengue hepatitis may present with hepatobiliary dysfunctions. LDH, if there is a hypoxic liver, the LDH may be high. And ferritin is definitely a inflammatory markers. So in all these cases, you should not get a knee-jerk reactions to stem all these cases. So sometimes we had a very knee-jerk reactions. Ferritin is 501, ferritin is 1200, oh, this is things. So sometimes we give very much importance on this single value that is called ferritin. Yes. Dr. Archon, what is your take on this?
So ferritin is an inflammatory marker. It is an acute phase reactant produced from liver in response to inflammatory cytokines. So, and it is an iron storing protein as well. So ferritin in HLH, in the setting of HLH, macrophage gets stimulated to produce a lot of ferritin. And there is hepcidin activation also. So ferritin we should target. The higher the value, if ferritin is more than 2000, then the sensitivity and specificity of the relation with HLH goes high. If ferritin is more than 10,000, then the chances of mortality goes high as well as the prognosis becomes worse. So not above 500 is nothing. Ferritin above 10,000 you should treat. And the main thing is that here in dengue, anakinra is coming up in big way in the literature as management of dengue-induced HLH. In addition to steroid, anakinra should be given from the very initial phase. And other immunomodulators are there also in the literature.
So lots of work has been done, and controversies are still there according to this HLH, cytokine storm, hyperparatonymic sepsis, morph phenotypes, lots of work has been done, evolving thing is there. Still, after doing lots of work, still we are not quite sure in these cases whom to give, blanket coverage or selected patient. When to give, before the critical phase, on established organ functions. What to give? We need to give steroids, which dose? How to give the steroids? Anakinda, like on other cases we give anakinda subcut. In these cases you have to give anakinda IV. In other cases anakinda OD dose. In these cases 6 hourly to 8 hourly. And how long to give? Previously steroids to 8 weeks. So these questions are still not unanswered. But each and every cases are different. Do not blindly follow HLH 2004 criteria. Do not blindly follow the H score. Possibly we will doing the over-diagnosis of HLH in ICUs, and ultimately if we ending up giving lots of steroid, and ICU bugs will be very much happy. We have a very good ICU bugs are there. Whenever you open a bottle of steroid, they are very much delighted. Okay, he's getting steroid now, this is my time. So before giving it, think that this patient is in the ICU, lots of chances of developing the ICU-induced sepsis. I'm not going into details further. Thank you.
Thank you so much. Thank you, Prabhas. Thank you all the panelists. It was fantastic discussion to cap it all. May I request Dr. Surendranath to please come and hand over some memento to our very young brigade of excellent faculty.
Just one thing, I was just arguing with Dr. Chandra the same thing. She was telling they are getting lots of cases of HLH. Is it all HLH or is it some cytokine storm which they are over-diagnosed?
Whatever may be the name, most of the patients do not need steroid.
May I request Dr. Kundu, Dr. Shumon, Dr. Kher also to please come up. Dr. Surendranath to Dr. Prabhas, please. First. It's okay. So thank you again to Dr. Archan. And thanks for being with us. This is for Dr. Dona Banerjee. And this is for Dr. Madhya. Thank you so much. Thank you for staying with us throughout the day. I think it was a very nice scientific deliberation. We also enjoyed a lot. We believe in science. We don't believe in frills. So there was no inauguration, no felicitation, no introduction. It was science only. And thanks for being with us. And we promise that next year also we will come up with many more scientific programs, some focused program, and our summer CME, everything. And thanks again. So season's greetings to all of you. See you once again.